by Dr. Vernon Velho. I would like to invite Dr. Abida Shah and Dr. Sukdeep Jawar for their talk on anatomy of cerebellopontine angle.
Good morning, delegates and esteemed faculty. This is a 3D presentation, so I request everyone to take the 3D glasses. And can somebody switch off the lights? Thank you. So we are starting with 3D anatomy of cerebellopontine angle and posterior fossa. And of course, posterior fossa is not, can you make it 3D? So CP angle is part of the posterior fossa. Yesterday we had our journey around the skull base, anterior skull base, then we had middle fossa approaches, pioneer region, circle of Willis. So now today we will be discussing part of the posterior fossa, CP angle, then going on to the cerebral anatomy, fiber dissection, and finally cavernous sinus. So as you can understand, this 3D setup takes a little bit time. And I would like to thank Professor Ghosh and Professor Pandya for giving us this. And let me tell you, it is not easy. It requires a lot of effort to get these screens, projectors, glasses, and make this 3D presentation. I think it. Beautiful. So can everybody appreciate the 3D, this thing? Yeah, so now we are starting. This is base of the skull. So here we have all the cranial nerves emerging from the brainstem and going towards various foramens of the skull base. Coming to, this is the view from the posterior side. Here you can see the cerebellum and the posterior fossa and vertebral arteries, C1, C2, C2 ganglion in all its glory. Coming to, now what is CP angle? So a CP angle is an anatomical term. It's not like a restricted area for our lesions or other tumors. They can expand from one area to another. But for anatomical or surgical clarity and communication, it has been called CP angle, which is the cistern between. So it's clear from the name, cerebellopontine. So between the cerebellum and the pons. But if you, as we know for this the posterior fossa, we have a very useful rule of 3. So there are 3 arteries, three brainstem parts, 3 peduncles, 3 fissures, 3 cerebellar surfaces, and 3 group of nerves. So if you remember this rule of 3, it becomes very easy to understand the anatomy and all the relations of posterior fossa. So on top we have superior cerebellar artery, then we have ICA, then we have the pica. So this superior group, middle group, and the inferior group. So SCA is related to midbrain and the cranial nerves 3rd, 4th, and 5th. And the ICA is related to 7th, 8th cranial nerve and the pons. And the lower cranial nerves are related to pica and the regions of the medulla. So, and the peduncles, you you can understand that similarly these peduncles are related to these 3 areas. So just remember 3 areas, 3 fissures, superior cerebellar artery. It is related to cerebellomesencephalic. ICA is the main artery of cerebellopontine fissure, and the pica is with the cerebellomedullary fissure. So this is, again, bony anatomy, which we saw yesterday. And this is the area of the posterior fossa here, starting from the, this is a petrosal surface, cerebellar surface of the, or you can say petrosal surface of the temporal bone. Then the large part is formed by the occipital fossa here. So this is once you disengage these bones, how this bones are articulated. This is the clival part, and we have the jugular foramen here and the foramen lacerum here. And you cannot see the hypoglossal canal, but it is hidden behind here. So this is again, we yesterday also see the middle fossa anatomy while middle fossa approaches. This is the petrous ridge here. And this is the bony anatomy from outside. And most of the approaches, retro-sigmoid or retromastoid, which are behind the mastoid here, are related to this area. And depending upon the resection of condyle and resection of the C1 arch, and we can have a far lateral or extended approaches. So idea is the approach is to be decided by the lesion and the extension of your pathology. And they are not rigid approaches that we have to do this only, but you can modify according to the lesion which you are dealing with. So this is the anatomy of foramen magnum, which we saw yesterday. This is the carotid canal here, and the jugular foramen here. And this is the condylar fossa. It's a large condylar foramen. Sometimes it transmits a emissary vein here, and can be a source of bleeding while approaching from posterior side. So this is the close-up view of the brainstem. We can see third nerve, second nerve, fifth nerve here, and sixth, seventh, eighth nerve complex. Then just below it, we started this 9th, 10th, and 11th cranial nerves. And the pre-olivary sulcus, we have the rootlets of the 12th nerve. So this is the close-up of the CP angle. So you can see the fifth nerve, it arises quite laterally, and it's almost in the mid-pons. And it is the boundary between middle cerebral peduncle and the pons here. So their origin, if this is the close-up of the CP angle, the origin of this lower cranials here, glossopharyngeal, and the 7th, 8th nerve, it's quite close. They are very close to the origin. And they are related to this choroid plexus here and the flocculus. So these are all useful landmarks when you're dealing with CP angle. Where is the origin of the nerve and the root entry zone, all these things. And 6th nerve is quite medial. So the all motor rootlets are in this line. These are mostly the sensory rootlets here. So here, briefly I'll show you the steps of the retro-sigmoid one. This is the workhorse for the posterior fossa. Incision can be variable depending upon surgeon's comfort. And of course, then you expose this osteon, make this is the junction of the transverse and sigmoid junction. So you have a burr hole here, make a small craniotomy. This is the occipital artery, which can be seen. Once you open the dura, you will see the cerebellum. Now the question is, once you cerebellum, next step is our tendency is to go to the CP angle or see the tumor here. But rather than that, just lift this cerebellum little bit like this, and you will see the base, cisterna magna. So cisterna magna is not only in the center, it's go all around, it has quite a lateral extension also. So just release the CSF and wait for some time, and you will have a beautiful view of the CP angle. This is out of focus. You can see the vein here. Sometimes this vein, try to avoid and sacrificing any veins before you are sure whether it is not possible to save it. So this is the view that once your cerebellum is relaxed, then only you start retracting the cerebellum. So yesterday also somebody gave this message. So don't try to rush and like the sir was saying, slow is fast. Just wait the CSF to come out. So this is the view here. This is the lower cranial here. This is the internal acoustic with the facial and the vestibular nerves. And this is the fifth nerve with the motor and sensory roots. So in the background, you can see even the very thin nerve, which is fourth nerve here. This is the third nerve here. So the fifth. So these are the 7th, 8th nerve complex. These are your lower cranials. So sometime initially when the tumor is there, this lower cranial, they can be confused with the your facial nerve. So just wait and let the anatomy clear itself. So this is a view from the far lateral side. If you see this anatomy, you can see this is the lower cranial jugular foramen coming out. This is the 12th nerve coming out, and this is the vertebral artery with the first cervical nerve related to it as it enters the intradural part. So this is another dissection for the suboccipital triangle. So this is the journal, the suboccipital craniotomy. You have a wide exposure. You see the tonsils. This is a view from the top. You can see here the fifth nerve going into the Meckel's cave and the internal acoustic matters and the 7th, 8th nerve complex here. So this is the front-on view of the CP angle, and this is from the behind. You can see all the cranial nerves, how they are related. So here, and again, you have to see where this is the accessory part of the spinal part of the accessory nerve. So once you remove, then you see the vascular, how these vessels are, the three group of vessels. You can see the top SCA here. Then we have the branches of the ICA and the pica here. And these are the three components. So this is the close-up view of the CP angle. So when you're coming from lateral, first structure you may encounter is this, the flocculus. So that gives you an idea that you are close to the root entry zones. And you cannot see the zone most of the time, and you cannot see foramen luschka, but you can see this choroid plexus coming out, and that is a very useful landmark. Then you know you are close to the 7th, 8th nerve complex. So this is again, here you can see how this artery is pressing the nerves. So this is the PCA and the superior cerebellar here. So these are the top group of as I told you, three groups. This is the topmost group. So this we have covered yesterday. So middle group is the ICA, structure is the pons, cranial nerves is 7th, 8th nerve complex, and we have a cerebellopontine fissure related to middle peduncle and the surface of the petrosal bone. So again, coming to this, you can see all the cranial nerves we have already seen. So this is the view of the CP angle from behind. You can see this ICA is closely related to this nerve complex. But of course, when the tumors or vestibular schwannoma is there, these relation can change, and you know the tumor can give you space. So as you see now, again, this is a useful landmark. As I told you, this is a choroid plexus, and this is the foramen luschka here. And very close origin of these two nerves, and how these arteries, you can even see the subarcuate arteries. So lower group, in short, just have a look. They can be approached from behind, tilo-velo-tonsillar approach we saw yesterday. Pica is there. And once you release the CSF, you can have view of this jugular fossa. This is all lower cranials here, 7th, 8th. And this is a side-on view of the pons, how this fiber dissection can be done to see this various tracts and nerves going inside. This is the view from endoscopic point of view. So just to give an orientation, this is all cranial nerves with the, you can here see the ICA loop and the subarcuate arteries and all branches going to the internal acoustic meatus. We can see the beautifully the median nerve going here to the pterygopalatine ganglion. So this is the close relation. You can see how these nerves are going. This is 5th nerve, 7th, 8th. These are the lower cranial. So this is the dentate ligament here. From the, this is C1 coming. This is a vertebral artery entering very close to the dentate ligament. Shiny white structure. So these are again the nerves of the internal acoustic meatus, all the 4 cranial nerves you can see, and you have to remember how they are related to each other. So now we are seeing from the front, so top is the facial nerve, then superior vestibular, inferior vestibular, and this is cochlear nerve. So this relation is very critical when even in the pathologies, most of these nerves will maintain this relation. You can see some part of the cochlea here, how the jugular foramen is, this is the jugular bulb here, and this is the cochlea here. So sometimes high riding jugular bulb can give you problem and can be a source of bleeding. So thank you.
Thank you, Dr. Jawar, for your talk. Next, I would like to invite Dr. James Jones for his talk on CP angle syndrome.
Morning, very good morning, everybody. The CP angle syndrome, you know that from the first month of my clinical posting in MBBS, we were accustomed to the CP angle, the name CP angle syndrome is familiar to us because our seniors and our teachers frightened us with this syndrome, saying that this is the toughest case which you are going to get in your final year examination, and you are never going to diagnose it. The tip is, if a person is walking with a staggering gait or a drunken gait, you just say that it is a CP angle tumor, CP angle syndrome. At that time, till final year or after, even after the final year, I didn't understand where is this CP angle, how the things are happening there, but I know that there was a syndrome called CP angle syndrome. So you know that it's a Harvey Cushing in 1917 who coined the CP angle syndrome. But you should not forget the contribution of Dandy to CP angle syndrome. He is the first person who resected out the CP angle acoustic neuroma in total. He is the first person. And he is the person who has introduced the staged surgery for CP angle tumor, preserving the 7th cranial nerve, as well as he is the person who started doing it from the lateral side. Now, with the I came to know about, I understood the CP angle, what is CP angle, only after the introduction of the MRI and the boundaries. You know that the lateral boundary is already discussed, is by the petrous bone. The medial boundary is the pons, and the posterior boundary is the cerebellum, and the 5th nerve at a lower level forms the anterior boundary, where the cistern is continuous with the preponderant cistern, and you can see the 8th nerve traversing the CP angle. Now, the cranial nerves 5, 7th and 8th are closely related or related to the CP angle, traverse the CP angle. So naturally, the CP angle syndrome constituted by the involvement of the structure which are nearby. The first symptom is, or the first structure which is affected is sensory neural deafness, because the commonest pathology is a vestibular schwannoma, and you know that this deafness and other things go unnoticed by the patient, because it is a very slowly growing one, and as it is unilateral, patient won't feel that they have got a deafness. The second problem is facial numbness. That also will be usually transient in the initial stage, and patient may feel that it is insignificant. The third one is facial palsy. Facial palsy, you know that in a CP angle syndrome, it's taught in our postgraduate and undergraduate stage. It's an unusual feature. If a facial palsy is the initial presentation, doubt about the, you should say something other than CP angle, because CP angle lesions never start as a facial palsy as a first symptom. Of course, when you see that there is compression of the cerebellum, which is the posterior structure, you will have cerebellar compression producing cerebellar syndromes. The cerebellar syndrome is usually unilateral, and limb ataxia and staggering gait are the main manifestations. Then brainstem compression. The brainstem compression is the subsequent stage when you will see that patient is having problems with pyramidal tract, and you will have pyramidal signs, and finally ventricular compression. This ventricular compression will produce raised ICT and hydrocephalus. Now, there are certain unusual features for the CP angle lesion. That is, sometimes it can the nearby 6th nerve. So 6th nerve palsy may be associated with the CP angle tumor. It could either be a manifestation of the raised ICT, or it can be direct extension, and sometimes you may see the closely related 9th and 10th cranial nerves are affected, producing dysphagia and other things. They are unusual. Like that, trigeminal neuralgia. Trigeminal neuralgia is an unusual manifestation for a CP angle tumor, same like hemifacial spasm. Even though the incidence of facial palsy is rare in sepia angle lesions, rather rare. Hemifacial spasm is not rare. Nowadays, we used to take a MRI for any hemifacial spasm, not only to see the neurovascular compression, but we are afraid whether there is a CP angle mass which is coming. Now, another unusual manifestation is chemical meningitis. Know that as physicians we encounter recurrent meningitis. CP angle epidermoid cysts are notorious to produce recurrent meningitis. Unless you carefully, the epidermoid cyst may not be large. It may be just a small one, and you will see that the meningitis is coming in and again, and we carefully look for the CP angle for any cyst there, because it produces chemical meningitis. Sometimes the CP angle tumor like vestibular schwannoma is very slow growing, so that hydrocephalus may develop without raising, without any evidence of a raised ICT. So these patients may come with just hydrocephalus, and the signs may be frontal lobe dysfunction. Several times we have discussed frontal lobe signs. Because of the hydrocephalus, when we take the MRI, you will see that is a huge hydrocephalus and a CP angle mass coming there. So if you see incidentally a hydrocephalus and other manifestations of hydrocephalus with raised ICT, have a careful look at the CP angle, because it may be due to a CP angle tumor. Now, certain clinical signs are never seen in CP angle lesion, even though they are in the brainstem. One is gaze palsy. Second is internuclear ophthalmoplegia, then 1.5 syndrome, Horner's syndrome, and bilateral long tract sign without raised ICT. If you are seeing some of these signs with vestibular nerve or fifth nerve palsies and other things, go for an intrinsic brainstem lesion rather than an extrinsic brainstem lesion. In CP angle tumor, you may see long tract signs. Bilateral long tract signs will be seen, but invariably there will be associated raised ICT. If there is no raised ICT but long tract signs are there, it's never a manifestation of CP angle lesion. Now, regarding the etiology, you know that 80% of vestibular schwannoma, it enlarges the internal acoustic meatus. It starts from the internal acoustic meatus and come out to the CP angle like a ice cream cone. The second one is meningioma. It constitutes about 10% of the cases where you can see the dural tail sign, and epidermoid cyst and arachnoid cysts are the third commonest lesions in the CP angle. That's why the chemical meningitis is common with the CP angle lesions, especially epidermoid cyst. Sometimes ependymoma and choroid plexus papilloma can come to the CP angle. This is because of the unique relation of the CP angle with the foramen of Luschka, where there is ependyma is continuous with the space, and an ependymoma or sometimes a choroid plexus papilloma can grow exophytically into the CP angle, producing CP angle syndromes. Now, unusual lesions are CP like non-acoustic schwannoma, aneurysms, melanoma, embryological remnants like dermoid cyst, lipoma, petrous bone and skull base, cholecystioma, chordoma, exophytic brainstem tumors like glioma, choroid plexus tumor can also come in the CP angle. Non-surgical causes, patient will have typical, these are the cases which we are involved in CP angle, because patient will have typical symptoms of CP angle, all the signs of CP angle, but in MRI the findings are unremarkable. The usual conditions are apex petrositis, hypertrophic Faki meningitis. Unless you take an MRI with contrast, you will never see this meningeal enhancement. As a practice, you know that in most of the cases, the MRI may be there without a contrast. And arachnoiditis. Arachnoiditis usually develops as a part of a residual meningitis. A localized meningitis usually due to tuberculosis, or sometimes cystic occurs in that area. They may produce arachnoiditis, and it may not be very much evident in MRI, and IgG-related inflammation. You know that a lot of inflammation comes from different part of the brain, and CP angle is a site where you will see IgA-related inflammation, and the MRI is unremarkable. So suspect these conditions when you see that the MRI is not very remarkable and CP angle syndrome is there. And I will conclude this talk with a curious clinical findings. Burns nystagmus, which we all taught to the PGs, are demonstrated to them. The Burns nystagmus is a nystagmus when a patient is looking to one side, that is the side of lesion, you will see a coarse nystagmus. Coarse nystagmus. This is a cerebellar nystagmus and is a gaze-evoked nystagmus because the ipsilateral cerebellum is compressed by the CP angle tumor, with the result that an ipsilateral gaze-evoked coarse nystagmus, which is a characteristic of cerebellar nystagmus, happens. But when you ask the patient to look to the opposite side, patient will have a fine nystagmus. This is because ipsilateral 8th cranial nerve involvement, ipsilateral 8th cranial nerve, that is vestibular nerve, produce a contralateral nystagmus, and the vestibular nystagmus, as you know, they are fine nystagmus. So a combination of coarse nystagmus to one side and a fine nystagmus to the opposite side indicate that there is a CP angle lesion to the side where there is a coarse nystagmus. This is what is called Burns nystagmus. If you see these nystagmus in a CP angle lesion, in most of the cases, this nystagmus can be demonstrated. Thank you.
Thank you, Dr. Jose, for your talk. Now, I would like to invite Dr. B.K. Misra for his talk on microsurgical excision of vestibular schwannoma, impact on facial nerve and hearing preservation.
I'm not sure whether I'm talking for both Sanjay and me, but anyway, thank you, Siddharth, thank you, Dr. Pandey. It's been an honor and privilege to be here. I enjoyed and learned a lot of things, beautiful presentations, and a very nice location. Thank you. So before I start, invite you all to join us next year in Mumbai, the 9th mass scene and the International Conference of Cerebral Vascular Surgery. Please block your dates. For this presentation, I'll focus on hearing and facial function and my personal recommendations. All my patients of vestibular schwannoma surgery is done through the one approach, and this is retro-sig. I don't do these two approaches for vestibular schwannoma, though I do it for other things, because I think all tumors, whether it is intracanalicular or giant 7-centimeter tumors, can be removed by this single approach, and it's better to specialize in one approach rather than being a jack of all trades. Hearing preservation is possible in this approach, and there's a very small bone anchoring at the intra-aortic canal and meatus, so you don't need to take out all this bone and waste your time on that, waste your time on the tumor dissection. I have a long-standing interest. This is a historical patient of mine. This is the first patient where I could preserve both face and the hearing, and that is when I was actually registered in Edinburgh. And 93 NSI, we presented from Sri Chitra. This is my personal series of 100 consecutive cases with a good, the total excision rate, but not so good facial function. We have moved on. This was one mortality in those 100 cases. This is my current experience in 2023, not updated now. And as you know, we had the first gamma knife in South Asia, so I control that also. So this is my personal experience of 1,000-odd cases and 617 gamma knife. And my patients, which has been operated by me, 17% patients have, over the period of follow-up, and gone on to get radiosurgery, either upfront or in follow-up. Different positions I have tried, but currently most of my patients are treated by the lateral position because the semi-sitting position has its own problems. I can't take time for that. Monitoring is critical. I think that is the standard of care. It doesn't make a bad surgeon good surgeon, makes a good surgeon a better surgeon. The preservation is better, and the quality of function is definitely better. I think that should be the standard of care in all vestibular schwannoma surgery. And you should have multiple possibilities, and this is my critical instrument, the calibrated suction, which does a lot of things. It dissects, it sucks, it decompresses, and so on. The standard retrosic craniotomy, this is from Fukushima's book. This is sigmoid sinus and lateral sinus, the transverse sinus. I do not see any advantage of an extended retrosic. Some authors talk about it. It's not necessary. It's a redundant approach to have an extended. All that is necessary is a retrosic craniotomy. ISC drilling, again, standard of care in my practice, and only in patients where the petrous is completely destroyed, and you have a wide opening, or the tumor is completely extracanalicular inside the CP angle. We don't drill it, but most of the time we drill it. And we do it after tumor debulking. It's a good functional preservation. Some publications I see that the preservation is worse when you do intrathecal drilling. That's because you don't drill it appropriately. Drill widely, 180 drilling, a lot of irrigation. And if you want to preserve hearing, you do calibrated drilling so that you don't go beyond 5 to 6 millimeters so that you preserve hearing. Now, if you have a wide drilling, then your instruments, you can use these instruments to dissect out the tumor without damaging the nerves. If you have a narrow drilling, a small, very, very small area, then your instruments damages the nerves. And that's the problem. So you do not damage the nerves unless if you're doing properly. So I'll go through one. This is a cystic solid tumor. I'll try to see fast forward. You see that it's about a 4 centimeter tumor. And this has been edited by I thought there was sound. I don't know. They don't. Anyway. This is a lateral position, as you can see. So zygomatic inion line, this mastoid. This zygomatic inion line. So this is my standard, and this is the most retrosic approach. Now this is always we need to see this transparent sigmoid sinus. That's critical, and when you have a large cyst associated, the brain bulges. Now in these cases, when you try to do the cerebellomedullary cistern, opening it up is difficult. Oh, sorry, what happened? What happened? No, it is gone 5. So this, you cannot drain the CSF from here. So you go for large, especially in lateral position, you put the patient, you go below the foramen magnum, open the foramen magnum. Semi-sitting, you don't need it, but in lateral position, you need it. And now once you drain the CSF from the foramen magnum below, and then the cyst decompress, the brain is very, very lax, and you don't need a retractor after that. And then you start doing the standard thing, and then you take in that tumor arachnoid plane, or some people call it the epineurium or whatever, that shining area. I don't know why it keeps going back. So the moment I play it, it stops. Okay, so decompression, usual decompression, and I'll just show you how I do the intra-artery canal drilling. Now you have to coagulate, there is the blood supply comes from the ascending pharyngeal. Take out the flap of dura over that. The burr, and then have a wide opening, and then as you reach nearing the dura, then we use the diamond drill. And then we decompress from intra-artery canal inside by a very low CUSA, and then we use the different instruments, including the nerve stimulator, dissector, and that's the facial nerve. You can see that there. And sometimes the air cells are open, and this is a two-hand dissection. You can see this is the cyst wall. There's a large cyst, as I showed you. So we take that out, and we can remove total or a near total excision, and that's the facial nerve. Now, if you've opened up the intra-artery canal, then you must always patch it because there's some air cells you saw. So if you find air cells, we first put a little bit of fat, then we put the bone wax over that, and then fat again. And then we also reinforce the primary suture line with fat, and that has reduced my CSF leak very significantly, and that's you see the immediate post-op, how the patient is. The small tumor, similar thing. The only thing I want to show you this. The quality of nerves is much better seen in a small tumor than this is the wide drilling of the intra-aortic canal I showed you, I talked about. Now this is, you see the nerve, the 7th and cochlear both seen beautifully. A little smaller tumor, giant tumor, they're flattened, but in less than 3 centimeter, 2 centimeter tumors, they are beautifully seen. Now if it's a large tumor, or this is a formed tumor, it's a small tumor or a formed tumor, you need to cut it. And don't have so, and this is the brainstem side. Now once you remove it, you see that, and you irrigate out all and you confirm that your facial nerve there. At the end of, taking it out, wash out all the blood, and then we fix the bone. And this is the patient. This is a young girl from Iran with a normal hearing. So just medial to the discs to the 7th nerves, we all know, just medial to the intra-aortic meatus, but also because of the large tumor, so the soft angle between the intracanalicula and extracanalicula tumor, you lose the plane, and that's the risk. At the brainstem, no coagulation, only gel form. If there is bleeding, just put gel form. I'll try to show a video if it's possible. Time allows me. In the intra-aortic canal and meatus, no coagulation there. A lot of irrigation, and that will take care of that. To preserve hearing, don't drill beyond 5 to 6 millimeter, so labyrinths to be preserved. So these are some of the tips. The bipolar is good to have a clean field, so the posterior petrous you coagulate so that you have a clean field, but don't use it inside when you're debulking the tumor inside the intra-aortic canal or in the brainstem. No extended retrosig, avoid retraction, respect veins, and err on the tumor side. If you're trying to take out a tumor with preservation function and you're doubtful where you are, leave a little bit of tumor so that you can have good function preservation. I'm running out of time. I'll skip this video, I think. Okay, that's that. Thank you. Thank you very much. Let me just go back. Some of these essential points I want to show. Where is the back? How do I go back? Yeah. So this is what I'm showing again in this similar thing. And this is a smaller tumor. Now I wanted to show you that this is the first thing where you coagulate. You have a clean field. I don't like blood there. It doesn't matter. Some people like it. I don't. I want a clean field. I want to see everything what I'm doing it. Stay in the tumor arachnoid plane or whatever you call it. If you are doubtful where is that plane, go onto the tumor side. So if you are remaining on the tumor side, you can always come back and decompress, have a lax brain. You see there is no detractor there. You have released the CSF, the good decompressions. Once you have good decompression, then you go to now again, this is two-hand technique. You see one side, you're holding the tumor. Other side, you're taking out that the membrane, and you decompress. I wanted to show you the intra-aortic canal drilling, how wide it should be. Now you see there's a wide drilling, right? So this 180 millimeter drill, 180 degree drilling is very, very critical. Now sharp cutting, there is dura going over there. So you have to cut it, open it up, and then decompress with a low CUSA. And this is low CUSA, very low strength CUSA, otherwise you'll damage it. You are continuously monitoring. If the patient is hearing, you are monitoring the beta. And once you have done that, now you'll see that different instruments being used. This is a hook with a nerve stimulator, and there is a nerve stimulator. This is a nerve stimulator, so it's constantly giving you the feedback how close you are to the nerves. Oh, I think it's gone up. Or? Now you see that the nerve. Now you see, this is what I tell you, the facial nerve is intact. There is a shining membrane, whatever you call it. Stay inside that membrane to have good function. So that's the cochlear nerve, and that's the facial nerve, and that's the empty space there. Now we put, as I said, we put fat graft inside. We close it. Before you close, put in some lot of saline there, because otherwise the air sometimes produces a problem, and then you close it and reinforce with fat. Now please remember, for the young nurse, take it out one thing from me. Reinforce the dural suture with fat graft and suture it over that. That will completely almost eliminate your facial nerve function, the CSF leak, which can be killer. Now this is, when there is bleeding, sinus and jugular bulb or venous injury, what do? Now drill over sinus, not a craniotomy. We do a craniotomy today, but over the sinus we drill it. If injured, no coagulation. Coagulate the emissary vein, but don't try to coagulate or achieve hemostasis on the sinus. Don't try to repair, not necessary. Some people so very nice, elegant, suturing of the sinus, not necessary at all. It's a redundant procedure. On the brainstem side, again, I'll show you what this is. One patient, I have got everything shown in bleeding, how to control. This is my resident. Of course, you have a resident training program. The craniotomy is being done by the resident. Now, you will see he has injured the sinus. So nothing, I tell him, and then he calls me. I tell, put a gel foam, sit on this, I'm coming. And you don't need to do anything. Put gel foam, couple of minutes there, lot of irrigation, put glue, come out of there, put a patty there, nothing, no need. It will completely close. And there is a little bit of, this is a condylar vein which it injured, there is some glue there, gel foam. This takes care of this. So that's the bleeding on the sinus. Any bleeding on the sinus can be controlled with gel foam, glue, and this is the emissary vein, you coagulate that, right? So that is the sinus bleeding. Now I will show you the bleeding inside the intraocular canal, because you saw the anatomy, the high jugular bulb can sometimes create problem. And now we are drilling there. Now this will be bleeding from the jugular bulb. Now when you are lateral position, it's not a dangerous thing, but when in semi-sitting position, a dangerous thing because air gets sucked in. Now there's a bleeding there. Don't panic. This can massively bleed. Please remember, if you're semi-sitting, you can kill a patient with this. So once you have done that, now what do you do? Again, the same thing. Gel foam, leave it for some time. It doesn't stop, it's still bleeding. But I want to know exactly where I have opened it up. So what I will do is, I will take that out. In a few seconds you will see that, because it's still bleeding, I'm not happy. So I'm removing that. I'll remove it, I think. Because you need to know where it is, the hole is there. So once I know where is the hole, I put a smaller piece of gel foam and push it inside. This is Professor Sami has described many years back, this technique. And you push it in. Don't completely block it, but you push it in a little bit. You see that? And then you put glue, put one more gel foam over that, and then put a patty. And once you start drilling again, they take out the patty, and then more drilling. So that is you saw the sinus bleeding, you saw the jugular vein bleeding. Now you'll see the brainstem bleeding. Now when you're taking the brainstem side tumor, now there is bleeding, this venous injury. And that sometimes patients, the cerebellum swelling and all that, because you try to coagulate that. Do not. Gel foam, patty, leave it, come out somewhere. And that's what I wanted to show that, so I'll skip that. Now, ICA injury again, when you are, sometimes, this is just to show that. Tumor with, sometimes we have this kind of anatomy there, when the ICA is going inside the intraocular canal or is stuck to the bone there. Now you can't do the decompression obviously, because you will injure the ICA. So what do? You have to drill that. Sometimes you just have to take out the dura here, separate that out. It is just this one, it was stuck to the dura only. It was not going inside. So you just cut that off. I was prepared to drill it because sometimes it goes inside the intraocular canal. And I cut it off, and then I release that dura. And I have to take that, because the ICA you can't injure. You can't obviously injure ICA. So you have to take that off. So along with the dural sleeve, the artery has been pushed back Now I have the area to do whatever normally we do it. So this is something which I found useful. Some tumors, sometimes everything looks like a nerve. We have used fluorescent, which enhances the tumor and does not enhance the nerve. So you can see this, if you are interested, this is Neurology India, please read it up. And also you have an idea about the disposition of the nerve. In pre-op, this is the seventh nerve, pre-op tractography, you can do it, and that you can see it. So I will skip that. This is possible. You can see these, some of the patients. Long-term preservation. There is some people think that it always comes back. It doesn't. This is 20-year follow-up. Large tumors. Now 20-year follow-up. And what happens if there is a small tumor? You don't go on for adjunct tumor. Many of these patients do not need any further treatment. In fact, the 3 months post of enhancement sometimes reduces. Yet another patient, similar thing, and this is 12 years. Hearing is preserved after 12 years. There's a sound there. The problem is sometimes it's unpredictable. There is more often than not, there is a drop of hearing. So you can preserve, but it is unpredictable. So you need to analyze your own cases. There's no point quoting Professor Sami or XYG. This last 100 or 50 cases, what you have done, that should dictate what you do to the next patient. I have 2 slides more just to show what we do today. All my intracanalicular tumor go for a period of observation. We do not agree with the concept for going for radiosurgery for preservation of hearing early on, especially in young patients. We wait for growth or hearing, then they go to that side. If there is good hearing, we still try to go for a microsurgical approach to preserve hearing in intracanalicular tumor. In extracanalicular tumor, earlier on, 2007, I used to tell in extra 2.5, 2 centimeter plus tumors, I will still do a microsurgery. We have analyzed last 100 cases. We have found our hearing preservation is better in extracanalicular small tumor in gamma knife rather than microsurgery in my hands. So we have changed. So for a good hearing in a small tumor, and the patient has critical hearing, he's a musician or something, whatever is critical for his hearing, and patient can afford follow-up, we say that you can go for radiosurgery. To summarize, today, function preservation is critical and hearing is bonus. So always you warn your patient you're going to lose your hearing or it will definitely drop. So if you preserve, that's a bonus. Total excision, subtotal excision with function preservation is appropriate. Even if you have to leave some tumor, that's fine. But total or subtotal excision with functional compromise today is not acceptable because we have adjunct alternative treatment. And this is a very fine balancing act, and that comes with experience. Unfortunately, the experience comes with the cost of the damage to the patient. So the fine balance comes with experience. Thank you very much, Dr. Ghosh, for giving that extra time.
Thank you, Dr. Misra, for your talk. Next, I would like to invite Dr. Manjul Tripathi for his talk on role of SRS in vestibular schwannoma.
Thank you, chairpersons, and thank you, organizers. So we just heard a wonderful overview and personal experience of BKM sir, which was a very pragmatic approach, and he changed his philosophy over the last 2 to 3 decades. Depending on the things, how does the patient behave, how does the tumor behave in the long term. And my topic is actually to speak on radiosurgery for vestibular schwannoma, and once you come with a radiosurgery, it comes with a blanket term, because there are so many radiosurgery machines that it becomes difficult to even remember the name of those machines these days. So I'm here in capacity of a microneurosurgeon and gamma knife radiosurgeon with a fair experience of radiosurgery to different vestibular schwannomas, cystic, solid, recurrent, primary, all these things. The psychology of understanding says that once human being learns something, they learn it so well that it becomes really difficult for them to unlearn them. And when the studies which come as an iconoclastic studies, which shake your belief, which you have been practicing for the last 3 to 4 decades, it becomes really difficult to change your practice because you think that what you are practicing is actually the right thing and you garnered good results with those ones. There are 3 sorts of studies. The first study is a non-threatening studies, which just adds to your knowledge. The second study, which changes your perspective like Aruba. People started treating more and more unruptured AVM after Aruba rather than leaving them behind. And there are third sort of studies which completely change your perspective looking at the things, like coiling for an aneurysm or radiosurgery for vestibular schwannoma. So there have been conceptual mistakes in the generation in the last 5 decades that resection is more radical, it's a benign disease, once I remove it, I cure the patient for the rest of their life. Modern microsurgical resections and my results are very good. Resection after SRS is more difficult and you lose the plane. If the tumor doesn't disappear after 3 years, SRS has failed. In case of failure, you can't retreat it. Small acoustics rarely grow, and if even they grow, we have a good chance of functional preservation with the hearing. Complete resection equals to cure. Mind you, there is nothing like a benign and a cure. You can control probably for the life, but you can't cure a patient, whatever the disease a neurosurgeon is having, except for the infections. SRS is increasing mortality because of increased carcinogenesis, especially in NF2. No, all the platforms of SRS are same. You can never treat and care for vestibular schwannoma with an SRS, or hearing loss is a direct effect of the tumor compression. We saw a sea change in the concept in vestibular schwannoma management. We started with the life preservation, then paresis preservation, then facial preservation, then we talked about the hearing preservation, and now we discuss about the quality of life. Why is it so difficult to change? Because we believe in the happy endings of our things, and we too much believe in our understanding about the natural history, the milieu of the CSF, endolymph, perilymph, basal turn of cochlea, tumor growth. Once we do not know exactly what is the biological behavior of that particular tumor. We are aiming with SRS for better quality of life, while having a preservation, progression-free survival, overall survival, free from additional treatment, no radiation-induced complication, preserving your neighborhood. So as rightly told, for a small newly diagnosed vestibular schwannoma without significant mass effect, yes, observation is a good option, especially if the tumor is intracanalicular. But in that case, you need to keep your patient on a regular clinical, radiological, audiological parameters. And if there is any fall in any of these, you need to jump as a clinician over there. But if you see a growth, even a minimal growth, then observation is no more an option, and you need to treat that patient. And if it is a Coos grade 1 to 3, SRS is actually the norm. The problem is that literature does not know the exact natural history of a vestibular schwannoma, especially if it is a naive one, first time diagnosed, or it's a residual one or a recurrent one. And if you do a 3D slide-to-slide comparison with the co-registration, you will find that the studies have regularly proven that there is a growth, and that growth is up to the tune of 33.6% per year. This is from head-to-head comparison. And most of these tumors, which have been kept under observation, had a 69% volumetric growth at a median 1.1 year follow-up. This was a very pragmatic study with a VREX randomized clinical trial in which the 4 years comparison of the tumor volume was done in between the wait and watch and proactive SRS, and they could conclude that upfront SRS was much effective at reducing tumor volume at 4 years than an initial wait and watch scan. 42% of these patients within 4 years needed salvage SRS and 2% needed resection. These are my own multicentric studies with a median 3-year follow-up with observation versus gamma knife. So we found that SRS was associated with the lower odds of tinnitus, vestibular dysfunction, any cranial nerve palsy, no change in cranial nerves, and it improved the tumor control while reducing the tumor volume in comparison to your observation strategy. Even if you remove it completely, you actually sometimes have a cuff of a tumor which is attached to the brainstem, which doesn't get visualized at the time of surgery or at the cranial nerves, and that tumor has a chance of coming back in next 20 years to 40 to 50%. So if you say that I have cured the patient, I'm sorry, you have not cured, you have not followed your patient for a longer duration of time. Regrowth rate after partial resection is up to 44% the longer you follow, and where do we stand? We stand in the cloud of uncertainty. If you are having a residue, then you need to understand that if it is still causing a mass effect, trigeminal neuralgia, you need to probably go again and operate over it. But if it is not, probably you can observe for some time, and at the point of the first growth, you need to intervene. What are the chances that your residue is going to remain stable? Pretty good if you follow them for a shorter duration of time. If your patient has a good life expectancy, probably you are going to fail in the long term, and it has been proven repeatedly that we fail in the long term. So why don't we jump immediately? Coos grade 1 to 3, practically everybody has accepted it, that yes, it gives a good result. So we studied some patients with the Coos grade 4 vestibular schwannomas who had a radiological compression, but clinically the patient was completely intact, and this is again a multicentric study with 627 patients. Its follow-up is rather small because the median follow-up is not that good, it's 38 months. The longest follow-up in our study was around 12 years. The tumor control could be achieved in 94.1% patients with an excellent facial nerve, trigeminal nerve function, hearing is going for a toss. Whatever you do, you observe or you do radiosurgery. So SRS was safe and effective treatment in obtaining tumor control in patients with Coos grade 4 with non-threatening or disabling symptoms, especially those with the surgical comorbidities that contraindicate the resection, but you need to keep your doses up to 12 gray. We further dissected it into younger patients and older patients, and we found that it is effective with the tumor control. Rather, tumor is reducing in most of these patients, causing a radiological decompression and the clinical decompression. This is ISRS guidelines on exactly dealing on this issue of large vestibular schwannomas published by my friend Konstantin Tuleska and his team. They could find that the tumor control down the line 10 years could be achieved in 89% patients, and further microsurgery was needed in only 7.7% patients with an excellent cranial nerve outcome. Their recommendation for an ideal patient was without disabling symptoms, with serviceable hearing, with comorbidities that make resection riskier, and those who wish to avoid a resection with no symptomatic mass effect. What happens once you radiate? Once you irradiate, first at 1 year, you get a radiological necrosis, then gradually the tumor reduces in size, and the longer you follow, the patients which I follow now for 1 decade and more, there is hardly any tumor in those Coos grade 1 to 3 vestibular schwannomas. Would I be able to hear again if I have lost my hearing? Probably not. An audiological assessment showing an PTA and SDS up to grade 2 is a serviceable hearing, otherwise it doesn't matter. There are some patients, they claim they got a better hearing, but I do not claim that. Because the problem is hearing we couldn't understand so far. We have been putting it a blame on the tumor, but there have been multiple factors including the compression, secretion, vascular, and the biological effect. The cystic vestibular schwannomas, if they are having a cyst inside the tumor, they actually respond better than the solid vestibular schwannoma, contrary to the earlier perception, and they give an excellent result just within 2 years. If you failed, tumor slightly increased down the line 3 to 4 years, you can again go with the second gamma knife radiosurgery. This is 20 years follow-up of close to around 1352 patients. Only 6 patients needed SRS, and all had control after the second SRS. This is again our study on NF2 because there has been an uproar about high chances of the malignant transformation in the NF2 patient. And with the 15-year tumor control of 52% in NF2, which is not like an sporadic one, we didn't find any malignant transformation in any of these patients. Intratumoral hemorrhage after SRS is an extremely rare entity. These are 10,000 patients, 25 years follow-up, only 4 patients had a bleed and 2 patients needed surgery. And if you go with the primary and microsurgery vis-a-vis radiosurgery, index procedure, follow-up cost treatment, it's better in the radiosurgical group with a better quality of life. For Coos grade 1 to 3 vestibular schwannoma, 500 patients, microsurgery, days off from the work is 130 days, return to work in only in 2/3 patients. While in gamma knife, the days off are 7 days and return to work, it's 99%. And it's a typical 2 to 3 hours procedure, day in and day out. Tumor control, since there are so many machines, Zapex, CyberKnife, gamma knife, proton, the tumor control overall has been found better with the gamma knife and LINAC in comparison to the proton. Compared to the most of the techniques, practiced SRS techniques, proton does not give you any added advantage for tumor control or your cranial nerve function, repeatedly proven now. Even for the hearing preservation, despite bragging about the Bragg peak, it doesn't give you any benefit over there. So if you go with the single fraction SRS technique, the best results are still with the gamma knife radiosurgery in comparison to the LINAC-based ones. Facial nerve preservation, facial nerve dysfunction are 4 to 6 times higher with the LINAC ones, which include the CyberKnife and the ZAP. Trigeminal neuropathy after radiation therapy are again 4 times higher with the LINAC-based techniques. And gone are the era when you used to treat these patients in 30 fractions, 25 fractions. That's never a stand here now. It's not going to stand in the future. So I say that once you are looking at the techniques, do not go with their cost because the proton carries a significantly higher financial toxicity without giving you any added advantage in comparison to your quality of life, facial nerve preservation, hearing preservation, which are actually the goal. Sometimes at 1 or 2 year follow-up, your tumor may show a slight increase in the size. You do not need to just jump over there. There is a phenomenon of the pseudo-progression, which depending on your radiology may vary. If the patient is not having a clinical deterioration, just sit tight, it gradually reduces, and we have proven it again and again and again. Sometimes, do not think that radiosurgery is an easy game to do, because it's an equally nuanced field. There are hot spots, there are cold spots, there is a way to include the margin, there are ways to leave the margin. And if you are not sure, you are bound to create a complication. It's a delicate knife, it's a powerful knife, but if you create a complication with the radiosurgery, once you have given the radiation, you can't take it back and it becomes really difficult to manage them. Some complications are inevitable. If may happen, they become a very rarity, but most of them are actually avoidable with a good planning. So just do not leave it to your medical physicist. Plan it yourself, see the nuances of it, and then you approve it. Radiation-induced neoplasia is a very rare complication. So far, I haven't seen anything, but yes, in the literature it shows, but still it's an extremely rare to be kept on a negligible one. So radiosurgery is an equally nuanced field and its philosophy should be learned while you are learning the philosophy of your microneurosurgery. Do not be overexcited about it, as Dr. Mishra just told. Do not be overly skeptical about it. But yes, be a part of the planning team, whatever the radiosurgery platform you are using, and be a signatory over there. Quality of life, we kept discussing about the hearing preservation and everything. A patient who is having another functional hearing, his quality of life is not affected by the hearing. He is least bothered because he is able to hear from the other ear unless he is a singer or a pilot. The factors which affect it are the tinnitus, vertigo, headache. Those are the factors which affect their quality of life and the facial nerve function. So take-home message with gamma knife radiosurgery: facial neuropathy less than 1%, trigeminal neuropathy less than 3%, hearing preservation 75% at 8 years and 85% for intracanalicular, and tumor control, even in the long term, you can achieve in more than 97% patients. So neurosurgical progress or lack thereof is based on the things that we can measure rather than the things which we should measure. So do not just always jump on looking at a scan with a black appearance where earlier the tumor was there. If you go with a planned partial resection, give a secondary radiosurgery, giving a good quality of life, that's actually the motto for your patient, because your patient should not bear the cost of your endeavors. Thank you so much.
Thank you, Dr. Tripathi, for your talk. Next, we have the Dandy Oration virtual talk by Professor Salim Abdul Rauf, titled Lesson I Have Learned from Yasser Gill.
Can I start?
Yes, sir.
It's my pleasure to be with you here. I apologize again for being this virtual talk. Could not be there in person. Again, I'd like to commend Professor Ghosh, our officers, the professors in the Dandi chapter of India for the tremendous work that's been put in over the last 10 years on this organization. Also, I'd be remiss not to mention the passing of Professor Dilip Chatterjee this last year, who was an officer of this organization. And I send our condolences to him, to his family, to the neurosurgeons of India, and a loss for all of us. I'd like to speak with you today from a different perspective. I'm speaking to you today as an apprentice rather than a professor. I'm reversing the roles today to share with you lessons I learned from Professor Yasser Gill. This year happens to be the 100th birthday of Professor Yasser Gill, and we felt this is timely to give my reflections. If I have seen further than others, it is by standing upon the shoulders of giants. This was once said by Isaac Newton. And today is my opportunity to reflect on that thought. One of the things early on in my time with Professor Yashigo was something I noted that would affect my thinking about how to take care of patients. And what we did every time we did the surgery, we would, of course, go see the patient in the waiting area, in the recovery area. The patient goes up to the ICU. And then throughout the day, in the beginning, it was something that was totally new for me. His office and my office was right next to each other, and he would come to me and say, okay, let's go see the patient. And we would, as we're doing other things, we'd go see the patient multiple times throughout the day until we leave that evening, sometimes 4 or 5 times a day. I mean, we're talking about a patient who's doing well. So I was just really kind of, in the beginning, I was not used to that. The patient was doing well, but we would do that with every patient every time we did a surgery, multiple times throughout the day. And I have adapted that. So my post-operative patients, I continue to perform that. I continue to see the patients multiple times throughout the day after the surgery, something I learned from him. Looking back at it, and in my conversations with Professor Yashigo, a lot of us are affected by things we see throughout our life. And one of the stories he told me was about a Professor Yusuf Staribis, who was the chairman of Neurology department in Ankara, Turkey, where Professor Yashigo had grown up. So when the Professor Yashigo was 14 years old, he developed pneumonia, was quite sick, and he was in his house. And his family knew Professor Staribis, and Staribis, who was a neurologist, and of course at that time there were not tremendous treatments for pneumonia, he'd come in every day to see the young Professor Yashigo, and would personally apply these hot towels to his chest. And he'd come in multiple times and just do that every day for this young boy. I think it affected him quite a bit to see that some big-time professors coming in to see him every day, watching over him and making sure that he's doing okay. So I think this affected the way he looked at it, looked at medicine, and looked at the compassionate care a physician can give his or her patients. It was very, in the beginning when I first started to work with Professor Yashigo, as all of you know, once we finish our training and all of us think we could do everything. A lot of the young neurosurgeons in the audience probably can appreciate what I'm saying here. So there was a patient that came in with a posterior communicating artery aneurysm. The residents called me. I went saw the patient in the ER, and then I was planning to take the patient to the operating room for clipping of that aneurysm. As you know, all of us are trained that PCOM aneurysms are simple aneurysms, whatever. So I was in the hallway, and Professor Yashigo told me, "Oh, I heard you have a case." I said, "Yes, I have a simple case, a simple posterior communicating artery aneurysm." Now I was so sure of myself. So he turned to me and said to me, "Simple for you, but maybe not so for me." I was shaken up by that comment. I was frozen actually in place. And then it actually took me many years later to understand what he meant by that comment, and I'll cover that in this vignette that I'm giving today. He and I would never talk about that again, but it did affect the way I looked at things, and gave me a lesson in humility of the kind of things we deal with, things that we think are simple can turn out to be very, very difficult. And when you're very young and you think you know everything, you're most often quite wrong. At the turn of the century, the board of Neurosurgery, the journal, under the leadership then Mike Apozzo, had an advisory committee of 170 neurosurgeons from around the world, and the board itself met to look at the history of neurosurgery and where it has come within 100 years. They looked at two major things to see who were the contributors to this field, to our field, over this era. They looked at it in two elements. One was the foundation of the field of neurosurgery, and the second being the progress of the field, mostly microneurosurgery. So these were the two main elements they looked at. Of course, neurosurgery as we know it today was developed in the 20th century. So that was a foundation. And then the development of microsurgery occurred in the second half of the 20th century. So they divided the century into two halves based on these two key elements to name the man of the century. Without a doubt, in the first half of the 20th century, the foundation of the field of neurosurgery, the modern field of neurosurgery, is attributed to Harvey Cushing. Harvey Cushing, as a young neurosurgeon in the beginning of the century, working at Johns Hopkins, noted the high mortality in the field of neurosurgery, in the field of surgical surgery of the brain, and came up with the visionary idea that neurosurgery should become a separate specialty from surgery, which was completely not something that was accepted at the time by his colleagues, the surgeons that were working at the time. But he pushed it hard, and within his lifetime, he would change profoundly the mortality from cranial surgery, introduce the basic concepts of neurosurgery, even things like the anesthesia record that we take for granted. The anesthesiologists write the vital signs every minute, every hour. Now they're computerized. That was invented by Cushing, not by anesthesia. So he was a profoundly visionary figure that would promulgate neurosurgery into a field, into this new arena. I think the best way to summarize is based on the statement by Michael Apozzo. One of the great elements of solace in the rigorous and frequently stressful journey through life in the neurosurgical profession is the company that we keep, both historically and in the contemporary vein. Cushing and Yashigal clearly deserve a special status in the hierarchy of our extreme appreciation for the contributions to and support of our own daily endeavors as neurological surgeons. Without question, they have changed the art and science of neurosurgery during their time and forever. I think those are two words that explain to us how in our field we pay homage to those who came before us, who've had such a profound effect of how we do everything today. It is the company we keep in many ways. We're all related as neurosurgeons by that people who have trained us, and that's a proud company that all of us have, and we will continue to cherish. In the many conversations I had with Professor Yashigil in my time with him, he mentioned to me a book that was given to him as a gift back in the early 1950s, when he was just starting in training in surgery and neurosurgery. A book was given to him by one of his professors, Professor Bandi, in 1951. It was a German edition of Brain Surgery. There was a monograph of this book here called The Brain. Many of you may be aware of that. It's a dandy book called The Brain. And he told me this book profoundly affected him very early in his career. It just totally really affected the way he looked at what neurosurgery is. So that's the connection that I just wanted to make here, because we're all connected here between Yashigil and Dandy, and how that book would go on to influence the way he would go on to think. Many years later, I got to meet Professor Dandy's daughter. I met her when she was in her late 80s in age. I got to know her over a number of years and learn about Walter Dandy quite a bit through her stories, her reflections. Like, I'm giving you reflections of Professor Yashigil. I heard her reflections on Professor Walter Dandy, and the family life and all that followed many years later, including his career in all the politics and neurosurgery that has always existed since the beginning. That ultimately, that relationship with Mary Ellen and I ultimately look and would make what we have today, where you are today, which is the Dandy Society. This is a note I was kept from Mary Ellen. Mary Ellen passed away, unfortunately, a few years ago. She would tell me with great appreciation for your work on the Dandy legacy with affection. She and her family felt I did everything I could. Having heard the story, having heard the contributions of this yet another great master neurosurgeon, and we did everything to name a society for him, but specifically dedicated to what he was really good at. He was a master surgeon, master technical surgeon with anatomic understanding of the brain. And so that is a fine area in neurosurgery. Many neurosurgeons have many great attributes. One of the key attributes we look at in neurosurgeons are their mastery of the craft and understanding the anatomy of the brain. And clearly he was that. Just to connect the dots, just wanted to show you the picture of the late Professor Hugo Rizzoli, who was Dandy's last trainee, and I'm speaking to you as Yashigil's last trainee. Just to connect the dots, Hugo Rizzoli established the Department of Neurosurgery at George Washington University, where I work now. So it's interesting in neurosurgery where all these things are so connected. The innovations we make or think about is not because we are great at everything, but they're based on lessons we have learned from others. This is an aneurysm of the middle cerebral artery in the right sylvian fissure. And many of the professors sitting here know that the complexity of this aneurysm is such that this is the M1, this is one M2, that's another M2. It's a very wide neck aneurysm with some calcification in the neck. Early in my career, I would attempt to try to directly clip this aneurysm here, and that would be a big mistake. Because this kind of aneurysm, if you try to put a clip or multiple clips here, that is one option. But when you try to put a clip directly here, the clip may slip and tear the aneurysm, or may slip downwards and occlude the M1. So this kind of aneurysm can really trick you into quite a difficult situation. So the first thing is to, of course, to separate the M2s from the aneurysm dome, as I'm doing here. Okay, and sharply is safer than bluntly, for sure. Okay. When I was with Professor Yashigal, I recall there were these small, tiny aneurysms on certain blood vessels, and he would take his bipolar and just shrink that aneurysm and essentially get rid of it. Tiny little aneurysms. I had never seen that before, and I was really impressed by that. So I decided to take that to the next level, meaning, would it be possible in this kind of situation to reconstruct the aneurysm in a way that we could make the clipping safer? So this is the situation here. So what I'm doing here, this is in real time. What I'm doing is reshaping, reconstructing this aneurysm. There. Within a span 1 or 2 minutes, you're dealing with a totally different aneurysm at this point. Totally different animal, okay, from a clipping standpoint. So this idea of, reconstructing aneurysms, came to me after seeing Professor Yashgil use the bipolar for tiny little small aneurysms. Okay. This takes me to the birth of extracranial to intracranial bypass. On October 30th, 1967, in Zurich, Switzerland, a 20-year-old male who had presented with occlusion of left middle cerebral artery, had no collaterals, underwent superficial temporal artery to middle cerebral artery bypass. On follow-up notes that Professor Yashigil has, the patient was followed for 5 months, ultimately died of unrelated disease. This would usher in a whole new era of thinking in neurosurgery. So what was the birth of neurosurgery or microneurosurgery that had never been done before? As a medical student at the University of Basel in Switzerland in 1943, Professor Portman had given him a project to look at the hypophysis in the frog, to do a special project looking at that, and for that you needed a microscope, something that Professor Yashiga had never used before, and it was never used in surgery before. So that was the beginning of the thought of what is potential impact of micro work in neurosurgery, okay? When he went back to then he moved to Zurich, Switzerland. As a young neurosurgeon, he encountered a couple of situations that would push him to think along these lines. The cardiotoracic surgery had evolved earlier than neurosurgery, and they were doing cardiac surgery and doing coronary surgery. And because at that time, anticoagulation and dual antiplatelet therapy was limited, they would have patients that would have embolic disease to the brain during and following those surgeries. So essentially, the inception was in early 1962, Professor Senning, who was the head of cardiac surgery in Zurich, Switzerland, talked to the young Professor Yashigul about a patient who now had a occluded left middle cerebral artery, and asked Yashigul to go and open up this artery. Yashigul was apologetic to the senior cardiac surgeon, saying, I really have no way of doing this. There's no instruments, there's no such thing in neurosurgery we have to go open up somebody's middle cerebral artery. So that really profoundly affected him, the limitation of the field he was in, with surgeries being done with the naked eye. That ultimately led him to connect with Professor Donahue in Burlington, Vermont in the United States in 1965. And he would move to the United States to spend time with Donahue, who was just starting doing some training using a microscope for microneurosurgery. Professor Yashi would write, many years later, I was welcomed by Dr. Donahue. His earnest dedication to the task impressed me immensely, and he offered me a grant from the Hartford Foundation of $2,000 for the year. I'm deeply grateful to Dr. Donahue for teaching me the use of the operating microscope, microinstrumentation, and the basic techniques of microdissection and microvascular experimental work. For me, this was the beginning of reconstructive brain artery experiments in the laboratory and the birth of microneurosurgery. So these men coming together would ultimately, as soon as Professor Yashkel went back to Zurich after that, that's what led to this first operation of ECIC bypass in Zurich, Switzerland, and then Donahue performed the same operation very shortly afterwards himself as well. So this was the birth of our deep connection to microneurosurgery. The main contributors to microneurosurgery, or pioneers in microsurgery from that era, really what Professor Yashigul has given his credit to them was Julius Jacobson at Mount Sinai, Harry Bunke at University of Stanford, of course Donahue here, William House, Bill House from the House Institute, then the University of Southern California, and Theodore Kurz, also from the University of Southern California. The people who came together to create the field of microsurgery. Many years later, as a young neurosurgeon, I dealt with this specific case. A patient presented to our emergency room and had developed ophthalmoplegia over a few weeks. The residents called me about him. I went and saw the patient. And we asked for an angiogram, which is shown here. The question for me was, what are we going to do about this? Clearly, this is not a clippable aneurysm. And I was very early in my career with my interest in vascular neurosurgery. I spoke with the patient and said, listen, what we will do is do what's called an STA to NCA bypass, and then we'll trap or occlude the carotid artery. and so forth. I had discussion. We admitted the patient to the hospital, thinking about planning to do this once I had the chance to speak with his family. So that's fine. The patient was otherwise neurologically okay without the ophthalmoplegia, except for the ophthalmoplegia. At 2 in the morning that night, the residents called me that the patient had suddenly deteriorated. And by the time I got there, he had fixed and dilated pupils. And they tried to resuscitate him, but without success. Probably one of the hardest things for a neurosurgeon is to go to the pathology suite and look at what exactly happened. I personally did this. What I found, although in our literature we're told that these cavernous aneurysms are very benign, in this case the aneurysm tore through the dura into the temporal lobe, killing this man. I was very shaken up by this. Given that I had not had this kind of situation before, I was just starting out. And the lesson I got from Professor Yashigo at that time is a lesson in resilience. Either I'm gonna just get on my knees and be shaken up with this whole thing and never deal with it again, or take the other path. Go right in and see how you can make these situations better in the future for other patients. This was the inception in my life, in my career, to start to think about ECIC bypass surgery and what I can do in it. Now, some years later, when I had moved now to St. Louis, I encountered this patient here, which was sent to me. Initially, it was thought to be a very large sphenoid-wing meningioma, but when we did the angiogram, this was almost an 8-centimeter aneurysm. So here, a different thought process had entered my mind. When I first started thinking about bypass surgery, based on Professor Yashigo's experience and working with cardiothoracic surgeons early on in his career, I told the Professor Yashigo I have tried some saphenous veins for high flow bypass. I encountered many difficulties with them, including thrombosis, the valves, and so forth, and that cardiac surgeons are using the radial artery quite a bit. So he said, encouraged me to explore that further. And then I went in and scrubbed in with one of my colleagues who's a heart surgeon to see how they were using the radial artery in coronary artery bypass grafting. So I tried to learn as much about the radial artery as I could from the heart surgeons to potentially use in bypass surgery. So in that patient I just showed you, I ended up using the radial artery graft, doing the high flow bypass, completely trapped the aneurysm, keeping the main vessels open, and so forth. This patient went on to do very well, and we really essentially converted to radial artery almost exclusively from that experience. Because of our early involvement in ECIC bypass and doing all the courses, I think it became really the radial artery has now, I believe, become the main conduit for high flow bypass, except in certain cases where we cannot, use it. In my early studying from professor's work, I saw a lot of the beautiful angiograms he did, and I was always struck by this really large vessel, the internal maxillary artery, that comes down to the temporal floor. I was doing the bypasses using the radial artery coming up from here all the way here, and so, or the saphenous vein. I started thinking how we as neurosurgeons can use the maxillary artery. It'll be closer, shorter, and given the physics of bypass surgery, shorter the graft, the better likelihood of the graft surviving. So this is where it sits right below here. and it would just be from there to there. And so this started my thought about looking at the maxillary artery. This is the anatomic work that we did in the lab with my fellows and residents, identifying the maxillary artery through the middle fossa floor. And this ultimately led to our, after a lot of work, this was the first patient ever to undergo the maxillary artery to intracranial bypass, high flow, using the maxillary artery in a patient with a giant aneurysm. This was the cover page of Neurosurgery describing that process. And then my good friend, yet another master surgeon and contributor to the history of neurosurgery, Robert Spessler, around the same time when he wrote his book on cerebral revascularization, I was humbled the fact that he wouldn't go on to name that as the Abdroff bypass. We can get all kinds of awards, but nothing makes us more humble when your own colleagues in neurosurgery recognize you, and that was very humbling for me. I had told Professor Spessler that I'd be giving this talk recognizing Professor Yashigil as a mentor. So he sent the following statement. I asked for his thought about Yashigil since he also saw him as a mentor. And so he sent me this thought to share with you today. Ghazi was my role model for ultimate surgical virtuosity. He was meticulous in his approach and attention to details. His mastery inspired a generation of neurosurgeons to the great benefit of our patients. He remains a terrific mentor. So here we see multiple generations of neurosurgeons. We talked about Dandy, we talked about Cushing, Dandy, Yashigil, Spessler, and now I'm speaking as an apprentice to the next generation of neurosurgeons. So it's a great history that we have. The first course is in microsurgery with hands-on training would go on in Vermont, in Burlington, when Yashigil and Danahy together would establish the first hands-on courses in micro work and micro neurosurgery to train other people that this can be done in the operating room and you can learn micro technique. Based on that initial vision, when I moved to St. Louis, we started our international symposium in cerebral revascularization. And this would go on for over a decade. And for the third symposium, it was Yashigil that was the honored guest for that, to teach, for us to really discuss bypass surgery as you are doing today in Cork, India, with having a hands-on training. So the history of that, which Giovanni and others, Giovanni, as you know, he's there and he spent time with me, continues over time. We continue the vision, we continue the thought of how we train yet another generation. Talking about the giants of neurosurgery, there is no talk about giants of neurosurgery without speaking about Professor Charlie Drake. I remember when I was with Professor Yashigil, when we talk about many of these things, he told me one thing that really always stuck with me. The word that he used about Charlie Drake was he was so courageous. He was so courageous. And when I asked further what he meant by that, he meant for someone to have the courage to go after basilar apex aneurysms throughout his career, even at the time when we have limited microscopes in illumination. To this date, Drake has the largest series of clipping of basilar aneurysms than anybody ever, and I believe anybody ever in the future either. So he was a major figure. And to tell you more about Charlie Drake, I want to quote him in something that was profound and it affected me. If only we could have back again many of those who were lost or badly hurt for a second chance in the operative room with what we have learned. How profound is that statement? It resonates with each one of us. Only if we go back, had the chance a second time for some of our patients who did not do well. I think each one of us knows the meaning of those words. As I went on with my career, we found situations, despite all the things we've learned from our mentors and all the techniques that we have learned and developed, there's always a situation that everything went perfectly, but the patient wakes up with a deficit. This situation really bothered me over the years, that there are times that you just don't know what's going on, especially in intracranial cerebrovascular surgery. So when we went back and looked at the data, when you look at intraoperative neuromonitoring, look at SSCP, motor evoked potentials, this is a largest meta-analysis. There's a very high level of concern about sensitivity and specificity of intraoperative monitoring. Up to about 20% of the patients we're getting the wrong information on. So the missing link for us is that how long can you keep a temporary clip on a vessel and it's safe? And secondly, once you put your permanent clip on and there are peripheries behind you cannot see, how safe are you during surgery when the patient is under general anesthesia? So let me just show you a couple examples. This is early work on awake surgery. I just want to move this along here. This is a patient with a grade 1 ruptured aneurysm. This is the aneurysm. M1 is here, 3 M3s, and I'm working behind it. So I'm identifying the M2s. And here, I'm putting the temporary clip on the M1. Now, because this is a part of study, the patient's having intraoperative monitoring plus awake testing.
Squeeze my fingers, Kerry. Excellent.
So the minute I put the temporary clip on, the patient is doing well in the right arm. I'm working the left sylvian fissure. I'm happy. I'm proceeding.
Kerry, you're doing great, buddy, okay? Just don't move anything right now.
I'm reconstructing the aneurysm to create a wide neck aneurysm all the way back here as I'm doing this, okay? And everything is going fine. The monitoring is perfect, everything.
Fingers here. You move these fingers?
The patient suddenly tells me he cannot feel his arm, he cannot move his fingers. The SSCP, all the monitoring is completely normal, okay? So automatically—
You move these fingers, Kerry?
Automatically, of course, I remove the temporary clip right away, restore flow, and start clipping the aneurysm without temporary clip because
right here.
You see, within 10, 20 seconds, he's moving his arm. Interesting thing is his monitoring never changed throughout this time. Had I been under general anesthesia, there's no way I would have known this, okay? These are the early examples we had from this study.
Excellent.
Okay. This is just another case, just for time. I'm going to go through it quickly here. This is a posterior communicating artery aneurysm, an anterior choroidal aneurysm with anterior choroidal artery coming here. Okay. So I'm clipping the PCOM aneurysm, it's no problem, but the anterior choroidal artery, as you know, can be very sensitive and you cannot see it behind you, behind the carotid, right? So here is the anterior choroidal artery right there. So I'm going to be careful around it with the clip, but I cannot see deep where the choroidal turns, right? So how am I going to know 100%? So as I close the clip, you will see
my hand.
You see, I'm testing.
She's moving up.
I'm testing the patient as I'm closing clip. I know 100% before I leave the operating room that everything is okay and not relying on monitoring, Okay. As the same thing applies to high flow bypass surgery, tolerance of the temporary clipping vessel, and then permanent occlusion of the parent vessel after a high flow bypass. Because of the time limitation, I'm going to skip this part. Anyway, initially the study was 30 patients of bypass of clipping, 30 patients of bypass that I was allowed by the IRB committee to perform. These were the first 30 patients of clipping aneurysms. And these 30 patients, this was published in Journal Neurosurgery, did better than the cohort, which is the general anesthesia in the neurosurgical literature. Similarly, for high flow bypass, I compared my first 30 high flow bypass awake versus under general anesthesia. Again, they did better than my own patients in my own hands under general anesthesia. So this is the cumulative phase 2 study showing significant difference in this ongoing trial between general anesthesia and awake, as you see here, as phase 2 study, and phase 3 studies continuing into the complex aneurysm area. Multiple centers involved in collecting this OMTA trial study results. I'm going to move really fast because I'm coming to the last few minutes here, so I'm going to have to just truncate this a little bit. The other area that Professor Pozo at the 30th anniversary of Journal of Neurosurgery asked to write a paper about intraventricular tumors, I had the honor to give the cumulative information about techniques of intraventricular tumor surgery with Professor Yashigal and I writing this monograph. And having learned from him the various techniques, what's safe, to how to operate around the fornix. This is a third ventricular tumor, and how to open the choroidal fissure safely, sharply. All techniques I learned from Professor Yashigal, to do this, and that's in our monograph. Any of the young neurosurgeons can look at that. I think with I'm coming to the end of my time. I'm going to skip some of this here about AVMs. Finally, I want to recognize Professor Sam Al-Mifti and his work. He was very instrumental in bringing Professor Yashigal to the United States. So I spent time with, just the history continues. I did my fellowship in skull-based surgery under Al-Mifti. Deanna Sasaki did her fellowship under me. She is just named the professor and chairman, University of Arkansas, Little Rock last year. So this history of us training each other continues. I think I will skip because I'm end of my time here. When Professor Yashigal in the late 1960s wrote his monograph of microsurgery, explaining the foundation of microneurosurgery, he recognized his mentor, Professor Cranbuell. So as I told you, everything I have done, I emulate my mentors. When I wrote my book on bypass surgery, the foreword was written by Professor Yashigal. So we continue to respect our mentors and our teachers. At the end, I'd like to say, especially for the young neurosurgeons in the audience, you might think by listening to me today, everything I learned from Professor Yashigal was in the operating room, but that is not true. This is a list of all the publications, the invited comments about articles in neurosurgery that he and I wrote together over the over the year of the time I was with him. All these, we spent hours and hours each discussing different parts of the brain, different techniques. The learning I had from him, from all this work we did together, had a more profound effect than just learning technique. So I just want to make sure I set that straight as far as the work that was done with him and I together in learning so many things and writing the comments and invited editorials by editors that asked Professor Yashville to contribute. Professor Yashville would come and visit me a number of times when I established the Department of Neurosurgery in St. Louis. Okay. Diane Yashville is somebody who, in the history of neurosurgery, has to get the credit. She was the most amazing scrub nurse I have ever seen working under her. All you had to do is put your arm up and she knew exactly which clip you needed to place a clip on. So she really typifies what are the best of the best are in the field of neurosurgery, those who help us with surgery. Yet another generation, we're learning from our mentors who mentor yet another generation in neurosurgery. I've been told I was Professor Yashville's last trainee, and I'm humbled by that, honored by it, but I am not so honored by when one of my other mentors told me I may be the last of the dinosaurs. I don't would like to believe that microsurgery at its essence will continue among the young people sitting in the audience. The concern is those of us who have long series aneurysm clipping and bypass and ABMs, those days are over, given the evolution in endoscopic surgery, endovascular surgery, and that microsurgery will no longer be as well a practice as an art. At the end, I'd like to say, no, I do not want to be the last of the dinosaurs. Microsurgery is the soul of neurosurgery. It has to work very closely with the excellence of endoscopic and endovascular neurosurgery. But I do believe yet another generation has to be trained so well to be masters at this craft, just like those who came before us. Thank you very much. It's my honor to speak with you today, and my honor to be with you, my colleagues, Indian neurosurgeons, residents, fellows who are in the audience, and the international colleagues who are joining our Congress in India this year. Thank you so much.
Thank you, Professor Abdulraf, for the inspiring oration. Your reflection on Professor Yasser Gill and the lessons learned are truly invaluable.
Thank you, Professor Salim, for giving such an excellent talk. It was really very overwhelming to hear from you about your mentor, and I'm sure you are taking it forward to the next generations. We're looking forward for your work that you are doing for your IVIC surgery on the difficult aneurysms and bypass. I'm sure the next generation is going to learn from you about this IVIC surgery on the bypass and the difficult aneurysms. Thank you so much.
Thank you, Professor Ghosh. All of us give a lot of talks. This one was written from the heart, because when we think, all of us, about our mentors, it's very emotional for us. Professor Ghosh, you and the other professors there represent the best of the best. And we're so proud that the Dandy Society has you and the officers of this society to really be the mentors for this next generation. Thank you, sir.
Next, we have a virtual talk by Dr. Hirotaka Hasegawa on endoscopic excision of different CP ankle tumors.
Hello, everyone. Can you see me? Now I'm sharing my presentation. Okay, can you see my slide?
Yes, sir.
Perfect. Thank you very much. So, I'm very sorry about my mistaking the time of my presentation. Sorry for that. And so my today's topic is endoscopic excision of different CP angle tumor. It sounds a bit weird, but we can go to the CP angle even from the nose.
We can't see you.
So endoscopic surgery is a well-established standard approach for the
Professor,
treatment and
Professor,
supraphysiology.
sorry
Yes,
to
sir?
interrupt.
Yes?
We cannot see you, so I think your camera you have to on. The slides we can see, but we cannot see you.
I see. Sorry, maybe it's like the camera problem, so I'm not sure how to fix it. So let me keep on that. So anyway, so the posterior fossa, particularly the CP angle and the ventral line posterior fossa, these regions are very challenging because of the narrow and deep corridor, and many important arteries and nerves are there. But endoscopic translational surgery may offer a promising alternative for accessing these deep regions, providing minimal invasive access to even the brainstem. So let's divide the posterior fossa using these two landmarks, which is Jorello's canal and gross pharyngeal meatus. So usually we can say this is the upper posterior fossa, and this is the middle, and this is the lower. And this is the ventral midline posterior fossa, and this is a CP angle. Lower side, you don't have CP angle. Instead, you have lateral cerebral medullary cistern. But in this presentation, I would call this as a CP angle. So when you want to go to middle posterior fossa, you gotta do just a standard transcriber approach. But if you want to go a bit lower, then you have to use the transpharyngeal corridor. It's also the kind of transcribal approach, but you may have to add transatlantal approach. And for the upper posterior fossa lesion, I think it's among. I think this approach is among one of the most challenging approach for transnasal surgeons, because it requires transcriber and pituitary transposition to see the suprasellar lesion and upper cribal lesions. So this is a very standard case, cribal chordoma. So this patient has got the tumor in the level of middle clivus, so I just use the standard transclival approach. So this is the frontal side of the sphenoid sinus, which is being removed progressively. So be careful that there are a bunch of bleeding points, like this is a cavernoma sinus, and back there is a the posterior side of the cavernous sinus, petrous apex, and also the vaginal plexus. So many plexuses are there. So you have to master, how to make a good hemostasis. Like, this is the flowable hemostat. These bacteria are very important to make an instant hemostasis. So this is the tumor. This is the difficult point for chordoma, because the chordoma always invades into the venous sinus. So you have to cut into the cavernous sinus to take out the rest of the tumor here. So this is inside the cavernous sinus. You can nicely see the carotid artery. And after taking out the tumor, you can use, again, the flow seal and some other flowable hemostat to make a complete hemostasis. So this is now the final part, which is the intradural part. After removing the intradural part, you can see the basilar artery and the pons there. And this is the sixth nerve, by the way. And this is the lower side, the other side of the sixth nerve. So the tumor has been completely removed and her symptoms improved thankfully. So tumor is sitting to the in the lower midline posterior fossa. You have to use transpharyngeal approach. So this is the case. For this type of case, I will usually harvest the nasopharyngeal flap up front and place, and then so this is a cranial corridor. And then down there, you also have the transpharyngeal corridor. So you have to connect, the middle clivus and the lower clivus. And just progressively remove the clival bone and open the dura to expose the tumor. First, the internal decompression, meticulously continue that. And then using the cistern just on top of the tumor, in the vascular artery, and then follow the all the vascular anatomies like AICA, and this is the right side VA. This is, by the way, the anterior spinal artery, which is the most important thing for this type of tumor. This is the left side of the VA. Meticulously cut the tumor, and then the tumor is now being removed in a piecemeal fashion. So the rest of the dura is coagulated. For the reconstruction, I take the duragen and inlay fascia. So this is actually a case which was done in a couple of years ago. So at that time, I didn't do any dural suturing technique. So I just did the multi-layered skull-based reconstruction. And this is another pharyngeal flap, which is nicely covering the defect. So the patient went well. There was no CSF leakage, and the patient's symptoms improved. So this is again one of the most difficult cases because the tumor is sitting both in the suprasellar and upper clival region. So in this type of case, we have to do pituitary transposition. So this is the posterior craniotomy process, which is removed, and this is a suprasellar view. So you can see the top of the tumor. This is a SHA. Also, you have to completely preserve to preserve the visual function. Unfortunately, the PCOM is completely embedded inside the tumor. So first, I turn my attention to the right side to find the vascular artery and cut the tumor into two small pieces. And because the right side tumor is smaller than the left side, so I first took out all the right side tumor and then coming back to the left side tumor, generally removed in a piecemeal fashion. This is a PCOM, nicely dissected using sharp dissector and scissors. This is a P2, and this is the third nerve. The rest of the tumor is progressively removed using the 30-degree angle endoscope. This is 5, 6, and third nerve and the fourth nerve, and this is the complete removal of the tumor. So I took the duragen and inlay fascia, which is sutured to the dura. This is the pituitary transposition case. So essentially, we cannot do any watertight closure, but we can do a near watertight closure using these backless fat and close the suture. And everything has to be covered by the onlay fascia and the nasopharyngeal flap. And the patient went well, and this time also no CSF leakage, no deficit. This is very interesting case. So this is the tumor is completely sitting in the CP angle. So this is an epidermoid cyst in a 29-year-old female. This is actually an asymptomatic case, but the tumor is progressing over time. So I decided to take her to the OR. So this is the simple transcriber approach. You gotta see to the right side using the angled endoscope. So the transcriber exposure is being done in a usual fashion. This is a basilar plexus, by the way, and the posterior cranial process and the dorsum sella is also removed. And it's very important to remove the jugular tubercle to obtain a good view in the lateral side. So once open the dura, you can take out the tumor. As you know, this type of tumor is really soft and suckable. So luckily, I was able to remove also the capsule is very important. So this has to be removed simultaneously with the tumor. This is the up-angled view. You can see the basilar tip and mammillary body and structure over here. And this is the right side view. You can see the sixth nerve and deep there. You can see the seventh and the eighth nerve using, this is a 30-degree, and also I use the 70-degree endoscope for this particular case. So again, for the skull reconstruction, I take a duragen in left fascia, suture it to the dura, and on left fascia, and finally another pharyngeal flap for this particular case. So this is the total removal with subtotal removal of the tumor capsule, and patient didn't have any neurological deficit. I think for the time issue, this is gonna be the last case, but this is the foramen magnum meningioma in 59 patients. So this is a kind of lower clival lesion, so you have to do transpharyngeal transclival approach for this case. So you don't have to pass through the spinal sinus, but you can go directly to the pharyngeal side to find the lower clivus, and this is the hypoglossal canal, which is also opened up. And the ventral side of the dura is exposed, and this is a tumor. Unfortunately, the tumor is really tough, so I have to use the Sonobet like maximum power to do internal decompression like this, and the tumor is being progressively removed. So I was finally able to find the vertebral artery and the 12th nerve and the lower cranial nerves there, which is meticulously dissected off of the tumor like this. And finally, the rest of the tumor is being pulled out. And then lastly, you can nicely see the anterior spinal artery, right VA, left VA, and lower cranial nerves, and 12th nerve. Again, the dural reconstruction is the same. Duragen in the fascia, near water depth suture using this time 6.0 PDS, and only fascia, and the pharyngeal flap. So the surgery went well. The tumor is totally removed. Thankfully, she didn't develop any deficit at all after surgery. So, so when you want to reach the lateral side of the tumor, then you have to, the lateral lesions lateral to the cranial nerves, then you have to use the endoscopic anterior transpitulosal approach, which I think I have to skip for the sake of the time. But you can do the same quality of anterior transpitulosal approach as the microscopic transcranial approach using the endoscopic surgery through the 3.5 centimeter very small bony window. So I'm gonna skip the video. By the way, this is the fifth nerve and the basilar artery, and the contralateral side of the third nerve, and this is the third nerve of the ipsilateral side. So this is the final view. You can nicely see the bunch of nerves and brainstems, and you see this is just a 3.5 centimeter very small craniotomy using the endoscope. the same quality as the microscopic transpersonal approach. So this is the subtotal resection causing no neurological deficit after surgery. Okay, so I have shown the various transnasal and the minimally invasive transcranial corridors, and everything can be done through the endoscopic eyes. So now endoscope can be used for multiple various trajectory to the deeper side of the skull base in a minimal invasive fashion. So you can explore possibilities with your imagination, and you can assess the feasibility of your imagination through the surgical simulation. And then finally, you can move to execution. So this is my last message. Thank you very much.
Thank you, Dr. Hasegawa, for your time and the insightful talk. Next, I would like to invite Dr. Keiki Turel for his talk on managing complications of vestibular schwannoma surgery.
Is it working? Good morning. Thank you very much. Thank you, Dr. Siddharth Ghosh and his team, Anil Pandey, Manjul Tripathi, and all of you. Thank you for attending this course. It's been a splendid hospitality and a wonderful environment. So I'm going to talk about complications, avoidance, and management of vestibular schwannoma. It was very heartening to listen to Salim Abdul Rauf today and how he paid his homage to his mentors. And here at this stage itself, I would say that I would like to pay great respect to my mentor, Professor Sami, with whom I worked in the early 80s, and from whom I learned all the essential lessons on not only CP angle surgery, but everything else, including his philosophy and his great approach to neurosurgery. So we have been organizing these meetings on complications in neurosurgery, as you know, and which is why probably I have been asked to once again talk on something on complications. This is the 5th meeting, and the 6th meeting I'll go show you at the end of this projection will be in Italy next year. So CP angle houses many important structures, and vestibular schwannoma, as you know, is in this very narrow space, and therefore it is fraught with danger and not free of complications, and therefore I call vestibular schwannomas as benign tumors in a malignant location. And this paper particularly tells you that there is a very large 22% of patients had severe postoperative complications in this particular series. And those who had severe complications were those who had large tumors, who had vestibular symptoms, and lost hearing recently. So I would cover my subject on this matter by going through these points one after the other. So here, if you have a pre-op deficit in a patient, there's a great likelihood of the condition actually getting worse, though not necessarily so, but you have to be foreguarded as to how to manage the facial in a person who already has a facial deficit. But a very important thing is imaging, and all our surgery is aimed at gathering data from imaging. So here you have CT scans. Most of the people do not realize the importance of CT scan in CP angle. Everybody thinks MRI is the ultimate, but please remember, there's a lot of information you can get on bone destruction. You can see the jugular bulb over here, which is being pointed, and that shows how close it is to the canal where you're going to drill. And the case over here, you can see the jugular bulb literally pouting into the CP angle with the tumor just lying in front of it. So therefore, what you do is to depress the jugular bulb whilst you're drilling. A case in question over here is this lady who had a very high jugular bulb in an acoustic tumor, and here I am operating on this patient, and you can see as I am drilling the canal, the jugular bulb is open right over there. I quickly put some bone wax, some gel foam, and stop it. And there's no much reason to get any flustered. You continue with your operation. You put a little patch on that. And the other point was, as you can see, a very large internal auditory artery sitting right in front of that. Now, how do you know the facial nerve? Since facial nerve is the most talked about complication in vestibular schwannomas, we need to know something more about it. And DTI is one of the ways by which you can at least have an idea of where the facial nerve is located. Several papers have emerged, and you have to take the MRI in all views, the axial view, coronal, and particularly axial coronal. And several papers have shown, this is a paper from All India Institute, which shows 89% concordance with the information you can get on the DTI. And now more recently in 22, you have this Chinese paper where 93% of concordance. So DTI is an essential adjunct to understand the location of the facial nerve, which is, and that may help in dissection of the acoustic neuroma much better. Size of tumor matters. Size does matter every way. And the risk for facial nerve dysfunction in patients with tumors larger than 3 centimeters is 6-fold greater than in patients with smaller tumors, as written by Sana in 2012. And here you have a patient who has this young lady who was a model and a dancer who had a very large acoustic tumor, and she was just starting missing her steps, which is why, so then we operate on a patient. Oh, I must stop this. And then post-operative, I left a small sliver of tumor behind. So, and then you can see post-operatively, she has a mild facial paresis, but she still has preserved hearing. Position and exposure is very important, and you run through these various points of how to make the incision. So there are several positions: semi-sitting, supine, head turn, lateral park bench, half and half. Of course, you cannot do a sitting position like this where the knees are below the level of the heart. The legs have to be above the level of the heart to prevent venous air embolism. And you know the disadvantages of semi-sitting position. Though I was trained even before I went to Majid, we all used to do a semi-sitting position, but you must understand the nuances and the disadvantages of this position. So you have many people with doing this supine head turned or lateral park bench, which is my preferred position. And Imad, my friend from Saudi Arabia, has devised this half and half. It's a very nice position which compromises between the two. You, of course, will have neuromonitoring and navigation if required. And important thing is the incision. Where do you place your incision? You must understand the anatomy of these nerves. Some of these patients have severe scar pain and severe headache because of the damage or injury to these nerves. And you must know the greater or lesser occipital nerves and the auricular nerve. And therefore, the incision could be just a C-shaped incision or an S-shaped. And I will show you both the incisions over here. But you try to avoid damage to these nerves. And many of these patients do have post-operative headache because of that. Location of these junction between transverse sinus and a sigmoid sinus is paramount to your opening of the head because you have to get to the edges of these sinuses. And so I make my first burrow on the transverse sigmoid junction, and then I do a craniotomy based on that. Many people, and then of course, once you identify the sinuses, it's very easy to make a correct dural incision. So your dural incision could be a T-shaped or it could be a C-shaped curve incision. As you expose, you have bleeding from hemispheric veins and dural sinuses. Again, you have to be careful, especially if you are in a sitting position. Air embolism can occur much more commonly in retromastoid operation than in any other surgery. And here, since I choose to do craniotomy in most patients, you can have sometimes a rough weather. You might run into the sinus. No need to panic. Just put a little Surgicel or gel foam over there, and bleeding will stop quite promptly. There is no need to do anything more than that. People have tried to use flow seal, etc., but this is enough. And then you make your incision and continue with the surgery as if really nothing happened. So in large tumors, those with high intracerebral pressure, the first dural nick is over cisterna magna to allow the pressure to drop. And once this brain relaxation occurs, then the dural opening will become easier. If you open the dura in the presence of this very swollen brain, you will damage the cerebellum. So here you are. I have made a small nick in the cisterna magna, and after the cisterna magna, once the CSF is out, you always lift up the cerebellum from below upwards with a broad-based retractor. Allow CSF to drain out. Once the CSF drains out, you can see the copious amount, and now I don't need a retractor for the surgery. The cerebellum is nice and soft and pulsating, and then you can see the tumor also. In this, so you can see how here in trigeminal neuralgia or in the upper CP angle, you retract the cerebellum downwards. So that is all right as far as that operation is concerned. But for acoustics or correct way, to do for CP angle, for acoustic tumor, is to go from below. With a broad retractor, lift up the cerebellum. You can almost see the lower cranial nerves now. Allow CSF to drain out, and then you proceed with the tumor decompression. So you do that decompression by major debulking, and then a second stage by finer debulking closer to the cranial nerves. So here you can use variety of instrument, tumor forceps, CUSA, but be careful when you're using the CUSA not to lose your track of the tumor substance and not go beyond. So as you do the finer dissection, you'll come closer to the cranial nerves. So be cautious about using CUSA because it may perforate a thinned out tumor capsule and you may land up into unwanted structures. So leave a shelf of tumor capsule all around. So here you can see the facial nerve at the left corner after doing the finer dissection. Another case where I'm separating the tumor out, you can see these brainstem veins. Very careful, and you can imagine what can happen. You see, this is a patient where there was no arachnoid seen on the preoperative scan, and how the brainstem looks. It looks absolutely dead-like, cheesy. But this brainstem is still functional, and it still gives you a very good postoperative outcome. But you cannot compromise on the veins. Be careful about preserving the veins. Do not even use your sucker. Just put a patty, and that will be enough to safeguard the veins. You cannot afford to lose brainstem veins. Similarly, you can't afford to lose any other vessels. ICA. ICA is very rarely visible during your acoustic tumor surgery because it's outside the arachnoid. But ICA may send its perforators, its branches to the tumor. The tumor supply comes from ICA, and here you can see small little perforators going. But are these perforators, are these arachnoid strands? Are these vessels going to some other territory? So you have to tease them out with your forceps and make sure that you are only coagulating what is entering the tumor, and other things can be just teased away. And you can see all these ICA perforators can be pulled away very gently without sacrificing them. It's very important to note this, and therefore staying inside the arachnoid holds the key. But you must remember the trade secret. I published this long back in 1985, preservation of cranial nerves, the ultimate goal of acoustic neuroma. Tumor removal is merely a byproduct, and the principle of preservation is staying within the arachnoid. Now coming back to the earlier case which I had shown you where the internal auditory artery was standing right in front, you have to preserve it. You can see this tumor the artery is dorsal to the tumor, is facing you. Now you cannot sacrifice it because by doing so, you are sacrificing the labyrinth and the cochlea both, and even the facial nerve. So you have to work around it. Injury to these perforators can be a problem. You can see on the left-hand side, basilar artery and pontine perforators. You don't see them in your standard acoustic tumor, but that was a petroclival tumor I operated in 1988. And you can see the perforators all placed intact. But on the next side, you can see that if there's a small perforator damaged, then you can have a profound impact on the brainstem. And you can see the question here on the right-hand side, small pica perforator. This happened to me only a couple of months ago, and I was operating on a very tiny perforator from pica supplying the tumor. The tumor was going from tentorium down, and this is what the patient presented post-operatively. He had a 6th nerve, he had a 7th nerve, he had an 8th nerve, and he had even lower cranial nerves. There was immediate post-operative. Later on, after 4 months, he had fortunately recovered everything. Therefore, not a single perforator, not a single vessel can be sacrificed. I was lucky that this patient, well, the patient also was lucky that everything came back. So, preservation of veins. Now, superior petrosal vein is right up on the acoustic tumor. You should not be worried about it, but you have to keep an eye. Here I am showing you an epidermoid tumor where the petrosal nerve gets damaged, but whenever it gets damaged, it usually tears off where at the point where it enters the petrosal sinus. So that's the point where no coagulation will work. But it's always better to be aware of the petrosal vein and remain safe. Arachnoid. Arachnoid, very small. There is no arachnoid over here. As you can see, the brainstem is looking wet, very hypodense, and this is a clear sign that you are going to have some trouble separating the tumor from the brainstem, and that is paramount. You may preserve the 7th and the 8th, but if you damage the brainstem, it is of no great value. So here you can see the tumor decompression being done by using CUSA very rapidly. This is a very large tumor, giant tumor, so you have plenty of tumor to do. And then with your 2 hands, separate the tumor capsule. With one hand, with the other hand, you tease the remaining brain. And that's how it's a 2-hand technique while the assistant keeps on irrigating and sucking. A large tumor, as you can see, the meatus is very widely exposed, very widely open. Now I'm separating the tumor nicely from the cranial nerves, constantly looking for the cranial nerves. Tumor removal is a byproduct. I'm looking for the, and here you can see the brainstem, the 5th at the top, 7th and the 8th at the bottom. There's still some tumor in the widened meatus, so I'm chasing it and getting it all out, and it's a complete tumor removal, as you can see, with a good preservation of the facial nerve. You have to drill the auditory canal in every case. Very rarely you can get away with it when the tumor is entirely extracanalicular. As you know, the tumor arises from within the canal. And the way, especially when there's a large tumor, you don't even know where the meatus is. And a good way of knowing it is by seeing this tubercle line. These are the dural folds which all open up together at the internal auditory meatus. And that's the point where the acoustic tumor arises, from the canal outwards. And that's a very good, it's a very good point to know where the meatus is. But always, a large tumor has to be decompressed, made small. A small tumor has to be made still smaller. Then you approach the canal. So the canal is to be drilled by making a semicircular dural incision on top of it, take the dura away, and then start with a cutting burr to begin with, and then use a diamond burr as you come down. Formerly I used to drill all the way up to 10 millimeters, but you can get a good idea about the size of the canal when you have seen the CT scan, even on the MRI. And then you ease the tumor out from the canal very nicely, and you can see the 7th and the 8th. All of you know the location of the 7th nerve is at the top end, cochlear is the lower end, and facing you is the vestibular vesicles, superior and inferior, and you can see the 7th and the 8th, both very well preserved in this tumor. And you don't drill way away, just drill up to 7 millimeters. And be careful when you are drilling, leave no cotton patty nearby. If you have a cotton patty nearby, this is what you're going to have. So be careful, and the cotton patty can get stuck into your drill and can have a devastating effect. So please keep all the cottons away when you're drilling. All right. So that's the anatomy, where you have the Bill's bar vertically going down, and you have the horizontal crest, and the 7th and the 8th now anatomy you know very well inside the canal, so that you can locate it. Once you expose the canal, you put a hook, open the dura, slit it all the way until you see the tumor end, and then you can deliver it either with a hook or with a tumor forceps, or if you have got a very elegant thin CUSA, you can use that. And this was the lady where we had some tumor left behind, so its excision of tumor is not complete until you look at the fundus. And now the way to do that is to see through an endoscope. So here you are drilling it away, and now you're using an endoscope. This was a patient on whom I had to operate for a recurrent tumor about 15 years ago, and we used the endoscope to locate that tumor way away into the fundus of the canal. So microscope vision is like this. It doesn't give you the obliquity which the endoscope view does. Okay, having delivered the tumor away from the canal, you get it out up to the porus. The maximum adherent point of the tumor with the 7th nerve is 7 millimeters or 5 millimeters outside the porus acousticus. That's the place where you stop dissecting. And then you start coming from the brainstem up towards the same area. So sometimes varying amounts of tumor may be left behind for a variety of reasons in this schwannoma surgery, sometimes deliberately, sometimes inadvertently. In 1989, I happened to operate on this lady, and these are the slides. Actually, I did not have a video of that patient. So this was the 1989 complete operated tumor, total removal. And here, shall I stop? If you want me to stop, I can stop here. I have no problem. So there's a facial nerve. And immediate post-op, there was a mild paresis. 20 years later, she came back with some tinnitus, and there was a little tumor growth. So obviously, I had not seen that part of the tumor, probably because I didn't have the MRI at that time to see, nor did I have an endoscope to see. So, but you have to keep on following these tumors. This gentleman had a moderate-sized tumor, which we removed. He had a facial palsy for almost 6 months, but I was very sure that we had removed it completely without damaging the nerve morphologically. And true enough, a couple of years later, when he came for a follow-up, he had a reasonably good facial recovery. So lower nerve injuries, of course, are more devastating. You would rarely have a problem with them because you are lifting the tumor away from the lower nerves. And therefore, okay. So tumors can be solid, cystic, and cystic tumors can appear very simple on the scan, but they can be very devastating. They can be very, very adherent. They have good hearing, frequently, but the problem is how to separate them, and the surgical outcome in cystic tumors, as you can see in this paper, also very complicated. So here we have a cystic tumor, removing it, opening the cyst, start searching for the nerves. Always decompress and then look out for the nerves. Tumor removal is a byproduct. Get the tumor fragments out, looking for the nerves. And here you can see everything out, 7th nerve preserved, 8th nerve preserved. Fortunately, in this case, the cystic capsule was not too adherent, and I could preserve everything over there, and the patient had good hearing post-operatively also. That was 24 hours after surgery, and that was another cystic tumor. And post-radiation, I will not waste your time, because post-radiation also, this is a patient who had underwent cyberknife. Cyberknife has a greater amount of damage to the surrounding nerves, and then to operate on this tumor is a very big problem. But still, we had some problem with the facial nerve dissection, but immediately, but post-operatively, later on, he recovered fully. So, and this is another example of radiosurgery, a Telangana minister who did not want surgery and had these devastating effects. Okay, so we have mortality in more than 1,100 patients, 0% mortality in our cases. But then there are complications, as you can see. Some are early, some are late complications. I've had all grades of facial palsy in my series, and some CSF rhinorrhea is another issue. Most of the time, the problem is because we have left some bony cells unplugged. So please plug them. This was a patient where we had to reoperate in order to stop that. Quality of life and ICCN. We have had all these discussions on complications. 4th nerve, 4th, 5th, 6th, and now the 6th. We have published 2 books on complications now, and the 6th ICCN is going to be in Italy, in Northeast, in next year, 2026. Thank you very much for your attention. Thank you.
Thank you, Dr. Turrell, for your talk.
Sorry for overstepping my time.
We come to the last talk of the session. I would like to invite Dr. Ravi Mohan Rao for his talk on microsurgery of brainstem cavernomas.
Coming. Good morning. I thank Professor Siddharth Ghosh for his very kind invitation. I'm privileged and honored to be here today presenting my talk on brainstem cavernomas. I'm very fortunate that my mentors are sitting in the audience, Professor Suresh Nayak, Professor Mishra, Professor Atul Goyal, and Professor K.K. Turrell. I have been following their words of wisdom publications for a very, very long time now, and has helped me immensely. And we are in this beautiful setting, meeting all our seniors. So the first patient is a lady who presented with 10 days history of a squint of the left eye with facial deviation to the right side, transient difficulty in swallowing and nasal regurgitation, imbalance while walking and intermittent vomiting. She was alert with left element facial palsy, left 6th nerve palsy, normal lower cranial nerves and normal power in her lower limbs. So this is the 6th and 7th nerve palsies, which were the sole deficits at the time of examination in the outpatient department. And this is the MRI scan, the T1, the T2 weighted images, which show a lesion in the medulla with a bleed extending into the pons, posteriorly and superiorly. So you see this lesion here in the medulla, the olive of the medulla, with the bleed extending into the pons posteriorly towards the 4th ventricle. And these are more images, flare, swan, and this is the pyramid of the left side, right side, this is the olive, and the lesion is situated in the olive of the medulla. She had recurring six nerve palsies, so even in 2021, she had presented with left medial rectus palsy, was seen in Ophthalmology Institute in Bangalore and given Botox injections. So this is the anatomy of the medulla at the level of the olive. The 12th nerve emerges between the pyramid and the olive, and the lower cranial nerves, 9th, 10th, emerge behind the olive in the retroolivary sulcus. So the principles of brainstem cavernoma surgery are do the surgery when the lesion does the talking. So this lesion has been talking since 2021, and at this presentation, the pons is talking and the medulla whispered with a very transient lower cranial nerve dysfunction. The other principle is build the approach from inside out, and when planning on the navigation, I decided on the far lateral approach would give direct access to the olive, where the olive is in front of the lower cranial nerves. So these are the safe entry zones. There are ventral safe entry zones, lateral safe entry zones. This is the olivary zone, which was used in this case, and the posterior zones, both for all for the midbrain, pons, and medulla. So this was the navigation which was used for planning. A park bench patient was used with IONM. And this is the condyle, the lateral mass, this is the vertebral artery exposed, and the C1. So the suboccipital craniotomy and partial resection of the condyle, less than 1/3 of the posterior 1/3 of the condyle was used. And this is the video. So the primary fissure of the cerebellum was dissected, like opening the Sylvian fissure to reach the peritrigeminal zone, which was normal. But there was discoloration of the olive. These are the lower cranial nerves. I'm sorry. So these are the lower cranial nerves. And this is the olive with discoloration. So when a lesion has come up to the pial surface, it becomes easy to select the point of entry into the brainstem. So you see the discoloration here, the pial incision is being given. And then with microforceps, the lesion is removed in a piecemeal fashion. So this is the cavernoma which is held in the forceps and being dissected. One more rule in brainstem surgery is don't take out the hemosiderin ring, just take out the cavernoma. Unlike in cerebral cavernomas presenting with epilepsy, where you may have to remove the hemosiderin ring. So that's the last portion of the cavernoma coming out. So the surrounding hemosiderin was left behind. The problem I faced in this case was the MEP and SSAP flattened during the surgery. So I was very worried. This is the SSAP baseline and this is the SSAP post-resection. But the patient was extubated the next day The lower cranial nerves was normal, and the patient was able to walk. And this is the post-op MRI, which shows excision of the cavernoma with the resolution of the pontine hemorrhage. And her sixth nerve was persistent post-op, along with facial palsy. And there's follow-up after 1 month and follow-up after 2 months. So this is a case of a midbrain cavernoma. The patient was a documentary filmmaker who presented with double vision and drooping of the right eyelid, which made camera work for her impossible. This is the bleed seen in the midbrain. So you see the cavernoma in the tectum, pericollicular region. So done in a sitting position with monitoring of third, fourth, sixth cranial nerves, with brainstem triggered EMG, and of course navigation guidance. An occipital transtentorial approach was used. The tent is being cut. You see the arachnoid of the quadrigeminal cistern is opaque and tough. So this is the arachnoid being dissected. So a very good dissection of the arachnoid is essential to see the tectum. And then sure enough, there was discoloration of the tectum, which marked the presence of the cavernoma. So a small incision into the midbrain was made at that level. And the same principles were followed: piecemeal removal, mobilization of the cavernoma, leaving the hemosiderin ring intact. So this is the cavernoma, grasping it and with slight traction, removing it in a piecemeal fashion. So I'm almost finished. So this is the cavernoma which is coming out. This is the last bit of the cavernoma. And this is after the removal of the cavernoma. no attempt is made to dissect the wall of the hematoma, and this is the post-op MRI. Immediately post-op, 1 month post-op, her doses improved, but she had medial restriction of the eyeball. 4 months post-op, most of the eye movement abnormality had vanished, and she could resume her work as a filmmaker. So thank you very much.
Thank you, Dr. Rao, for your talk. I would like to invite the moderator, Dr. Vernon Velho, to share his insights.
Well, it was a good session, and we have almost covered everything on vestibular schwannomas. And to start with Dr. Sukhdeep, who gave a wonderful 3D demonstration, and congratulations to you and Abida, who are doing a very good job. And you're sort of the neurosurgeon anatomists of our country. So keep it going, and it's not easy to do 3D slides, and it takes a lot of hard disk space. I know myself, because it fills the hard disks, and you're doing a good job. And what I want to comment is the CP angle is a 3D space. It's a 3D box which you have to understand properly. And when we are operating on tumors, mostly the anatomy is distorted. You won't find the normal anatomy. You have to search for the normal anatomy. And if you have, for the students, if you have that 3D image in your mind, that's how you have to go about when you're operating on CP angles, tumors especially. The second speaker was Dr. James Joss. He showed us something about the CP angle syndrome. But my question to you, Dr. Joss, is what is the classical syndrome, the classical CP angle syndrome? Because if a syndrome should have 2 or 3 classical features. So what would you put as the classical syndrome?
The classical syndrome consists of a 8th nerve problem, sensory neural deafness. The second problem will be those with the trigeminal nerve dysfunction, especially sensory dysfunction, followed by motor dysfunction. And the third component will be cerebellar.
Yeah, because the trigeminal nerve will be involved pretty late.
Late.
That's why.
Late.
And you got to have a tumor which is more than 3.5 to 4 centimeters.
So
that
8th
is why I
nerve,
was asking.
cerebellum, as well as the trigeminal nerve. When these combinations are coming, the possibility that it's likely to be a classical CP angle problem. As you have said, facial nerve involvement is rather unusual and very late, as well as brainstem compression and pyramidal signs, hydrocephalus, they all come late. So whenever you see a patient with a deafness, and if he has got a cerebellar signs ipsilaterally, and if you see that the coronary reflex is sluggish, that is the reflex which is affected very early, even without the evidence of other paresthesia and other things.
Yeah, I'm still confused about that, because those are not the early signs, they are the later signs. I think Suresh, Professor Suresh, you want to comment on this? Because the students should get a proper message.
I think James has told, but as he told correctly, first is hearing loss. Hearing loss, there are ways to find out whether it is conduction, sensory neural like that. This time I won't waste for teaching you all that. But other than that, fifth nerve motor hardly ever comes. If you suspect a fifth nerve motor in a CP angle syndrome, put it to Meckel's cave. So otherwise, motor symptoms, sensory, as James told, it's an early symptom, then disequilibrium. Disequilibrium, it could be from any of the things, brainstem compression or cerebellum. So I tell students, because 7th nerve, as he correctly told, large lesions, unless it is a cystic schwannoma. Cystic lesions will come with overt facial weakness. Otherwise, facial weakness is very unusual as a early presentation, only towards the end. Exception is cystic tumors. Otherwise, hearing loss. It is classical, retro, what is that? Hearing apparatus, what do you call? Retro? Retrocochlear sensory neural hearing loss with disequilibrium could be from brainstem compression or cerebellum with fifth nerve sensory symptoms. And facial nerve is last to come. Lower cranial nerve is last to come.
I just want one difference with Dr. Jose said. Dr. Jose said, if you have a seventh nerve, don't call it CP angle syndrome. I don't think that's correct. You don't say it's a vestibular schwannoma. Seventh nerve involvement early in CP angle tumors is an epidermoid, is a classical thing. So it's still a CP angle syndrome. And I think he's right about the the fifth nerve sensory component is quite early. It doesn't have to be a giant tumor. It's a very sensitive nerve. So hearing, after hearing, in fact, if you see the largest, earlier series from House Group, the first was hearing and the second was this fifth sensory actually. So it doesn't have to be a giant tumor for a fifth motor like Suresh said. Fifth motor is very, very unusual. But just one point you made, if you see facial nerve paresis, don't call it CP angle syndrome. I think you need to change that because a rapid is, don't change it to not a vestibular schwannoma. That's about it. But it's still a CP angle syndrome.
Somebody
exactly that I meant.
Having a seventh nerve, lower motor seventh nerve, you should always think about a seventh nerve.
Seventh nerve, exactly.
Seventh nerve tumor. Seventh nerve schwannoma is another thing which
exactly.
you always consider about seventh nerve tumor.
That's for residents sitting here. Say if suppose somebody comes with hearing loss, facial weakness, then sixth nerve loss, and also some disequilibrium and all. Say you should think of 3 locations. All are different locations. One is CP angle. Other is brainstem. I will tell you how to pick up. Other is Meckel's cave. Meckel's cave produces hearing loss with the involvement of cochlea nearby GSP, and that is how they produce seventh facial weakness and hearing loss, not from proper nerve involvement. Then fifth is the conduction deafness. Fifth is very near, and superior cerebellar peduncle can get involved. CP angle, all of us know. Brainstem 5, 6, 7, 8 can come there. Catch, I will tell you. As James correctly told, suppose something is in the brainstem, hydrocephalus is hardly, and he told IONM and all. But the thing is taste. Say, if it is an angle, taste will always go. If it is the brainstem, seventh is involved, taste will be spared. It is different nucleus. Then something which I think James, seventh, seventh, you have a ipsilateral seventh with a contralateral UMN 7. That is classical of Pons involvement. Because, the descending fiber to the contralateral lower half, it comes from one side and then crosses low up in the middle and ascends up. So you carefully look, suppose somebody has a fifth, sixth will come, they will have a contralateral UMN 7. Eighth, even though people tell, will not occur for brainstem lesion, they can have some hearing symptoms. Yeah. So everything can occur. Sixth with 7, everything can occur. Yeah. What is that? Yeah, correct. But I'll tell you. Say, for someone to hear 2 sounds simultaneously from either side, you require something in the brainstem also. Understand? That is the thing. Say,
I think we will have to go to the next, because of the want of time.
Yeah. You require brainstem involved. If it is affected, you will not. You will not get
I think Professor Mishra has shown us the
some hearing affection
beautiful techniques of how to preserve the facial nerve and how to preserve the auditory nerve and the cochlear nerve. Just one question for you, sir, is after preserving the cochlear nerve, suppose the patient complains of tinnitus, what was the treatment?
Yeah.
We have patients like that.
No, that's a problem. I have no treatment. I send them to ENT guys, and in fact, every single patient, before the patient goes for surgery, if they have presented with tinnitus, even otherwise, we say that I have no treatment for tinnitus. You can do all other things like masking device and all those things, but we warn them before. And I have never had a patient, some people say that you go and cut the eighth nerve. I have never had that necessity to do it. And they, over a period of time, they get used to it. Eighth nerve tinnitus, they never, they say that is fine, I mean, it's bad, but they never come to a stage where they have committed suicide. Some people overdo it. I don't think that's been a problem. But I have not.
No, it's pretty bothering, but it is bothering.
Just tell you, say if you do a good surgery, say some people tell that tinnitus is there, then the surgeon to tell, I have preserved the eighth nerve. It is not correct. Even if you cut the eighth nerve, also tinnitus may persist because it is because of cortical deafferentation. So it is something like phantom limb. So even if you cut the eighth nerve, there tinnitus may not go because of this cortical deafferentation. It is because cortex plays there. So it is a very tricky thing. Treatment is extremely difficult.
Okay, thank you. Professor Hasegawa has shown us some good videos about how to approach to the transnasal route, but I think whatever was shown more in the midline, more of midline tumors, and which have, where the tumors have created a space to go to the lateral aspect, but I don't know, for pure lateral, he still, I think, advocates the transpetrosal. And then coming to Manjul Tripathi, who has told us the role of SRS. What about tumors which are recurrent tumors and they are adherent to the brainstem? What would you do?
So whenever we are going to speak on an SRS for a recurrent tumor or a residual tumor which is attached to the brainstem, these tumors, we can make out a boundary between the tumor and the surrounding structures. And if you are able to make out a boundary, you are very safe with the gamma knife radiosurgery.
If there is no boundary?
Even if there is no boundary, there would be a contrast enhancing area. And you can make out, looking at different sequences, T1, T2, contrast, these three basic sequences are good enough to know where does your tumor exactly ends and your surrounding tissue starts. And with the sharp dose fallout, you can keep a radiation delivery to your tumor while sparing your neurovascular neighborhood, so that doesn't become a problem over there. The dose, the tolerance dose for brainstem is around 12 gray. The prescription dose for a vestibular schwannoma is also 12 to 13 gray. With this sharp dose fallout, your brainstem is always secured in those cases. And still you are able to deliver the required radiation to the tumor, so you do not create any trouble over there.
Thank you, thank you.
If I can just add one comment to that tinnitus part, I just tell the people that tinnitus is the sound of the brain, it's not the sound of the ear.
No, but telling is different and the patient suffering it is different, let me tell you.
There is no, yeah, I agree, but there is no answer with anybody. Even the guys have tried DBS also for doing for the tinnitus in their trials and they have failed. So the white noise and other behavioral therapies are probably the answer over there. Yeah.
Sorry for coming back to this question. Sir, what is your experience on utilizing a translabyrinthine approach to these tumors? Because those who do both, they have seen that the translabyrinthine approach leads to lesser complication of tinnitus by dint of destruction of the auditory pathway. So as long as the tinnitus is not because of central adaptation, it is because of this, then translab approach makes a point here.
Yeah, how do you know it is not because of central? I mean, every patient has a central connection. Yeah, yes. See, we do much less translab now. When I started my skull-based surgery in the 80s, almost every single case used to have got a dedicated skull-base, transbasal, translab, transpetrosal, all that, which we have gone away from it. Acoustic, I don't think there is any logic behind doing it. If you are not, if you're doing along with a ENT colleague or a ENT colleague is doing it, is good for him because he's not familiar with a subarachnoid system manipulation. But if you're a neurosurgeon, you should be competent enough to manipulate the subarachnoid space. If this is a tumor going into the subarachnoid space, and when you're going from translab, you take time of doing the lab technique, translab technique, and then the last part you see the nerves. Whereas you want to a small tumor, you go, if you want to do something else, do a middle fossa approach. But all sizes tumor, straight from intracornicular to small to large to giant, can be taken by one approach. So is it not logical to be a specialist in one approach and try to take it out? And when you can preserve hearing, you can have everything. The only problem is, only criticism was the risk of having headache was more, and the risk of, which you have gone away from that by putting the bone back. So I don't think there is any logic in my mind to do a translab approach.
So my question was in terms of reduction of post-op tinnitus.
Well, there is no
No, I think it's important. It's important to counsel the patient about this. We counsel the patient about the facial nerve, but we do not counsel the patient about tinnitus, which can happen.
Vernon, the present, one of the concept is it is not, any stimulus coming through any sensory nerve can bombard the dorsal cochlear nucleus. And it sends what he was telling, Manjul was telling, it projects it to the central areas. And that is one of the causes of this persistent stimulus.
Thank you, thank you. The next speaker was Professor Thurel. Only one question. Professor Thurel, suppose you have done everything and just before you start going on the tumor, the cerebellum comes out at you. What would be your strategy?
If you have a mic, can I have a mic? You don't need a mic. Why are you keeping the mic? You don't need a mic. Okay. Yes, if the brain bulges, the first thing that you have to do is to go down to the cisterna magna.
No, you have done all that. You have done all that.
Yeah, if your patient already has hydrocephalus, then you should have had a burr hole.
Done all that. Still the cerebellum is coming out.
Check the neck. Ask the anesthetist to find out whether your CO2 and everything else is okay. And most likely there could be an endotracheal tube in kinking. So please check. At the same time, whilst you are checking your parameters, the anesthetist has to check her or his parameters to find out if there is any intubation problem. And if the tube is cooked, normally we use an armor tube, which doesn't go into a kink. But if you are not using an armor tube, then you will face this problem.
I think there is an option also for going in the second time. You wait. You can just hold on.
I tell you, the anesthetist should
hold on and then go in on another day when the day is right. So that is what we do sometimes. Okay, my last question to Dr. Ravi is, cavernomas are easy when there is a bleed. What about cavernomas which have not bled? What would be your strategy?
You mean asymptomatic
it's
cavernoma?
Easy to identify, no, not an asymptomatic. A symptomatic where the cavernoma has not bled, it becomes very difficult for you to find your topectomy area. If you do not have that, hemosiderin around, it becomes very difficult to identify. And if your navigation...
Most of the cavernomas in the brainstem become symptomatic by microbleeds.
Yeah.
Without a bleed, they don't become symptomatic.
So an asymptomatic one you wouldn't touch?
No, that's for observation.
Okay, thank you. Thank you all.
So may I just comment on that? There is no such entity as an unbled cavernoma. There is no radiological signature of a cavernoma if it has not bled. Because cavernomas are visible just because of their hemosiderin.
So you will not see a cavernoma if it has not bled?
You can't see it because it's only the hemosiderin and the different stages of the blood which can show that there is a cavernoma. There is no other telltale sign.
No, I think there are classical features of a cavernoma on MRI. Any radiologists around? They will tell you.
No, if you identify it with the hemosiderin, that means it has blood.
If there is a hemosiderin, it has bled. It has bled either remotely, subclinically, without any other clinical evidence, but it has bled. So there is...
Yes. Also there are cavernomas which can be diagnosed by MRI.
So without hemosiderin, there is no radiological signature. We go for the SWI for looking at these cavernomas. On SWI, a cavernoma is visible because it has bled sometime earlier, remotely. So there is no T1, T2 appearance of an unbled cavernoma if it has not bled.
Okay, we'll discuss it at T if there is a T.
If we can just ask one question to Dr. Ravi. Sir, if you find a DVA associated with that cavernoma, how do you handle that DVA? Whether you occlude that, you leave it there, how?
I think that has to be preserved. Yeah. If you have a venous anomaly, it has to be preserved. You can't sacrifice it.
And in most of your cases, the cavernoma is actually coming to the pile surface, and those are actually the best cavernomas to operate.
Correct.
But many a times you find exactly sitting in the middle of the brainstem. In those places, you do not find any good corridor. In those cases, actually, your aim is to prevent any episode of a rebleed again. And in that scenario, radiosurgery gives a very good response in these patients.
I agree that if it's deep within the brainstem, then approach becomes difficult and the possibility of causing deficits raise exponentially.
That should have symptomatic or asymptomatic.
We will now have a short tea break.
Asymptomatic could be diagnosed for in any other region. You are doing a CP angle tumor, acoustic, the coincidenting cavernous somewhere. First cavernous I operated in 1983, the coincidental in temporal lobe. So it is possible to have a cavernous which are asymptomatic.
Sir, it could be asymptomatic,
okay.
but
Second
it would
thing,
have blood.
First time I read in 1993, cavernous giving radiosurgery in a child nervous system. When I talked to Kale, he was not agreeing. But now we have largest series of cavernous giving radiosurgery. If anybody from AIMS, it must be more than 150. So it is bled or no bled or waiting for bleeding, it will be stupid. If it has bled, wait for 3 months, let the blood get absorbed, go for radiosurgery. Because when the blood is there, you will not be able to know how much area we are going to give. I think.
I just want to make a comment. We don't do radiosurgery for cavernous, period. In my practice of 30 years now, we have not given a single patient of cavernous radiosurgery. So this is a very controversial thing. Not that there is no data available. What Manjul said, there is enough data available. The Pittsburgh
surgeon
group,
always want to operate
the Austrian
because he
group,
makes money.
Austrian group and Pittsburgh group, they have data, but the data on completely on the other side, saying that there is no evidence to suggest
it is available on the literature. It's
I
all
want to
available
introduce
in the
to you
what is
Ramamurthy sign. Do you know, guys, what is Ramamurthy? Where is
We have a
Anil?
short tea break. Please be back by
Arey,
11:45 for the next session.
Ramamurthy sign, Anil, you know Ramamurthy sign? In acoustic tumors, in large acoustic tumor, infrequent blinking. Infrequent blinking is an early sign, and this was demonstrated by Ramamurthy, and I just, Anil, for your information.
Hello. Orange. Okay. Okay. Orange. Okay, okay, yeah. This is one for you. All right. If anyone asks you for mine, I'll just direct them. Yeah. Welcome back for the next session. We'll start off with a session on glioma, and I would request all speakers to please stick to their allotted time to ensure a smooth session. I would like to invite Dr. Abida Shah and Dr. Sukhdeep Jawar for their presentation on anatomy of cerebral hemisphere.
So, good afternoon, everybody. So, let us start with the intrinsic anatomy of the brain. And for that, we will start with the cerebral hemispheres. So, this is the brain as it sits on the skull base, anterior cranial fossa and middle cranial fossa. I request everyone to wear their 3D glasses. So, this is the cerebral hemisphere as it sits on the skull base. To study the brain can be divided into 7 lobes. So, this is the frontal lobe. This is the central lobe, this is the parietal lobe, this is the occipital lobe, this is the temporal lobe. Hidden within this is the hidden lobe of the insula, and on the medial surface of the brain is the limbic lobe. So quickly let us see all these lobes one by one. So this is the naked brain with the pia removed. So now this is the frontal view. You can see here, first you have to identify the central sulcus here. This one is the precentral gyrus. So the boundaries of the frontal lobe are till the precentral gyrus. Then you have two sulci here, that is the superior frontal and the inferior frontal sulci, which divides the frontal lobe into the superior, middle, and inferior frontal gyri. The important point of the superior frontal gyrus is this portion of the superior frontal gyrus. Right in front of the precentral sulcus is the supplementary motor area. The middle frontal gyrus, where it joins the precentral gyrus, is the area of the frontal eye fields. Then going on the lateral surface, so here again you see the central sulcus. You see how it is, how the pre and the post-central gyri are connecting here to form the subcentral gyrus. So this is the central lobe of the brain. This one is the precentral sulcus. So now you see very nicely how the middle frontal gyrus has this robust connection with the middle frontal gyrus. So this is the frontal eye field. Then you have the inferior frontal gyrus, which has 3 parts. These are the pars orbitalis, the pars triangularis, and the pars opercularis. I will show you in a better image. So now you can see this is the central lobe of the brain. So the central lobe is consisting of the pre and the post central gyri, which meet here superiorly as the superior-olandic point and inferiorly in the region of the subcentral gyrus at the inferior-olandic point. Now you see the inferior frontal gyrus orientation much better here. So now you see this is the pars orbitalis. Then you see this structure here. So it is a triangular shaped gyrus which is pulled up into the sylvian fissure. This is the pars triangularis. Now you see this point here where this is a dilatation in the sylvian fissure. This is the anterior sylvian point. This is very, very constantly present. Now this U-shaped gyrus which connects the inferior frontal gyrus to the precentral gyrus is the pars opercularis. Now this whole area of the pars triangularis and the pars opercularis is the Broca's area. And this is the area when you stimulate, you get speech arrest. So this is an important landmark during surgery. Then this is the subcentral gyrus, and as you can see here, it sits on the planum temporal of the superior temporal gyrus, and it sits right on the Heschel's gyrus, so in the auditory area. Coming to the temporal lobe, this is the superior, middle and inferior temporal gyri separated by the superior and inferior temporal sulcus. If you see this, the superior and the inferior temporal gyri meet at the temporal pole. The middle temporal gyrus never goes up to the temporal pole. The Sylvian fissure ends in the supramarginal gyrus. The superior temporal sulcus ends in the angular gyrus. Here behind the postcentral gyrus, you will have the interparietal sulcus of Jensen, which divides the parietal lobe into the superior and inferior parietal lobules. This is the posterior view of the brain, and you see this is the occipital lobe, and these are the cerebellar hemispheres. The occipital lobe has a little varied anatomy, where you have the superior, middle and inferior occipital gyri separated by the superior and inferior occipital sulcus. The superior occipital sulcus is a continuation of the interparietal sulcus of Jensen. So sometimes there are 3 gyri, sometimes there are 2 gyri. This is the region of the parieto-occipital arcus, where the parieto-occipital sulcus comes up onto the superior surface. So now this is with the craniometric points. You see the coronal suture here, lying in front of the motor area. Here you see the venous anatomy. Now here there are some important landmarks. So where the precentral sulcus meets the superior frontal sulcus meets the precentral gyrus, this is the region of your hand motor activation area. It lies about 1.5 centimeter posteriorly and 3 centimeter laterally to the bregma. This is the point, that is the superior Rolandic point, which comes on where the pre and the postcentral gyri meet. Posteriorly, this is an important landmark. The angle between the sagittal and the lambdoid suture is the region of the parieto-occipital sulcus ending or the parieto-occipital arcus. That is an important landmark that you should remember during surgery. So coming back to the lateral surface, we have already done this. Now coming to the medial surface of the hemisphere, the most important structure that you see here is the corpus callosum. As you can see here, running across the middle surface. This one is the cingulate gyrus, which starts here in the subcallosal area and goes all the way down. So the cingulate gyrus continues here as the parahippocampal gyrus. The other gyrus, this is the lingual gyrus, also continues here as the parahippocampal gyrus. So it has 2 offshoots here. And then the parahippocampal gyrus turns and becomes the hippocampus, as we'll see in few other slides. This is the medial portion of the superior frontal gyrus. This is the paracentral lobule. This is the precuneus. Here you see the parieto-occipital fissure, then the calcarine sulcus. Now you see, as I was telling you, the subcentral gyrus sits here on the auditory area or the Heschel's gyrus. Now here you see the relation of the gyri to the ventricles. So here you see the hippocampus in the temporal horn, which is easily accessed beautifully by this middle temporal gyrus. The other parts of the insula I will discuss in the region of the insula. Now coming on the inferior surface, so here you see the parahippocampal gyrus. This is the region of the uncus. The anterior part of the uncus corresponds to the amygdala. The posterior part of the uncus corresponds to the parahippocampal gyrus. This portion of the brain is the entorhinal area. Here you see the rhinal sulcus. So the part that is medial to the rhinal sulcus is the entorhinal area. Coming down here, now you see the close relation of the uncus to the cerebral peduncle. This is the oculomotor nerve as it is coming out from the oculomotor fissure. Here you see the other parts of the brainstem, which is not today's discussion. The inferior surface of the frontal lobe, this is the most important landmark. The cruciform sulcus of Rolando, which is H-shaped. It is dividing the orbital gyri into the medial, anterior, posterior, and lateral orbital gyri. This is the gyrus rectus. This is the region where the olfactory tract runs. Coming more inferiorly, so this, the parahippocampal gyrus we've already seen. This is the collateral sulcus or the lateral temporo-occipital sulcus. This is the fusiform gyrus. This is the inferior temporal gyrus. The inferior occipital gyrus continues here into the inferior temporal gyrus. Now this is the region of the anterior perforated substance here, where you see, this is the region of the anterior perforated substance. So now the base of the brain, the frontal and the temporal regions are connected, and we'll see all these connections by fiber dissection. So now this is the anterior perforated substance lying between the medial and the lateral olfactory striae. If you see, this is the posterior medial orbital lobule. It sits like a hat on this region of the anterior perforated substance. So this is the new amygdala. The amygdala has beautiful connections to this medial olfactory region or the septal region and to the brainstem by the ventral amygdofugal pathways. And here you have one connection called the diagonal band of Broca. Now we've seen the surface anatomy or the cortical surface. Subcortically, there are various fibers that will come into play. So this is the short arcuate fibers which are seen when the cortical gray is removed. The first fiber bundles that come on the lateral surface here is the SLF, the superior longitudinal fasciculus, and this one is the arcuate fasciculus. Here you see the insula. This one that you see is the middle longitudinal fasciculus, and here down is the inferior longitudinal fasciculus. Going deeper, I've removed the gray matter of the insula. You see the extreme capsule. Now you can see the shape of the arcuate fasciculus coming into play. The other tracks I will discuss in the insular presentation, but just to give you an orientation, this is the arcuate fasciculus, this is the uncinate, this is the IFOF, and this we will see later. These are the U fibers or the short arcuate fibers that will be seen as a superficial layer. Medially, the most important lobe is the limbic lobe. Now all the structures of the limbic system run in this C-shaped manner around this region of the thalamus and brainstem, and it is called limbus because it means border or a ring. So now first, this is the cingulum. The first layer, you see the cingulum arising here on the superior surface and coming down here to end in the entorhinal area as the radiation of the cingulum. It connects with the precuneus with the superior frontal gyrus by persistent connections. Coming to the limbic system, so here you see the radiation of the cingulum ending here. This is the corpus callosum, and we'll start dissecting in this region now quickly. So the short arcuate fibers are dissected first. Then you go further in this region of the medial temporal area. Now you see the hippocampus here very nicely lying here. So this anatomy of the hippocampus is just a very beautiful thing. Maybe we can show in the epilepsy presentation. So here you see the fornix as it is coming. It comes on from the fimbria on the layer of the hippocampus, turns here, becomes the crura, and then becomes the columns of the fornix to end here in the mammillary body. It gives out an offshoot in front of the anterior commissure, that is the precommissural fornix, and this is the postcommissural fornix. When you dissect further here, you will see there is a tract that is coming out here from the mammillary body, and that is the mammillothalamic tract as it goes here in the anterior nucleus of the thalamus. Here you can see the tract very nicely. Here it gives another offshoot, that is the mammallotegmental tract. Now you see this is through the foramen of Monro that we are passing through. This probe is in the foramen of Monro. Now, when you dissect all the layers in this region, you will see this structure. So when you come from laterally, internal capsule is the last thing. When you come from medially, it is the thalamic radiations. So you have the superior, the anterior, superior, posterior, and inferior thalamic radiations. This is a closer view of the thalamic radiations as they curve along the lateral ventricle. When you remove the ependyma, you will see them. So I think this image is a little distorted. This is the whole Pape circuit actually, which has been dissected out. And here you can see how beautiful this hippocampus is. So the limbic system, actually there is a circuit that turns like this, which we will see later. There is a circuit that goes above the corpus callosum and comes here to end in the subcallosal region. So there are 4 or 5 limbic circuits that are important to understand anatomically. Lastly, the corpus callosum, the commissure of the brain. It is a fascinating structure, and it has dorsal, anterior, posterior, and ventral callosal radiations. So you can see this image, and this is how it goes. These are the dorsal callosal radiations. This is the forceps major. This is the forceps minor. And this is the inferior view of the corpus callosum. Here you can see again the uncus with the amygdala and the hippocampus. This is the ependyme of the temporal horn. This is the splenium of the corpus callosum. Here you can see the hippocampal commissure as it lies just beneath the splenium that has been dissected. And this is the, again, ventral, sagittal view of the brain with some of the fibers dissected. I think we won't have time for this. But again, here you can see all the fibers of the limbic system, which I had shown yesterday. So the Pape circuit is component of the fornix and the mammillothalamic tract. This is a tract that is the stria medullaris thalami. It originates here in the septal region, goes and connects to the habenular nuclei here, then decussates here in the habenular commissure, and then goes down with the MLF and the medial, the fasciculi of the brainstem. Here you see the pineal body, and with that I'll end my presentation. Thank you very much.
Thank you, Dr. Shah, for your talk. Next, I would like to invite Dr. Adityan for his talk on awake craniotomy, role of fMRI and DTI.
Once again, I thank Dr. Siddharth Ghosh sir for giving this opportunity. In this presentation, I'm talking about the DTA, resting state fMRI, task-based fMRI. By cases based, this is one of the case. This 24 years female with IIT student with history of multiple episodes of seizures. Initial craniotomy was done elsewhere and it was for radiotherapy. But there was a large residual lesion noted in the insular region frontal lobe with focal perfusion indicating high-grade tumor. In this case, quantum-like protocol with diffusion with eye directions and DTA was done. We can get different networks like sensory motor, language, and other cognitive networks we can get. In this case, we did a task-based fMRI as well as connectome. You can see the language areas, Broca's, Wernicke's, and other supplementary language areas. And almost the task-based fMRI, the connectome, we can match the similar signals we are able to get. But the laterality can be better assessed by the task-based fMRI. In this case, other the cognition networks like salience, central executive curve, and this is the important network tract is the frontal astellang tract. The closeness of the cognitive networks and the tract near to the lesion can be well seen. This case, this is the final output of all the network connection to the tumor, and this is the arcuate fasciculus, and relation to the tumors is very close. And this is the corticospinal tract course. And this case, this is a pre-surgery, and after surgery, the lesion was almost completely removed. In this case, this terms and task-based fMRI and DTA as a help for the pre-surgery counseling of the patient. Since the patient is IIT student, the cognition and other intellectual language is very important. And also help for near total excision. The post-operative time can be reduced. The background history of seizures, patient having seizures, the intra-op awake anatomy must have produced more operative time, and seizures may be there. And cognitive networks was well seen in this case, and language laterality also can be assessed. And coming to the insulo-sylvian gliomas, many of these insulo-sylvian the cognition is affected because of non-traditional. We want to assess many of the cognition pathways, and this side, many of the patients who have cognition will be affected. And in this case, the terms are resting state-based fMRI, cognition will be much useful. With the awake anatomy, the complex cognitive psychomotor function is very challenging to assess. Currently, most of them are for language and motor functions with less emphasis on cognitive domains. And sometimes there was up to 20% there is a probability of occurring seizures and awake craniotomies during corresponding complications. In those cases with aborted awake craniotomy, the resting state fMRI connectome will be very useful. And now with the resting state fMRI using machine learning technique, we can assess the various networks from the resting state fMRI also. This is one of the case came to us. This is a 31 years male with school teacher with a recurrent lesion in the insula. In this case, based on the resting state fMRI, machine learning technique, the connectomes of the language pathway is assessed. This is the primary language networks for Broca's and Wernicke's areas. The closeness of the lesion to the lesion can be assessed. This is the other accessory language networks can be assessed other than the routine Broca's and Wernicke's from the middle and superior frontal gyrus and other regions. In this case, this is a default mode network and salience network, and this the lesion is very close to these cognitive networks. Beyond from the traditional surgical strategy, focusing on the meta-network population is now useful. We can traditionally non-eloquent areas, the refining intraoperative cognitive mapping will be useful, and the optimal selection of intrasurgical tasks, and for developing oncological disconnection surgery, and for personalized multi-step surgical strategy adapted to each of the brain relocation potentials. The traditional thinking of the Broca's Wernicke's language, now there are some different networks involved in the brain. One of the important things is that the frontal assonant tract, this is the important tract for the sublime SMA syndrome. Many of the intraoperative neuromonitoring may be inconsistent for producing for assessing this tract, and it may post-operative complication of SMA syndrome can occur if the tract is affected. This is one of the study which assesses the awake craniotomy intraoperative monitoring with the fMRI. This told there was a 100% specificity for motor, but for the language Broca's and Wernicke's it is relatively less, they mentioned. But this study was done long back, 15 years back, when this study was done with the 8-channel coil. Now we advanced to 32 and 64 channels, and multiband technique of fMRI was not done, and this is a non-randomized comparison, and there is a task is different between the surgery and what fMRI was done. This is another study which showed there is a good concordance with the sensory, but relatively less for the language, and this also was done beyond 15 years back in 2002 and 2011 study with 1.5 Tesla and without multiband technologies. This is a recent meta-analysis publications of the 68 observation studies of a larger series of 2,756 cases, and they have found out that the post-surgical functional deterioration was less likely to occur when pre-surgical fMRI mapping was done, and performance status was improved when fMRI was done, and the adverse effect was less than 11% with fMRI, and without fMRI was around 21%. This is one of the case, 66 years female patient with a left frontotemporal lobe mass lesion with highly perfused eye-grade lesion. And this is a connection pathways near the networks, near the lesion. You can see the language, salience, and limbic networks are very close to the lesion. And this is a post-surgery MRI. And we can also assess the post-surgery, what are the networks affected, and so that appropriate rehabilitation can be performed for the patient. In this case, most networks are preserved except for the limbic networks. The task-based fMRI is usually done for the language and the motor fMRI, and is helpful for planning the surgical approach, relation of the brain lesions to eloquent regions, and assessing the need for intraoperative cortical stimulation for determining the language dominance, which is well done by the task-based fMRI. And it gives a very important information to discuss with the patient before surgery what are the complications can occur. This is one of the case with a 24 years female with history of seizure. The lesion is in the left parietal lobe, very close to the hand and language. This is the task-based fMRI. You can see the Wernicke's areas is very close to the lesion, and this is the hand area. This is also very close to the lesion. This is the DTA. You can see the arcade fascicular fibers is displaced medially by the mass lesion, and based upon this, the awake craniotomy was done, and the complete excision of the tumor was done. This is the final output. And fMRI is also helpful for the plasticity changes. This is one of the left frontal avium with a very large lesion. The surgery cannot be performed. The SRS was done. And in this case, you can see that this is the pre-SRS. All the language and motor are same side. It was displaced to the same side. And this is a follow-up after SRS we had done after 1 year. The networks are actually improved and came to the same side. Many of the plasticity changes, how the plasticity can be assessed by the fMRI protocol. Coming to the DTA usually will do 32 to 120 directions currently. The 3 Tesla is better than 1.5 Tesla. We can do pre-operative or post-operative DTA to see what tracts are affected and how the complications, and intraoperative navigated DTA also can be done. Similar to the DTA, the fMRI, both task-based and craniotomy fMRI, resting state fMRI also can be navigated currently. This is the pre-operative DTA. This is the left frontal lobe mass lesion, necrotic mass lesion, high-grade glioma-like appearance. You can see the aslant tract Ascending tract is displaced medially by the mass lesion, and the corticospinal tract arcade vascular fibers relation you can assess. This tract is very important. The deficient tractography for awake craniotomy, this is one of the large studies. They have mentioned that preoperative data provide very accurate prediction for the spatial resolution of tracts in relation to the tumor. And this is one of the case of left thalamic epithelial GBM. It was record planned for surgery. Similar to the FMR, the DTA also can be navigated in this navigation system. And this is how the closeness to the lesion and how close to the corticospinal tract to the tracts can be well assessed. This is the preoperative, this is the postoperative final outcome. The lesion was completely removed. This is another case of right parietal pilocytic carcinoma, which was confirmed by preoperatively by ASL-APT mismatch technique. And this is the relation to the tract and the tumor. And the lesion was completely removed, preoperative outcomes. And how the DTA is useful for awake craniotomy, and they have found out that the surgical time is significantly less when DTA is used, and also there was a more trend towards complete resection when the DTA was applied. The summary, the DTA is very useful and it reduces the surgical time, and there is more trend towards a complete resection when DTA is used. And based upon the resting state fMRI, now cognitive networks are well assessed. Many of the insular and other tumors cognition pathway can be well assessed, and more elaborate language networks can be assessed. The task-based fMRI is the well-established technique, and the laterality are very well assessed by this technique. Thank you.
Thank you, Dr. Atityan, for the talk. Now I would like to invite Dr. James Joss for his talk on clinical neurology of eloquent hemisphere, different lobes.
Good morning again. I avoided the term lobes because the topic even was lobe-wise, but you know that we are moving away from lobes. Lobes has given way to networks. There's a important change in the clinical neurology because nowadays we don't consider lobe functions, we consider network functions. Now, if you take the brain, the right brain is visual and visuospatial, and the left brain is auditory and language. That hemisphere which lodges the language function is conventionally considered as an eloquent hemisphere. If you take the chimpanzees or the orangutan, you will see that both hemispheres are mainly oriented for visuospatial functions. That's why they can easily jump from one tree to another tree, goes very fast and move very smoothly, and all this is because of their visual functions, visuospatial functions. In human, as they develop language, the left hemisphere almost fully occupied with language functions and its related functions, and the visuospatial functions gradually move on to the right hemisphere. But don't ignore the right hemisphere. It's a brain of creativity. If you see the right brain, all these functions, they are represented in the right hemisphere, non-dominant hemisphere. And if you see that a person is a good teacher, if a person is an artist, if a person can give good oration, he can give good music, remember that they are all coming out from the right hemisphere. So don't cut too much right hemisphere thinking that they are all non-eloquent hemisphere. Now, you see that the left hemisphere is a more conservative hemisphere. He won't allow the right hemisphere to function. It's suppressed. If you want to give some charity, the right hemisphere immediately tell you that it's good. But immediately the left hemisphere will say that don't give because it's a bad trend. You have not that much money. Your wife may become angry with you. So in all sort they they suppress the activity of the right hemisphere, and practically they think logically with facts and analysis and ideas. So, know that the language is the function which is very much concentrated in the left hemisphere, and only in less than 1% language is represented in the right hemisphere, and that also usually is shifting when there is a damage to the left hemisphere very early in the uterus or the early childhood, early infancy. The language may shift to the left side, and the lateralization can easily be picked up by what called WADA test. We all know that there is a Broca's area and there is a Wernicke's area. Now there is a slight change in language areas. Now we all say the posterior language areas and the anterior language areas. The posterior language area essentially consists of 3 areas. The first is what is called the auditory phoneme perception system. That means that is the first stage of perception. They identify the sound and the phonemes. They can discriminate one sound from the other sound, but you cannot identify its meaning. The second is what is called a semantic system, internal semantic system, which is a part of lateral temporal lobe. This is the area where you comprehend what is spoken. The language is comprehended there. And the third area, which actually corresponds to our old Wernicke's area, is the lexical retrieval system. What is meant by lexical retrieval system? You know that all your words are kept in the brain as engrams, or you can say internal dictionary. There is an internal dictionary in your brain somewhere in the parieto temporal lobe, from where this lexical retrieval system will take off the appropriate word and you said what is required. So you can see that lesion of this individual area can produce damage. Word deafness, that is the one which is produced by the phoneme identification system, means that you cannot identify anything which is spoken to you. All other modalities are normal. If you are given as object, you can identify that, you can identify everything. But if somebody is talking to him, he won't understand anything. Fortunately, it is not a unilateral function, it's a bilateral function. So we sometimes encounter this pure word deafness in diseases like herpes encephalitis and other autoimmune encephalitis. Now, if you take off the temporal lobe, lateral temporal lobe, there is a high chance that you may develop what is called a semantic aphasia. The semantic aphasia, this is usually we see in frontotemporal variant of frontotemporal dementia, where the temporal lobe, lateral temporal lobe is affected. You see that the patient won't understand anything what we say. He is totally alien to language what we are talking. That is what is called semantic aphasia. And here, when the word retrieval system is gone, you will develop what is called a logophonic aphasia. It's similar to logophonic aphasia, means that patient cannot take up their words from the language, so they will produce only very few words. Conventionally, we say that posterior aphasias are fluent, but remember that logophonic aphasia, which we usually see in frontotemporal dementia variants or Alzheimer's variants, you see this logophonic aphasia, you will see that the patient has a very non-fluent talk where they will find out very difficult to take up words from this part. Remember that it is a posterior language area. Now coming to the Broca's area, we classically say that 44 and 45 is the language area, Broca's area. But remember that if you take, if there is a lesion in 45 and 44, you can safely take out that area. Nothing is going to happen because it produces a very transient problem. If the lesion or if the surgery extends beyond that to include the surrounding areas which I have shown in black, then only there will be a language problem with the anterior area. You remember that two functions, this Broca's area and its subcortical structures, carry out the motor planning, and it produces apraxia of speech, and there is syntax is carried out by this one. This produces agrammatism. Both these components combine together to form what is called the telegraphic speech of Broca's aphasia. Remember that non-fluent, it's a non-fluent aphasia, and you remember that non-fluent aphasia is not always an anterior aphasia syndrome. Sometimes it can be produced by a posterior language area dysfunction. Now, a particular function of the eloquent hemisphere is naming. You remember, you see that these are the area which is specifically important for naming. There is a stimulus recognition area which is occipital and fusiform gyrus. Then the semantic process that the patient understand this is the object which is shown. That is semantic processing by the lateral anterior temporal lobe. And then comes the lexical access, that is patient knows how to, where is that word name is kept, and it can be accessed through the parieto-temporal network, and finally it is executed. Now if you see that there are anomias depending on the area affected. If you cut off the anterior temporal area and the anterolateral temporal lobe, there is a high chance of dominant hemisphere semantic anomalies. And anomia means if you show an object, patient don't understand what is it. He won't name it because he is not understanding. He don't know the meaning. Then if it affects the parietal lobe, or you take off the lesion in the parietal lobe, it will produce word selection anomia. Means that patient knows, but it's a tip of tongue. Patient knows the thing, but it won't come out. If you show a pen, they will say that I know that I don't know the name now. It is something for writing, and if you say that is it pen, is something start with pen, then they will say that is pen. This is seen with the eloquent hemisphere posterior lesion. And of course, word production, when you see the area in the frontal lobe, you see that a patient will make mistakes in pronunciation. For example, for pen, they may say hen, like that. So these areas in the brain can produce anomia or naming defect, which you may not pick up immediately because unless you formally check that. Another one which is important for eloquent hemisphere is reading. Know that reading is a special language function or a special function for the literate person. Occipital lobe is involved, then the fusiform gyrus and the angular gyrus are the areas which are important for reading. The comprehension, the word identification is done by the fusiform gyrus, which is a part of temporal lobe. And the angular gyrus is the one which gives meaning to what you read. It's a 15-minute talk, isn't it? It's a 15-minute talk. Okay. So I prepared for a 15 minutes. How? 15 minutes, okay. Now, you know that reading, this is a circuit from the occipital lobe, fusiform gyrus and the angular gyrus. And the abnormality is called alexia. Different types of alexia can occur. If it is an occipital lobe lesion in the dominant hemisphere, you will get alexia without agraphia and hemianopia. Agraphia require the function of the angular gyrus, but there is no agraphia. Now, if the lesion is in the fusiform gyrus and its connection to the angular gyrus, you will get what is called alexia without agraphia. Patient will have alexia and they will not have agraphia and they won't have any hemianopia. And if the lesion is in the angular gyrus, you will get an alexia with agraphia. So this angular gyrus, you should always be very careful in touching. So many things are there. Now the praxis. The praxis is a function of the dominant hemisphere, superior parietal lobule and inferior parietal lobule, which is connected to the dorsal premotor cortex and ventral premotor cortex by the parieto-frontal pathways, which is the one which carry out the praxis. There is the posterior areas, the praxis knowledge and the praxis generation, and the anterior areas are the one which include praxis. Meanwhile, praxis means that the carrying out of a skilled learned motor act. That is what is meant by praxis, and this function is called apraxia. And if you see that the apraxia, there is sometimes in the posterior lesions or posterior after surgery, the patient will lose the concept of doing a motor act. This is called conceptual apraxia. You see, if you give this picture, this is a picture where partially nailed nailed one is there. If you ask the patient to take the correct tool from this tool selection, they won't be able to do the selection. If the alternative tool, the hammer is not there, but if you ask the patient to correctly do the correct one, they won't be able to do that. This is called conceptual apraxia. And then comes the ideomotor apraxia, again a posterior syndrome, where patient won't be able to manipulate. They know what to do, but they cannot be able to manipulate because of the fault orientation. Now there is what is called limb kinetic apraxia, which is bilateral. It is seen with right as well as left hemisphere, where fine manipulation cannot be executed. But be confident, because it is very difficult to create an apraxia by a surgical lesion or a restricted lesion. So when you cut some hemisphere, dominant hemisphere, don't be afraid of generating an apraxia, because the function is, I have simplified it and shown, but it is much more complex than what I have shown. And then finally comes what is called calculation and acalculia. You know that the numericals are represented in our dominant hemisphere in triplet code, which is, one is quantity, example is large and small collection. Then digital format, example 25, and in word format, example 25, written 25. These are the three way in which the calculation is encoded. With it, it's a separate area. The quantities are represented in the intraparietal region of the dominant hemisphere, and the word format is in the angular gyrus, and the digital format is in the fusiform gyrus. All these three areas are important for our calculation, and they are connected like that, very complicated connections, which is simplified here, and finally it comes out of the verbal or logographic output. That is the language. And you all know that this syndrome, which is seen in clinical neurology and neurosurgical practice, that is Gerstmann syndrome. This is the last slide on. It comes from acalculia, finger agnosia, right-left disorientation, and agraphia. Know that I want to spend 15 seconds for right-left disorientation. This, you know that if you see 30, I did a survey, 30% of the doctors have got right-left disorientation. You yourself may be experiencing that. You know why it is so? My own theory is that in your body, in your brain, there is a representation of right and there is a representation of left. But you are seeing the patient, and what is your right is the left of the patient, and what is your left is right of the patient. This creates a lot of confusion, and you will be surprised to hear that even in USA, there is sometimes happens that the surgeon wrongly operates the other side. Sridevi's mother is operated on the wrong side. This is because we are all highly prone for this right-left disorientation because of this factor. So surgeons should be very careful. And regarding something like memory and limbic function, which are bilateral, but they have a dominant role in eloquent hemisphere. For example, the auditory memory is lost when it is a dominant hemisphere function, as well as limbic function. There is a dominance. If you do Matthew may be knowing that he may be afraid of. I am afraid of sending a patient for a hippocampectomy if it is a left-sided lesion, because left-sided lesion produces a lot of limbic dysfunction, psychiatric, cognitive problem, whereas right hemisphere is safe. Thank you.
Thank you, Dr. Jose, for your talk. Now I would like to invite Dr. Vijay Kumar for his talk on anesthetic aspect of awake craniotomy, drugs and positioning, indications and contraindications.
Good afternoon. First of all, I want to thank the organizing team, especially Professor Dr. Siddhartha Ghosh, for giving me this wonderful opportunity. Thank you very much, sir. Let us move on to our presentation. To start with, I start with this slide for two reasons. Of course, the word is the Spanish equivalent for welcome, and the person, I think most of you will be familiar, popularly known as Mr. Professor. The uniqueness is identity, the person's character you can describe in 2 words. One is anticipate and be prepared. That's what we anesthetists are destined to do. Anticipate, be prepared, and manage. One declaration, anesthetist doesn't involve in any bank robbery. That's a funny note. Let us move on to a topic which is awake craniotomy, the anesthetic aspects of awake craniotomy. First of all, what is awake craniotomy? Awake craniotomy is a conventional craniotomy during which the patient is kept awake. Why? Why we need the patient to be awake? We know in brain, while operating, we have to preserve the vital areas of brain. So in order to demarcate the vital areas from the diseased areas, what we do is called cortical mapping. This cortical mapping requires the patient to be fully awake and cooperative. And also some surgeries such as epilepsy surgery, where we do electrocardiogram recording, and this DBS, where we do record the microelectrode potential, the patient should be free of any drug effects of anesthesia. So in other words, in all these conditions, the patient has to be awake in order to maximize the outcome of the surgery and minimize the neurological damage. That is the reason we need awake craniotomy. Then thus becomes the indication for surgery, such as tumors in eloquent cortex, and your functional brain surgery such as deep brain stimulation, and your epilepsy surgery. So what is the contraindication? Absolute contraindication includes, as we need the patient to be fully awake and cooperative, whatever condition which interferes with that becomes your absolute contraindication. The first thing is the patient refusal, and if the patient having some medical problem which makes him unable to lie down flat for a prolonged period of time, and the patient who has some cognitive problems such as memory disturbance, if it is difficult to have awake craniotomy. The other thing, the OSA, obstructive sleep apnea, difficult airway, and young patients are relative contraindications because it depends upon the anesthetist confidence level to take the patient for awake craniotomy. Then, what are the techniques involved in anesthesia? There are 3 ways we can anesthetize a patient for awake craniotomy. One is local, second one is GA, third one is called MAC with sedation, monitored anesthesia with sedation, where we provide analgesia and sedation. You may ask the question, which is best? The answer is this. Each is unique in their own way, and it depends upon the anesthetist confidence level and his expertise to choose a technique. I prefer to take the monitor anesthesia with sedation, where we provide analgesia and sedation. What are the anesthetic challenges? See, as I told, the patient needs to be awake fully. At the same time, the initial stage of surgeries, which includes scalp incision, craniotomy, and dural incision, all are most painful stages of surgery. So during this, the patient has to be extremely kept deep. At the same time, immediately after the dural incision, the patient has to be kept fully awake. This smooth and rapid transition from a deep level of anesthesia to take the patient to awake, fully awake and oriented level is a real challenge for any anesthetist. The second one is to maintain the cerebral physiology. What I mean is to maintain the ICT and hemodynamic stability. And third most important challenge is facing the complication. That comes back to our first slide, anticipate and be prepared. So patient may develop complications which has to be addressed accordingly. So first and foremost step in any awake craniotomy is proper counseling. A well-counseled, well-prepared patient will cooperate very well. We should carefully select the patient who is ideal for the which patient will be ideal for the procedure. This involves careful counseling with the patient regarding the procedure involved, what are the steps of surgery, and what is expected from the patient, on what is the expected problem the patient might have some sort of discomfort intraoperatively. All has to be well educated and well prepared. It is nothing wrong taking a patient prior to the surgery to the OT and make him familiarize with the atmosphere, how the OT will look like, how the theater lights would be, so that enhances his cooperativeness. So the next step is your preparation of OT. See, this is how the ideal preparation should be. Clear demarcation between a sterile and non-sterile zone. Care must be taken so that the patient face and airway is always accessible to the anesthetist. So we need to keep the OT personnel as minimum as possible. We should avoid noise. We prefer silencing or reducing the volume of monitor tone. And we also disable the alarm bells also. Of course, the anesthetist should always be looking the monitor rather than his mobile phone. And we should keep ourselves prepared for handle the emergency if at all is happening. Say that's again to the first slide, anticipate and be prepared. So we need equipments for emergency airway and ventilation if some complications occurs, such as this. The second one is nasal airway, where we can use if the patient develops some airway obstruction. The second one is a mask connected to a circuit to provide mask ventilation. If the hypoxia is very severe, we can use this airway device, famously known as LMA. The second generation LMA has the advantage that it can be inserted in any position. Then comes the positioning patient. Positioning involves careful coordination between the surgeon and anesthetist so that the surgical steps doesn't get compromised. At the same time, patient safety has to be taken care, particularly the airway. So ideally, we prefer a head-up position. Head-up position helps the surgeon to keep the brain lax, as the head-up position to 30 degrees is the most important step in reducing your ICT. And it also helps the anesthetist in such a way that it will push the abdomen contents downwards so that the pressure on the diaphragm is less. A spontaneously breathing patient under anesthesia, the tolerance of hypoxia will be more. So it's in both ways it is beneficial. And as I told, the patient face has to be exposed and the airway should be accessible like shown in the picture. And another important thing is we should avoid extreme neck flexion, extreme neck rotation, as some of the large veins of neck, if get obstructed, can raise the ICT. And also if patient is suffering from some sort of cervical problem, might complain of neck pain. So it is preferable to put such patients in a lateral position like this in the picture shown in the left side, rather than that is in the right side. So any anesthesia, we pre-medicate the patient with sedative pre-medication and anti-cyanogogues. For this case, particularly for awake anatomy, I prefer to avoid this because the sedative, we don't require sedation because we have well prepared the patient. The well prepared patient is not going to be anxious. So of course it doesn't require. Another thing is that might interfere with the awakening of the patient and his cognitive function also sometimes. And anti-cyanogogues we are avoiding because that causes excessive drying of the mouth. So the patient, in order to cooperate with you during the assessment, we will be keep on asking for water. So other pre-medication or standard pre-medication such as antiemetic, antiepileptic, dexamethasone, antibiotics. Monitoring, apart from standard monitors, we use bispectral index monitors called BIS monitor. This is a monitor to assess the depth of level of anesthesia. Ideal value should be, we kept around 40 to 60, which is indicate the patient is deep, and for a awake patient it has to be more than 90. As I told, max sedation includes analgesia and sedation. Analgesia, the best way I can give analgesia to this patient is by your scalp block. 2 minutes. Scalp block. A scalp block involves blocking almost 7 nerves on either side of the skull, which requires large volume of local anesthetics. Since the large volume of local anesthetics in a highly vascular region like scalp can lead to potential toxicity of the local anesthetics. So in order to avoid this, what I follow a protocol for different drugs for different purpose. We use ropivacaine for scalp block, and we use bupivacaine as a supplement to scalp block at the site where the mayfield pin get inserted, and we'll give lignocaine to the surgeon to infiltrate along the line of incision. As I told, sedation, propofol is the popular drug, is a potent sedative, but the problem with propofol is the dose at which the propofol will keep the patient deep causes complications such as hypotension, apnea, and respiratory depression. To avoid this, what we do is we add this wonderful drug called dexmedetomidine. The combination of dexmedetomidine and propofol will bring down the required dose of propofol in such a way it is safer to the patient and keeps the patient calm. And dexmedetomidine is an excellent anxiolytic and sedative, and doesn't produce apnea or respiratory depression. Of course, it is not free of side effects. In some patients, it can cause bradycardia and hypotension. The other drug is a recent addition to our armamentarium called remifentanil. This is an ultra short-acting opiate analgesic. I want to stress the word analgesic because the previous two drugs doesn't have analgesic property, but this drug has an analgesic property. But the problem with this drug is it cannot produce sedation, it can produce analgesia, but the dose required to produce analgesia may cause apnea. So careful titration of dose is required. Then again, same question, we will ask which is best. The same answer, it's up to the anesthetist confidence level and his experience and exposure. You can choose any combination. This picture to show how the cortical mapping is done. Electrode placed on the surface of the cortex and corresponding area potential can be seen in the graph. This is to show how a language assessment done during awake surgery. This is a video to show, just one more slide, where the patient is talking to their relatives through our phone. Adverse events I told can happen, include seizures. In order to manage seizures, we need to tell the staffs to keep ready ice cold saline in order to irrigate the surgical area. And other complications include agitation, hypoxia, and air embolism. Which has to be managed appropriately. To conclude, craniotomy is a complex surgery. It requires precise planning and expert anesthesia to get a good outcome. See, you can describe a surgeon with lot of adjectives: excellent surgeon, skillful surgeon, brilliant surgeon. And you can describe a physician saying brilliant physician, knowledgeable physician. But you cannot describe an anesthetist like that. You have only an adjective: I feel it is safe anesthesia. Thank you for patient hearing.
Thank you, Dr. Kumar, for your talk. Now I would like to invite Dr. Parthipan for his talk on role of intraoperative neuromonitoring in awake craniotomy.
Good afternoon to all. Today, we'd like to see that some of the intraoperative monitoring techniques, which is purely techniques, which we are routinely doing in awake craniotomy. First, I'd like to thank Professor Siddhartha Ghosh and Professor Atul Goyal and Professor Alias Gamayadi, and also the entire Walter Dandy Neurosurgical Society. Coming to the awake craniotomy, the rationale is the precise localization of the and preservation of functional areas to achieve the safe maximum resection. It also used to minimize the drug-induced interference with when we are recording that intraoperative electrical stimulation responses. Coming to the introduction part, the direct intraoperative application of the electric current onto the cortex for localizing and activating the functions, which is a motor, sensory, language, and cognitive. And it has a definite impact on preserving the function in the resection of low-grade gliomas. Coming to the technical part, actually, the electrical stimulation, which is more important in this case, actually, you need to choose appropriate stimulation device, which is more important to deliver the current. The another one is the stimulation parameter, which is so more you need to titrate accordingly to your local clinical environment. Coming to stimulation device and stimulation parameters, it consists of individual pulse and what's the pulse type and frequency, how much time that you need to stimulate the cortex and how much current you need to apply, and probe to deliver the electrical current. Coming to the device, there are two types of device which are there. One is that current based, which is actually the constant current stimulation based device, which is considered to be a very safe and ideal and more reliable to identify the functional areas. It delivers the preset current independently from the impedance, which is resistant to the brain as well as the patient's functions. Why not? There is another device called voltage based. Why not we use voltage based? Voltage based is actually it depends on the impedance, which is on the patients. So if there is an increase in impedance, there is a less delivery in current, which is suddenly there is a low resistance, which is in the impedance, and high level of current, which is delivered, which is going to be surgical manner, which is not, we have to be compromised on the procedures. So it has decrease in impedance that dramatically increase the amount of current delivery, which is going to be neurological milieu. Coming to the stimulation parameters, it is always ideal to use that low frequency, which is a single trained stimulus, which is the 50 Hz, which we routinely use in our Indian setup, and 60 Hz in the Northern America. Individual pulse is always that rectangular with either monophasic or biphasic pulse, which we can use, and cortex stimulation with annular cortex is more effective because of the neuron arrangements in the cortical level, which goes in the perpendicular to the perpendicular arrangement of the pyramidal neurons. The lowest stimulation intensity is good enough to see the stimulation effect on this surgery. Coming to the biphasic or monophasic pulse, actually first phase is actually coming to the biphasic pulse, actually it should be anodal always because of the neuron arrangement on the cortex, and coming to the monophasic also always the anodal. When it comes to the biphasic, first half of the second, which is 500 microseconds, which goes to the anodal and comes to the followed by the cathodal the 500 microseconds in this way. And also make sure that the stimulus pulse duration is maximum of 500 microseconds. It should not be exceed more than that. Coming to the selection of the stimulation probe, which is more important here, and the bipolar probe with the two tips, which is separated by minimum of 6 to 10 millimeter is ideal, because that is ideal to stimulate the elicitation of large pyramidal neurons, which is there in the cortical level. And we can use monopolar also, which is reference to the frontal zone. However, the distribution of electrical field differs between monopolar probe and bipolar one. And one must remember the maximum stimulation intensity should not exceed with a 40 microcoulomb, which is in the brain cortex, which is limited to maximum of 20 milliamp. This is the typical arrangements of both the bipolar and the monopolar. You can see that actually the bipolar, which is current is dispersing between those two poles only. It should not spread all over the cortex. However, in the monopolar, which is spreads 360 degree first over here, and followed by it goes 360 degree over here, and followed by it goes towards the reference. This is the same probe which we can. Both are bipolar, and this is the monopolar probe which you can use. The monopolar probe, which provides a homogeneous radiant spread of electrical field, leads to lower current densities in the area where you wanted to stimulate over there. And with this probe, stimulating the nerve tissue at more distant sites increases. Stimulation with the bipolar probe creates a good electrical field between the two contacts, and this current density is more homogeneous, and you can see that electrical field lines between the poles are close to parallel. You can see the typical bipolar component, which is minimum of 6 to 10 mm, the difference between two poles. That will be an ideal one for the cortical, as well as the same at the subcortical. Here, once you need to establish a threshold, you should maintain the same between both cortical and the subcortical level. However, still there is a debate in the awake anatomy that bipolar or monopolar is used, or both can be used. This is the basic difference actually. The bipolar is a low frequency stimulation with a biphasic of 50 Hz in the current duration, and the pulse duration is 1000 microsecond. It is a single pulse but continuous for 1 to 4 seconds, which mimics over there. However, it requires a lower current but longer stimulation delivery. That is one of the main advantage over here. Coming to the monopolar, it's a high frequency stimulation which gives a minimum of 250 Hz repetition or up to 500 repetition, but the repetition rate also 1 to 3 Hz. However, the duration of the stimulation is very low, but the current is required, which is higher for the eliciting any responses. However, globally, the bipolar is the gold standard nowadays. We are using routinely. In our center also, we are using routinely for the bipolar, which is a more ideal to identify the function. The monopolar is still in the debate, and it needs to be further evaluated significantly. Coming to the physiology test, for both motor and sensory pathway, accurate mapping of both superficial and deep pathways of the limbs, face and mouth, and followed by mapping can elicit or inhibit the movement. That is one important thing. Orofacial musculature, laryngeal activity needed to be as a tingling or movement that is like protrude to the tongue or speech errors. Coming to the language and speech cannot be assessed based on the anatomical landmarks. To assess speech, we do simple visual object naming test and followed by many other texts which will be presented by the next session by Dr. Ali. And the language functions can be studied with a greater refinement and complexity. multilingual patients were tested in all the language as the anatomical areas are naturally different. Coming to stimulation effect, once we stimulated the recording electrode, which is more important. Why? Because the mapping, what will happen now with the mapping, small movements or movements at a distant side can be unrecognized some of the time. So it is better always to monitor the muscle activity along with the stimulation area by doing a continuous EMG recording. To record EMG activity, surface or subdermal needle electrode which can be placed over the patients, and even that will be well tolerated even during the awake procedure. So this is a bipolar mapping procedure, and followed by we are stimulating the cortex, and we are recording the ECOG also, electrocardiography also. This is simple representative pictures. Coming to the patient's guidance, that is very important during the surgery, and therefore each steps on testing and stimulation procedure should be announced. It's an inter-team work, and patient should be carefully examined and asked about any sensations, feeling, or movements. Along with that, actually we do electrocardiography is helpful for ruling out and non-convulsive but focal temporal seizures. In 1950s, the Herbert and Jaffer Penfield developed the technique of electrocardiography, which is surgical treatment for epilepsy, but that can be also used for the awake procedure while we are doing the electrical stimulation. This is a typical example of, typical model of the electrocardiography techniques, which we do routinely with the stainless steel or platinum disc electrodes. This is a simple model of the electrocardiography recording. Don't look into this artifact, that is because of the bipolar and monopolar cortex, which picks up from all the channels. And coming to the electrocardiography, to monitor the stimulation triggered epileptic from discharges and after discharges, before and during the electrical stimulation in setting the awake anatomy, and it also helps to predict the threshold identification, maximum stimulation current, how much we need to use, and also the non-functional areas under awake general anesthesia. And also this after discharge monitoring can be essential to pick up the early seizure activity responses before it becomes overt. And this is a stimulation-induced seizure activity which can be picked up by the recording electrodes over here from that both upper limb and the lower limb. When we stimulated, patients moving the hand, but followed by patients getting the seizure activity, which is getting all the EMG activities picked up by the recording electrodes. Coming to the motor function, this is our motor mapping protocol with the Penfield stimulation. Bipolar stimulation, the single pulse biphasic stimulation is the 50 Hz, pulse duration always are 1000 microseconds. And the threshold stimulation duration is more important. 1 to 2 seconds we use for the primary motor cortex, and 2 to 4 seconds we use for the supplementary motor cortex. Once a movement is observed to the patient, the whole exposed cortical area is systematically to be mapped every 5 millimeters square. Coming to the mapping of the language and cognitive functions, Dr. Ali will describe more on this. The duration of stimulation, however, it should be set to be 3 to 4 seconds. That must be usually longer than the motor cortex mapping. So the repeated stimulation also can trigger seizures. So we need to make sure one could use that alternating testing mode. Patient continuously perform tests, but not manual stimulation break is necessary, but manual interval should be necessary for that. So we need to stimulate the 4 milliseconds continuously, and we have to give a manual interval of minimum of 2 seconds, and followed by again we have to stimulate and try to see the response. This is along with that we need to see the whole electrocardiography recordings also. Coming to the motor function, which is monitoring. Now the mapping is done. Monitoring is that strip MEPs we need to routinely use for that to identify the functional integrity of the corticospinal tract. This is a modified train of 5 techniques, which is 2 to 4 train is ideal. And this is very sensitive. This technique is very sensitive to predict the corticospinal tract integrity. And this is our protocol which we use. So short training consists of 2 to 4 pulses in the awake anatomy. Pulse width is maximum of 500 microseconds. And annual stimulation, which we routinely use. One must understand and ensure that none of the techniques should be performed simultaneously to avoid seizure activity. This is a typical recording of the pre-op and post-op of the strip MEP recordings from our patients. Coming to side effect with the stimulation point, the long-lasting side effect due to intraoperative brain stimulation have not been clearly reported, and seizure is the most common side effects that can be harmful to the patient. And pre-operative epilepsy and stimulation induces increase of occurrence of intraoperative seizures that can be noted. And instruments such as bipolar coagulation, probe QSA, and can mimic the non-convulsive seizure-related transient disturbance of a patient's performance. Coming to the conclusion part, the biphasic 50 Hz or 60 Hz, the biphasic stimulation is the best technique for awake surgery. Steep MEP short train technique broadens the monitoring strategies, which is not fully compliant, but with not fully compliant or pre-existing partial neural deficits of a patient, which can impair the intraoperative testing. The advantage of ECOG and steep MEP monitoring minimize the risk of intraoperative neural injury, and this is more close to the best function setup to pursue the awake surgical procedures. Thank you.
Thank you, Dr. Parthiban, for the talk. Next, I would like to invite Dr. Aliasgar Moidi for his talk on role of intraoperative ultrasound, which will be followed by his next talk on surgical techniques in eloquent areas or sapial resection.
Good afternoon and thank you. Thank you, Dr. Ghosh, Dr. Pandey, Dr. Goel, and everybody involved in this dandy meeting. It's nice to be back again every year. What I'm going to do is, I know Parthiban mentioned again and again that I'll talk about awake, but I realize that we'll run out of time. So I will try and stick to the two topics which are mainly there given to me, and if there is time, I will try and address the clinical aspects of awake also. But I'll focus on optimizing surgery for gliomas. And as I said, I will talk mainly on the ultrasound and on the subpile microsurgical technique of resection. If time permits, I'll come back to awake. So with gliomas, I think all of us who deal with them day in and day out realize that there is always this tightrope walk that we do, balancing radicality of resection with preservation of neurological function. And more often than not, as we all are neurosurgeons, always overconfident, or sometimes maybe we don't have enough information, and therefore the aim that we set out to achieve usually, sometimes, I won't say usually, but many a times we realize we've not achieved it. And there is this discordance between what you think you have done and what you actually land up doing. And there are many reasons why that can happen, and all of us have at some point of time experienced them. And neurosurgery is all about putting in defenses, multiple lines of defenses at each point, each stage, and that is what we do by minimizing errors. Dr. Turel is here, he keeps talking about it. So all we are trying to do at every time is to learn from mistakes, adopt, change our techniques, and use help wherever required. I think there's no shame in saying that we need help. You need adjuncts, you need technology, and that's what you can do. So when it comes to technology, there are many things that we use, both to balance neurological function as well as to extend your radicality of resection. And I'm going to talk about ultrasound, which is a very, very useful and a cost-effective tool. So the ultrasound actually came into the operating theater in neurosurgery in the 60s and 70s, and then spread to other surgical fields. But because of the rise of CT and MRI, it slowly fell into disfavor amongst neurosurgeons, even as an intraoperative tool. But things have changed. Over the last decade or so, there has been a lot of change in the technology itself, in the customization of the machine, the probes, and they're well suited for a lot of intraoperative work, not just neurosurgery, but many other fields. But also in neurosurgery, there is a range of application that the ultrasound can be put to, with very good images which can rival even MRI. And a very, very important function of the ultrasound that we use intraoperatively is as a resection control tool, as I said in the earlier slide, to prevent that inadvertent miss where we think we have done it, but we'll end up with some residue which we would want to remove, because now we all agree that extent of resection is important, and leaving residue, if it could have been removed, is not correct. So what's the evidence to say that ultrasound is really good? Am I just saying it, or is just some people, a handful of people just saying it? So when I think the evidence has accumulated over more than 2 decades, and this is one example where intraoperative ultrasound was compared histologically to multiple tissue biopsy samples with preoperative MRI, which was in the navigation. And it showed, as in this, that it was as good, and in fact better in certain situations across a range of intraaxial tumors in terms of histological accuracy. But you could argue that because it was preoperative MRI that was being compared and there would have been brain shift, there could have been a negative effect on the MRI arm. But there is also other studies. This is in high grades. There are similar studies in low-grade gliomas where intraoperative MRI has been compared to intraoperative ultrasound and other intraoperative adjuncts. And it has also shown that it is equal There could be different series which show slight better performance of ultrasound and some with intraoperative MRI, but that's like in scientific literature. You have some kind of variance, but they are essentially the same. And there are a lot of meta-analysis if you're looking for more evidence. So the proof of principle, ultrasound is reliable, it helps, and it improves your diagnostic capability. There is a caveat to that, I'll come back to it later. So how does it translate into decision-making intraoperatively? And this is our own experience. We had similar diagnostic accuracy, but this small chart over here shows that when you perform those intermediate scans intraoperatively, when you think you've completed resection, in 40%, 43% to be exact, there were residues which we detected, which we would have otherwise missed, and we went ahead and resected them further. So this is bridging that gap which I talked about, where you have an inadvertent residue and a miss. And this is one of such studies, and there are others published by others people also which show similar things. And this is not just with ultrasound, but other intraoperative imaging modalities. But ultrasound has certain benefits, and we'll see that. In low-grade tumors, which are non-enhancing, it's even better because there are a few other adjuncts which can help. For example, fluorescence is not so useful. And the ultrasound shows these tumors very well. And therefore, again, it can help you improve your resection rate. Mind you, it's not a magic wand that you will get a gross total resection if you put an ultrasound there. There are many things that go into achieving that radical resection, but this is one useful adjunct, one piece of information that helps you achieve that aim. And in high-grade gliomas, you can even do supra-radical resections beyond contrast enhancement. This was one of the older studies we published almost a decade ago. And now there has been enough evidence which has accumulated to show that resecting T2 flare component beyond contrast enhancement in high-grade gliomas, in glioblastomas, is prognostically significant. You may be able to do it in a very small subset, maybe 10% of patients, but you don't know which ones. And even if you are not able to do it, at least you can extend the resection more than what you would have without any of this. So therefore, it's a reliable diagnostic tool. It positively impacts the course of surgery also. And it is multifaceted. It can be used for different things, not just extent of resection, but many things during surgery. And to make it better, it actually has different kinds of applications, different kinds of methodologies you could use, not just the B mode, which we keep talking about. You could use the Doppler in many situations. You could use it intraoperatively when you're doing tumors, perisylvian gliomas, you're doing insular gliomas where you can do an angiogram. This is real-time intraoperative angiogram with power Doppler. You can even check for vessel patency, again, perisylvian glioblastoma post-surgery where you're seeing the MCA patencies preoperatively and postoperatively. And then there are this new kid on the block, elastography, which helps you understand consistency of the tumor. For example, this tumor, perisylvian, the same case actually with different components showing different appearances on the elastography. And contrast-enhanced ultrasound, which can also aid in picking up microperfusion and sometimes is useful even in picking up residue. And then you have multimodal imaging where you can combine the ultrasound with navigation, and it can help you improve image orientation, multiplanar display, allowing for serial temporal correlation, especially for resection control. So it's multifaceted, and therefore, no wonder it can be applied not just in cranial surgery, but across different neurosurgical specialties, spinal, minimally invasive, pediatric, non-oncology, etc., etc. For example, here you have just aspiration of a multiseptate cyst. Or in spinal tumors, be they extradural tumors where you want to confirm the patency or the adequacy of your spinal decompression, or intradural extramedullary tumors. This one, for example, we picked up some drop metastasis at the time of surgery with the ultrasound. And certain situations for even resection control. For example, here this was a complex dermoid, and intramedullary tumors where it helps you see the extent of the tumor, plan your laminectomy or customize it, and even do resection control, though IONM becomes a primary modality in these kind of tumors. So it's versatile, multi-purpose. It can be combined with different things. It can be used it can be incorporated into your surgical workflow without disruption. And it's also very, very easy. It's not very challenging. Small footprint. You can always have it in the intraoperative setup. Keep it ergonomically. It doesn't take much time to do a sweep, and you can keep doing it again and again and again, unlike, say, intraoperative MRI, where you have to, stop everything, wait for half an hour, 40 minutes maybe. And the best part of it is it doesn't come at too much of a cost. If you compare it, there are a few studies which have looked at this cost-effectiveness comparison, and the ultrasound definitely is much more cost-effective, provided you are able to achieve the same outcomes. And that is the catch and the caveat. Another paper which showed that it does not mean that if you have an expensive tool like an intraoperative MRI, it's necessarily better. They compared it in pediatric cases, and the ultrasound did just as well. So it is less time consuming, easy to do. It's much, much cost effective. Efficacy is equivalent, and this is dependent on the user. That's the biggest challenge with the ultrasound, because there is a user dependence learning curve. And therefore, competency development and training is important for ultrasound use, because you're going to do it yourself. And if you don't know how to do it or don't know how to interpret it, you're not going to extract the potential of the ultrasound. So train yourself to understand the ultrasound, how to perform it, and how to interpret it. And actually, I take this opportunity to request Dr. Ghosh, Dr. Pandey to consider even having a workshop. There were such a beautiful workshop sessions, 3 days. Maybe think of having an ultrasound workshop in the next edition. And if you're well trained and you're able to do it, and all of us do gliomas day in and day out all across the country, and there is no reason why this should not be available across the length and breadth of the country, and to give all patients the maximum benefit. It's a very effective and a surgeon-friendly tool. And no wonder then, if you scan the literature over the last decade, you'll find an exponential increase in publications with ultrasound compared to MR and even ALA, which has a little more constrained indications. So I would say that it's a reliable, accurate, and an effective tool. It's also very efficient, because it is it's cheap. It's also something which you can do anytime, iterative, repetitively, and most importantly, and I think the most important benefit, that it's cost effective if you compare it to, say, intraoperative MRI. So that's the first part of my talk, and as I said, I will skip to the second designated part. I had some things about awake, but I think I will not have time. So let me go to the second part, the second talk, which is on microsurgical subpile resection or block resections in hemispheric gliomas. It's not a new technique. It's something which has been there. It's just a different way of putting it. But it's something which probably makes sense. So generally, when we are dealing with tumors and intraaxial tumors, especially gliomas, a lot of us, and I must say even I have been trained that way, is to keep debulking it. We debulk piecemeal, and we go in and we finish the resection. But this can sometimes be a problem. Actually, more often than not, it can be a problem. It could be vascular, especially vascular tumors. Also, it sometimes takes longer, and it could lead to suboptimal resections and small residue here and there in the crevices in the cavity. And oncologically, if you go back and see, it's counterintuitive, because the principles of oncology, especially in non-CNS or solid tumor oncology, is to do block resections. That means to remove it completely without actually going into the tumor, and doing it with margins. These are not some things which you can do for gliomas. You may have to debulk sometimes, but the principle is to go around it to get what is possible as a macroscopic margin, and to be able to remove every bit of it without compromising function. And this is what is something which has to be ingrained repetitively for everyone who deals with gliomas. And the technique is adapted to ensure that you remove the entire tumor-bearing gyrus, not just en bloc removal of the tumor or a perceived margin, because we know gliomas can be infiltrative and the margin may be deceptive. But try and remove the entire tumor-bearing gyrus, exploiting this the pia, which is a very resilient barrier to spread of the tumor, and to use that for subpile resection. And this is, not, again, as I said, nothing new. Subpile resection has always been there, and a lot of it has been described in epilepsy literature, not as much as in oncology literature, but the principle remains the same. You respect pial boundaries. You peel off the gyrus, which is the tumor-bearing gyrus, or the tumor-bearing gyri, if there are many of them, from the most outer pial boundaries, keeping the pia intact with the two leaves of the pia with vessels running in so that adjacent neural structures do not suffer mechanical as well as ischemic damage. Sometimes the tumor is large, you may want to debulk it a little to be able to do a comfortable subpial oblong resection. The first step in any of these intraaxial tumor surgery is to localize the tumor. Often it is visible, you can see it. Sometimes you can't, and then you want to have some of these adjuncts. We talked about ultrasound, but there are many others that you could use. And you also need to ensure that there is no function somewhere around which you might compromise. Usually you may not find function in the tumor gyrus. Can happen sometimes in low grades, but generally not in high grades. But you want to make sure that there is nothing around. Once you've done that, we've seen IONM awake how it can help. Then you do a circumferential pial incision. The circumferential pial incision isolates that entire gyrus. If there are 2 or 3 gyri involved, you can involve all of them. Once you've peeled off all the gyral tissue, even if it looks normal from the pia, then you reach the bank of the sulcus where there is no more pia, and then you do white matter dissection, and this is where you have knowledge of white matter dissection is very important. The use of different extirpative tools, suction dissection with little bit traction or ultrasonic aspiration, very useful. Be careful that you know how to use the ultrasonic aspirator settings to be such that it does not damage the pia, and this is perfectly possible. So just as a demonstration, not a very complex video, but just to get the message across, let's see a couple of videos of subpial resection. So this is a very straightforward tumor which is in the middle frontal gyrus, looks well localized. So we open up, and what we do first is that you isolate the entire tumor-bearing gyrus. And then you peel off, hold the pia, the rim of the pia, and you peel off and separate the entire gyrus, even if it does not appear to be tumor. In this case, it was appearing to be a tumor, but there are many instances where you may not. And then you keep using suction, or you can even use a suction aspirator to isolate. And you keep doing it circumferentially in the entire sulcal boundary. Once you have come to the base, then it's white matter dissection. You keep maintaining a circumferential trajectory, but then in the white matter, you need to suck it out, or you need to use an ultrasonic aspirator. I personally prefer the latter. If it is an eloquent area, mind you, you have to do subcortical stimulation and mapping and monitoring. And you follow that trajectory, you will usually find a plane, but sometimes the plane may be deceptive. That's where intraoperative ultrasound becomes useful. Repeatedly you could do it, or you could do it at the end of what you think is a resection and check for residue. And this is, you continue till you reach and you remove the entire tissue with everything out. Check it with an ultrasound subsequently. Another case of a more eloquently located tumor, and this was, here you have the tumor which is in the parietal, superior parietal, and close to the corticospinal tract. You don't need anything to localize here because the tumor is already seen. But what you do is that you control your function. You have the strip over there. You can see the motor strip. We are doing an MEP monitoring. This has been done under GA. You do your circumferential pial incision, and then holding the pial rim. If there are bridging veins, this was a vein which was going into the tumor. You can see tumor anterior to it. Initially, we tried to preserve it, but it was entering the tumor and we took it. But bridging veins otherwise need to be all preserved. So the same technique, you separate off the tumor. Generally, you can do it with a suction if it is soft enough. Otherwise, a low setting on an ultrasonic aspirator is useful to separate off all this tumor from the adjacent sulcal banks. And you do it everywhere, all around, till you see virgin pia covering a normal gyrus on the adjacent. And here we are using a combination of subcortical mapping also, because this is close to the posterior part of the corticospinal tracts. This continues all around circumferential. Sometimes the tumor actually creeps. You think you have it at a pial boundary, but it actually is burrowing under, and the pile surface will be only seen much later. So you keep removing it till you reach a pile surface. That is the key in subpile resection of the tumor. As I said, keep doing it, and then the entire gyrus will actually get mobilized, and you are able to then remove the entire tumor-bearing gyrus. But this is up to the base of the sulcus. Once you come there, then you have to do white matter dissection. So now we've mobilized it all around the sulcus, and then you're doing subcortical stimulation. We're using a suction monopolar here, and we are also dissecting off the tumor, at the same time stimulating to make sure that it's far away from the corticospinal tracts. Do it all around in the white matter, functional control, and you can remove the entire tumor. Remember that it could creep into under certain gyri, into the folds of the gyri, and remove all of that. There is no point leaving behind this part of the gyrus if it was the tumor-bearing gyrus and it was not eloquent, because that will be the source of your local tumor recurrence subsequently. This is just the post-op scan. And this technique can be applied for both high grades and low grades. Little bit of modification. You can do a little bit of internal debulking. The advantages of doing a subpile dissection are that it's more anatomical. It ensures complete removal of the tumor-bearing gyrus and therefore minimizes the risk of oncological recurrence. Also, it is theoretically safer, and even practically, it preserves the vessels between the sulci which are supplying the adjacent the adjacent gyrus, which may be functional, as you saw in the previous case. And it also does not interrupt connections if you combine it correctly with subcortical mapping. Tumor may spread under the sulcus through the short arcuate fibers like Dr. Abida and Dr. Goyal always show us. And that can also be taken together in the en bloc resection, but with functional control, because there could be association functional fibers in the periphery of this tumor. And it's also important to understand that what you're doing is not just, we're not saying just en bloc resection, but what we are saying is subpile circumferential en bloc resection of the tumor-bearing gyrus. That's the difference that I would want to highlight, that you have to remove every part of that gyrus if you're dealing with intraaxial tumors like gliomas. And in functional regions, you can extend it. If the tumor is going under the arcuate to the adjacent gyrus, you can go up to the edge of all those gyri and remove it subpially, even do supramaximal, suprafunctional resections. Challenges may be there in redo cases where pile adhesions or it's disrupted, but you can still try and get it in a lot of cases. In highly vascular tumors, sometimes it may be a problem, but it could also be a blessing in disguise if you're able to go around it and avoid going into the tumor and causing bleeding. And very extensive tumors are generally unresectable, and you wouldn't get any such kind of pile margins. So finally, I'd like to end by summarizing that glioma surgery is a combination of multiple competencies. I think it's also theoretical understanding, knowledge of glioma pathogenesis, spread, anatomy like we've seen, cortical and subcortical. Also planning, surgical planning, using the right technique, and then using adjuncts wherever needed in order to meet the aim that you have started out with. So thank you very much.
Thank you, Dr. Moidi, for your talk. Next, I would like to invite Dr. Abita Shah and Dr. Sukhdeep Jawar for their talk on surgical anatomy of left insular glioma.
So while the screen is being set up, you can all take on your 3D glasses. So I'll just continue with Ali's talk. So what we have recently described based on this white fiber dissection that we are doing is gliomas arise from a named white fiber tract. And low-grade gliomas that are gyrus-based, they're actually arising from the short arcuate fibers that are within the gyrus. And identifying this plane of dissection, that you're taking the short arcuate gyrus, short arcuate fibers from which the glioma is arising in a whole beautiful plane and removing the whole tumor in an en masse fashion. So this anatomy of short arcuate fibers and the long association fibers beneath it is very, very important when you're doing this glioma resection. Can I have a pointer, please? Can we have the lights off also? So the insula is the hidden lobe of the brain. You can only see the insula once you lift the frontal, temporal and parietal operculum. So just give this a minute. So now this is a naked brain. It's not yet in 3D, but just I'm describing. So this is the brain with all the cortex removed. All you're seeing is white fibers. The only cortex here is that of the insula. Okay, so now you can see it very beautifully. So these are the short arcuate fibers that I was talking about, and we've recently published this anatomy of the short arcuate fibers. So they are just not connecting two gyri to each other, they are also having deep connections to the long association fibers. And this is the plane of resection for the en masse glioma technique that we have described. Now, when you come from the lateral aspect of the hemisphere, this is the SLF, that is the first fiber bundle that you will see. This is the arcuate fasciculus as it is turning around the insula. And now this is the insula. So I lift the frontal, the parietal and the temporal operculum, and you see this beautiful anatomy of the insula. So this is the insular apex. From it arise these 5 gyri. So this one, that is the lowermost, is the transverse gyrus. It runs along the Lyman insulae, and it will connect the insula to the posterior middle orbital lobule. This is the accessory gyrus. This is the anterior, middle, and short insular gyri. They are separated from the long gyri by the central sulcus. The central sulcus runs in the same direction as the central sulcus of the cerebral hemisphere. So that is an important identifying landmark. This is the superior surface of the superior temporal gyrus. This is the Heschel's gyrus, the planum temporal. There are 3 limiting sulci in this region. So this is the anterior limiting sulcus, this is the superior limiting sulcus, and this is the inferior limiting sulcus. This is the region of the Lyman insulae where the middle cerebral artery turns and the M1 becomes M2. Now look at the relation of the insula to the ventricles. So if you see this part, the anterior part of the insula corresponds to the caudate head and the frontal horn. The posterior part of the insula, that is the posterior insular point where the superior and inferior limiting sulci meet, it straight points to the atrium. And this insula actually forms a shield for the central core of the brain. It is an external shield, and you see what it is protecting. So this is the central core of the brain, and you can see the various capsules of the insula as we'll dissect them now. So the cortex, the extreme, the external capsule, in between them is the claustrum. Then you have the putamen, the globus pallidus. There you have the caudate head, the thalamus, and that is the internal capsule. This is the motor strip. Again, see the relation of the motor strip to the insula. So you can see these structures in this coronal view. So the cortex, the extreme capsule, the claustrum, the external capsule, the putamen and globus pallidus, the internal capsule, and the thalamus. Now this external and internal capsules are actually capsules of the putamen and the globus pallidus. So they are protecting this, and that is why they are called capsules. So they are the external and internal capsules of the putamen. Now let's dissect further. So now I've removed the gray matter of the insula, and you can see the of the cortex in the opercular region. Once I go into the remove that, you will start seeing the fibers of the insula. So the first layer that comes when you remove the insular cortex is this one, and that is that of the extreme capsule. So again, the SLF, the arcuate. Here, this is the superior temporal gyrus region. The arcuate is going to turn here and end in the region of the superior and middle temporal gyri. And this is the extreme capsule. You can see some fibers that are coming up here. These fibers. These are claustrocortical fibers that connect the insula to the cortical surfaces. Again, you can see in the depth these fibers that are coming up vertically. They are the claustrocortical fibers that are coming from the insula. So now we have removed a lot of these fibers. Now going in the depth, you see now the arcuate fasciculus has turned here, and you can see it is ending here in the superior and middle temporal gyri. This is still the SLF and the arcuate. Now this is just a perspective to give you how these layers are formed on the lateral aspect of the hemisphere. So the SLF is on top, then beneath that comes the arcuate, and then it turns down around the insula to go down. So now going deeper, once I remove the extreme capsule, this is what I will see, the external capsule. Now the external capsule has two parts. So this is the ventral external capsule, and this is the dorsal external capsule. The ventral external capsule is made up of the uncinate fasciculus, as you see it running here, and the IFOF, the inferior fronto-occipital fasciculus, as it comes down from here and goes posteriorly. And the dorsal external capsule are fibers that run beneath, form here and run beneath the arcuate to join the internal capsule to form the corona radiata. And that is the arcuate fasciculus again. Now this is an image where you can see various layers in one specimen. So here you see the IFOF, here you see the arcuate fasciculus, here you see the U fibers, here you see the extreme capsule, not yet dissected out, with some part of the insula, the putamen still there. Here the putamen has been removed, and you see the internal capsule, and here you see the external capsule, all going up and forming the corona radiata. Now going more in the depth, now you see this is an image from another image. Now this is the beginning of the uncinate fasciculus. It is a bow-shaped fasciculus that runs from the base of the frontal brain right up to the temporal pole. Just above that, you dissect and you will see the IFOF, which is originating here again at the inferior frontal region and going posteriorly all the way to the occipital lobe. So you can only see the IFOF when you lift the arcuate. Without lifting the arcuate, you will not be able to see the inferior front of fasciculus. So that is what I've done now here. I've lifted the arcuate, and here you see the IFOF running all the way from the frontal going posteriorly. Now you see these are some parts of the dorsal external capsule. In between here, I've removed some part of the putamen. So you see the various layers of the insula. Now here you see the uncinate as it is turning towards the temporal pole, and this fiber bundle that you see down is the ILF. Now going deeper, now the whole putamen has been removed, and what do you see next is the fibers of the internal capsule. So now before that, just this is the layer of fibers that go all the way to the occipital. So there is a whole bundle of fibers here that is called the sagittal stratum. This is the optic radiations. Above that you will have fibers of the anterior commissure and fibers of the IFOF. Below this optic radiations you will have the tapetum. So now you see in depth, once you remove the putamen and globus pallidus, at the base of the globus pallidus you see this structure, and that is the anterior commissure that follows this route of the IFOF, runs in the canal of Graciole and comes down here, joins the IFOF posteriorly and turns behind to form the sagittal stratum. So now this is the whole internal capsule. All the gray matter has been removed, and this is the anterior limb, the genu, the posterior limb, the retrolentiform part and the sublentiform part, which is made up of the Mayer's loop. So when you come from laterally, this is your limit of dissection. When you come from medially, the limit will be the anterior thalamic radiations. And of course, here you see the internal capsule will go down now as it forms the pyramidal tract and runs down into the brainstem, here in the pons between the corticopontine fibers and then forming the corticospinal tract. This is a closer view of the same. So you can see it is coming down from the insular region and going down all the way to form the corticospinal tract. Again, along for an insular tumor, the arterial anatomy is also important. So this is the region of the Lyman insulae, where the M1 becomes M2 and where it enters and forms the insular part. So here you see this bifurcation. Now the importance for insular glioma is you cannot go beyond the Lyman, because that is where you will have a danger of damaging the lenticulostriate arteries. Now you see these vessels. So when you're doing an insular glioma, you have to work between these vessels. You cannot afford damage to any of these vessels because some of them may be going all the way to supply the central lobe of the brain. Here you see the Lyman insulae, and this is the perforators as they go on to supply the basal ganglia, and that is what should not be damaged, so that your limit of resection should be the Lyman insulae. These are tractographic images showing the, in 3D showing the various tracks. So here you see this is the arcuate fasciculus. Here down you see the ILF. Here you see the IFOF as it is coming from the frontal to the temporal. This is the optic radiations going all the way. The optic radiation also has 3 parts, which we cannot discuss now. So here this is the IFOF. This red thing here is the whole sagittal stratum. And there is a bundle of layers here, which we have all dissected and seen now. And that is the arcuate, this is the IFOF. Now I'll just show you a small video so that you can appreciate the anatomy. So again, this is the arcuate, this is the sagittal stratum, this is the IFOF. Deepak, usko just turn the orientation. So fiber dissection is a very tedious procedure. It takes a lot of time and patience. What? नहीं आया. So now you can appreciate it. So this is the IFOF. Now here you can see that the whole globus pallidus has been removed here, and you can see the internal capsule. Here you can see there is some part of the IFOF still remaining. So here, this structure here that you see is here the arcuate I have cut. So you see that the fibers of the external and internal capsule have merged, and they are forming the corona radiata here and going up. These are all important for epilepsy surgery because you have to disconnect all this when you're doing epilepsy surgery. Now you see here, this is the anterior commissure. So this structure here, which is lying at the base, is the anterior commissure. Here again, I'm just showing the U fibers, the SLF and the arcuate as they have been dissected. So now you can see this is the anterior commissure, and here you see the IFOF as it is running, going all the way. So you see the anterior commissure is joining here just posterior to the IFOF, and this whole bunch of fibers is the sagittal stratum. So you have the arcuate, you have the MLF, you have the IFOF, fibers of the anterior commissure, fibers of the optic radiation, and the tapetum. Here I'm tracing the IFOF all the way to the frontal lobe. Going further. Now you can see here, now this is another important landmark. In this region will be the temporal horn. So when I cut through the IFOF and lift this region, you will actually straight enter the temporal horn and reach the hippocampus. So this is the basis of surgery for medial temporal epilepsy, as we have been doing and was described by sir. I'll just show you the hippocampus in this video. Going further. So here that I'm lifting the arcuate now, tracing the IFOF all the way posteriorly. So now you see this is the IFOF. Now I've removed, and after the IFOF comes the optic radiations. So the importance of this is that you do not damage the optic radiations and the IFOF when you're doing temporal surgery in the medial temporal region. Now you see this is the region of the temporal horn. I've opened it. Here you see the hippocampus lying, and you see that in the roof of the temporal horn, this IFOF and the optic radiations anteriorly run in the roof of the temporal horn. It is only posteriorly that they're in the lateral aspect of the temporal horn. So if you enter here in this region, you will not be damaging any of these fibers, and you're relatively safe to cause any visual deficit. Now all the way down, you will see that I have reached the pia. And if I dissect more further, I will straight reach the cerebral peduncle. So I think with that, we can end the presentation. Thank you very much.
Thank you, Dr. Shah, for your talk. Coming to the last talk of the session, I would like to invite Dr. Kuntal Kanti Das for his talk on anatomy-based resection of left insular glioma, its relevance in the era of functional neuro-oncology.
Good afternoon. So the last talk of the session. Again, thank you to the organizers for this invitation. I'm really honored. So in this session, what we have learned is that the anatomy of the brain, particularly the left side, is pretty complex. And in order to deal with lesions of this area, you need to have a lot of gadgets around you. And these complexities have a lot of complication potential. Well, this is true, but at the same time, you have to understand that we still have to resect these lesions. And in most of the centers in India, we don't have the kind of gadgetry that has been recommended. So we still have to get the job done. So with that in mind, particularly keeping the uninitiated, our residents in mind, I'm going to present this talk to you. So when you go into the literature, particularly the last 1.5 decade, what you see is that there has been a gradual change in the surgical paradigm of insular gliomas from the days of microneurosurgery of E.S.R. Gill to the contemporary times where there are a lot of gadgets being utilized to get this job done. And you see more and more reliance on adjuncts and less reliance on the microsurgical technique. It may not be the case in real life scenario, but if you look at the publications, this appears to be the situation. And there has been gradual shift from trans-sylvian approach to transcortical approach. So what has that led to? For the uninitiated, what it has resulted in is that we think that the insular glioma resection cannot be performed in usual neurosurgical setups. It can be done only in sophisticated centers. Secondly, it is a very highly sophisticated surgery. And thirdly, it is a surgery of gadgets. So this kind of thing can be overwhelming for the uninitiated. And let me tell you that whatever we do, the basis is always anatomy-based, good technical microneurosurgical resection. So there is a reason why insular glioma is considered to be the final frontier in glioma surgery, similar to petroclival meningiomas in skull-base surgery and probably basilar top aneurysm in cerebrovascular surgery. So insular glioma is like that. So why it is so? There are several reasons. For example, there are high complication rates, irrespective of who is doing it. Secondly, the location is quite precarious, as Dr. Abid has shown. And more often than not, the tumors will be subtotally resected. So much so that the authors across the world, they consider 90% resection limit as a radical resection limit. So such is the challenge here. So why does this complication happen? If you look at the best of the centers, the temporary complication rate could be as high as 25%, and the permanent complication could be as high as 10%. And I'm talking about the best centers in the world. So why does it happen? It happens because of two reasons, specific reasons. One is ischemic damage, as you see here, because of the damage to the lenticular striate. Now, this is a very, very important complication, and more often than not, these are permanent and irreversible. And the second group of complications that happen is because of inadvertent entry into the white matter areas, the direct neurological injury. But what I have seen in my experience is, more often than not, the permanent injuries are because of the lenticular striates. So herein lies the importance of good microneurosurgical technique, because in my mind, that is the only way of preserving these arteries. Now again, what are the important concerns here? Again, we have the Broca's area, so brilliantly described today. We have this Wernicke's area in the dorsal and the ventral language stream, which is so close by, but actually it is away from the tumor. That is one thing that you have to realize. Secondly, you have seen the intricate anatomy of the middle cerebral artery. Particularly if you look at the insula on the lateral side has the M2 branches. On the medial side, it has the lenticular striate. So it is actually sitting in between two important arterial trunks that you have to imagine. But what I want to tell you is there are some short arteries which arise from this M2 division. They actually supply the glioma. So it could be a strategic move on the part of the surgeon to divide the small arteries, because they will lead to devascularization of the tumor. I'll show you. And of course, Dr. Abida has beautifully shown the white matter tracts. I don't have anything else to say on this. In my own experience, I have operated around 50% of my cases have been left-sided insular gliomas. And of course, you can see that the complications rates have been high. So this is pretty much the situation everywhere in the world. But what I want to highlight to you is this first couple of lines here. You see, in my own experience, I've seen that these tumors are probably slightly different in that majority of them had higher grade. They were giant in size more commonly. They almost always involved zone 2, which is considered the irresectable zone. And many of them presented with raised ICV features. So probably a combination of the location, the site, and complexity of the tumor is what leads to more complications. So we need to be aware of that whenever we're talking about left insular gliomas. So what do I do? How do I do? My technique is primarily microneurosurgical, because that is the way I have been trained. And I do, of course, use some of the gadgets, but As you see, most of the gadgets are pretty simple with me. And the kind of patients that we have in government institutes, we are able to do awake craniotomy in a very small number of patients. So let us see a couple of cases. This is a left-sided insular glioma, you see, quite large. And as Dr. Avida has shown, it is abutting the frontal horn here. More importantly, we see an irregularity on the medial side of the tumor, and this is the internal capsule. And this is where the basal ganglia is. So this patient was taken for surgery under awake condition. Fortunately, he was fit enough. The reason being, I was operating on the left side, and awake craniotomy would give me more options. So let's see what was done. So a transcortical approach was taken. This is the cortical mapping with bipolar. Let me tell you, the kind of exposure that we have, I have barely found any active areas in insular gliomas. So this is one thing that may be completely avoided. See, here we are going a transcortical route. This is the temporal lobe here. This is the frontal lobe. This is the sylvian fissure. It is, you can take out the anterior part of the superior temporal gyrus with impunity. Nothing happens. Whatever happens, happens because of the areas here on the posterior part. It is very important to be slow, steady, and pretty meticulous because you do not want to cause a complication at this point. So during this surgery, we were interacting with the patient as this surgery was being conducted. Both language as well as motor tasks were being given to the patient. As you see, this awake craniotomy allows us to make these holes, this cortical openings in areas like pars triangularis. This is something that I won't do if the patient is not awake, because this could harbor language areas. The basic idea is we make these incisions to ultimately enter into the tumor. See, I was talking about these arteries, these short insular arteries. They are being divided here. So division gives you two advantages. It opens up the space because the MC can be retracted, and it devascularizes the tumor. Then we, of course, create some other openings on the frontal operculum, and eventually we go in and connect the temporal cavity here and the frontal cavity from here. And as it has been rightly mentioned, the most important point or the area in insular glioma surgery is this medial area. So we need to be pretty meticulous and very slow over here. Sometimes even the use of ultrasonic aspirator can lead to injury to the lenticular striate arteries. So here you can see this is an unmistakable thing, the basal ganglia. Once you have seen it, you will never miss it. So once you reach that area, you know that your tumor resection area is complete. So what we eventually did was we made multiple openings onto the operculum and resected this tumor. Of course, this kind of opening doesn't allow you good control over here unless you are angulating your microscope or using dynamic retraction. So this is the patient in the postoperative period, did have expressive speech problem for the initial couple of days. This is the resection that we obtained, and this is the patient at 4 years follow-up. Of course, he received radiotherapy because there was some residual tumor. Coming to the second patient, another patient with seizure. Now, if you look at the imaging, there is a peculiar finding over here. I want to highlight that. If you look at the middle cerebral artery, this is the middle cerebral artery. So in insular glioma, if you find some tumor in front of the middle cerebral artery, you should know that this tumor has some exophytic component. So a case like this is ideally suited for transsylvian approach. So we'll see the video here. So here we are doing the surgery under GA. We had a big opening here and we could find a hand area. Now, let me tell you, the opening was quite big. Otherwise, you don't find this. So here you see that the tumor has actually occupied the sylvian fissure. So this was one thing we could pick up on the imaging itself. So the peculiarity of these exophytic tumors are, once you decompress the tumor, you actually see the insula later. So the tumor was actually lateral to the MC. So you need to be cognizant of this important variation in radiology. So the essence of my technique is, I always seek this sulci, what Dr. Avida showed. So you decompress the tumor, go and find the peri-insular sulci. So if you are finding the sulci, which demarcates the insula, then there is less likelihood that you will be leaving some tumor behind. Again, I generally divide the short insular perforators. No long arteries, no sizable arteries should be sacrificed, mind you, but these arteries can be taken down. The basic idea is to expand the space between the MCA divisions so that you can work in between. On the deeper side, you see the white matter fibers are coming into our view. And of course, we use subcortical mapping. Now I'm working here. This is called the posterior insular point. This is the sylvian fissure which has been opened. So you see, you are basically utilizing the anatomy of the insula in guiding yourself during the surgery in the process of tumor resection. The rest of the steps are pretty much simple. The tumor is emulsified with bipolar and it is sucked into the suction like it is being done here. Ultrasonic aspirator is a very good tool. Now ultrasound, 2D ultrasound is a very useful tool as Dr. Ali had shown. In this patient as well, we utilized it and we were able to remove some of the some residual over here which was missed initially. And of course, it is very important to apply papaverine on these exposed vessels. This is the postoperative scan, immediate post-op CT and follow-up MRI, where we see a nice resection has been done. She received, of course, radiotherapy, because in gliomas, you never know that you have completely resected the tumor. The patient is doing fine at 3 years follow-up. Now, lenticular striatal preservation, this is something that I have recently published. This is again a completely microneurosurgical technique, as you see. We have described this 2-point antegrade skeletonization technique. This is the right-sided insular glioma, of course. Now, here we are seeing the epipyle segment of the lenticular striatal by resecting the tumor here. This can be done by opening the Sylvian fissure as well. We have the basal ganglia here, the nutmeg appearance. And what you do is, from point A to point B, you keep on resecting the tumor layer by layer. Of course, there's a word of caution. On the left side, of course, you'll be having the IFOP over here. But as you see, the tumor, what Yasargil initially told, this tumor actually pushes these arteries. So you can utilize this morbid anatomy and skeletonize these arteries right from their origin at M1 to this basal ganglia. So it may not be possible in all cases, but of course, this is a technique that could be really useful in tumors which have sharp medial border. Again, we talk about adjuncts, but these adjuncts are again dependent on anatomy. Let's see. There's a right-sided insular glioma, pretty well defined. We took this patient for a transcortical approach. You can see that the middle border is pretty sharp. This is one thing that is to be seen. We do an ultrasound. As you see, this is the ventricle, and this is the fossa cerebri here. And this is the hyperechoic tumor, what Dr. Ali said. So, an ultrasound at the beginning kind of orients you to the morbid anatomy. We resect part of the tumor here, put in the ultrasound again. And you see, this is the lateral ventricle, this is the caudate. And tumor is remaining here. We have been able to reach the level of the lateral ventricle. This is again confirmed with subpolar monopolar stimulation. So this is all being guided by your anatomy. Since we knew some tumor was still located behind, we made an opening on the temporal operculum. And in between the MCA branches, we made these openings and went into the tumor. And we keep on resecting the tumor layer-wise. It is very, very important. You cannot be deep at one place and superficial at another. We bring in the ultrasound again, and we'll see what is happening. This is called resection control, what Dr. Ali was showing. So you see some tumor is still over here. This is the basal ganglia. You can see my section poking in here. So this ultrasound, with the help of this kind of maneuvers, can further orient you. So I know some tumor is remaining here. I keep resecting that, put in the ultrasound again until I'm satisfied. You see now only a thin rim of tumor is remaining behind. I put in a subcortical stimulation, and I generally stop at 1 centimeter depth, because if you go more than that, then there could be chances of neurological complication. So this is the basal ganglia at the end. So these are some of the other patients. Our left-sided insular glioma, reasonably well resected. Another patient doing well at 8 years follow-up. So to conclude, insular glioma surgery is one surgery which is actually a meeting point of the art of classic microneurosurgery and the science of contemporary neuro-oncological adjuncts. You have to understand that. And in my mind, and for our residents, you have to have a very strong foundation upon which you can build this hybrid technique, and that basic is surgical anatomy and its intraoperative exploitation. And when you have that, you can build your own optimized onco-microneurosurgical approach to these patients, which is the need of the hour in my mind, in particularly in countries like us. At the end, my acknowledgement to my mentors at SUPJ, and I also like to thank Dr. Ali Asgar, who has been of great help personally to me over the last several years. And of course, the courses that he organizes, they're extremely useful. Thank you so much.
Thank you, Dr. Das, for your talk. Now, I would like to invite the moderator of the session, Dr. Atul Goel, to share his insights.
In the next 12 minutes, I will like to comment on what has been talked about, and also to introduce my work, which many of you know and many of you have heard. One is, low-grade gliomas, by definition, are called diffuse or infiltrative kind of tumor. This is the definition. So for the first time, we introduced that the term that they are not diffuse, they are confined tumors. So this is one thing that we introduced for low-grade gliomas. These tumors are confined to a named white fiber tract. You please note down these sentences. They are confined to a named white fiber tract, and they grow along the white fiber tract. So if they are along the uncinate, they will go along the uncinate. If they are along the IFOF, they grow along the IFOF. If they are along the short arcuate fibers, they grow along the short arcuate fibers from one gyri to another gyri. So this understanding that they are confined tumors, in my view, and without any hesitation, is a complete revolution in the field of low-grade glioma surgery. I have no hesitation to say that. When they grow along a named white fiber tract, they displace the adjoining tracts. They displace. They do not infiltrate. They displace. And the adjoining tracts are affected functionally by virtue of displacement and deformation and by pressure, and not by infiltration and destruction. You note down each and every point very carefully. More important is, because there is a displacement, deformation, there is a possibility of designing a well-defined plane of dissection between minutes. And the most important thing that I have realized, that when you remove this tumor, you may need no coagulation or very minimum coagulation. So if you are removing a 4 centimeter tumor without coagulation, it means there is some controversy or some discussion is required as to how these tumors get blood supply. So this needs to be discussed. Because these tumors have been called traditionally infiltrative tumor or diffuse tumors, and they are low-grade tumors. 30 years ago, nobody was operating on these tumors because they are low-grade, because they are infiltrative, and majority of tumors are in eloquent areas, insula, motor, supplementary area. Nobody was operating on these tumors. Biopsy was not even indicated because you could see by radiology. So over the last few decades, I will say not even 3 decades, maybe 2 decades, lot of innovation, technological, functional innovations have come in the field. And we have seen some beautiful demonstration of functional MRI. Then the thing has come on awake craniotomy. We have seen the anesthetist talking beautifully. Then we have come and seen the possibility of, most important thing in my understanding, the growth of the understanding of white fiber tracts. Nobody talked about white fiber tract 30 years ago. When I entered into neurosurgery, the brain was frontal brain, temporal brain, parietal brain, occipital brain. Nobody used to talk about white fibers. This coming in the picture of white fibers, understanding how they form the foundation of the brain, how they form the infrastructure of the brain, nobody knew before actually Yasser and Kieger talked about it, not even 35 years ago. So the whole understanding has changed, not only in the arcuate, in the association fibers, deep fibers along the arcuate tracts, along the IFOP. If you see a MRI of a glioma and carefully analyze, next time you see a glioma, carefully analyze, they will be along a white fiber tract. Along the corpus callosum, if it is a butterfly glioma, why it is butterfly? Because it is growing along the white fibers of corpus callosum. My understanding is, my feeling is, if you have this, you see, if you have the technique of dissection, if you have the technique of identification of normal from abnormal, and if you have concept clear. Now over the years, over the last 10 or 12 or 13 years, we have been doing this kind of en masse resection. As I grow into this business of en masse resection, my confidence in this concept has dramatically increased. The need of awake craniotomy has gone down. The need for intraoperative monitoring has considerably gone down. This concept is there, and this concept is here to stay, and this concept is going to progress. If we have this concept, you can do this kind of en masse resection, and the need for intraoperative monitoring can be considerably reduced. We have heard about monitoring. Don't misunderstand me. I am not saying awake craniotomy is not necessary. I am saying the need for awake craniotomy can be reduced. Parthiban, don't get upset. I'm not saying intraoperative monitoring is not required, but the need for intraoperative monitoring can be considerably reduced. If it is frontal glioma, and you see, if you see the work of Dufault, most celebrated work of Dufault, he does functional mapping throughout. You see, awake craniotomy, functional, when he's doing even this frontal tumor, there will be functional mapping for hours and hours. For every situation, he will do functional mapping. At least in less eloquent areas, there is no, I am doing en masse resection technique in the most elegant and eloquent areas of the brain. It is possible, it is here to stay. That is what my observation is about low-grade gliomas. Thank you very much.
Thank you, Dr. Goel, for sharing your insights. Before we head out for lunch, we have a special talk by Dr. Deepak Gupta on pregnancy with TBI, saving 2 lives, challenges faced by neurosurgeons.
Thank you, and thank you, Dr. Ghosh, for accommodating me in this talk. Well, I'm between you and lunch, and as they say, if you are made to fast longer, you eat better. So I do come across a few cases. I'm sure sometimes in our neurosurgical practice, we reach at a stage wherein people look upon you. You know, you may come across a patient with a term pregnancy, and then you're left what to do. And naturally, most of the neurosurgeons, they end up talking to their great friends obstetricians. They themselves are not aware what actually needs to be done. For those from the other part of the world, I mean, this is where I work, All Indian Institute of Medical Sciences. In fact, Government of India has come up with 26 other aims like institutions in our country, and this is our team of 25 plus faculties from the Department of Neurosurgery, and that's the level 1 trauma center wherein I'm working. So first message I want to give is that minor TBI in pregnancy is never minor. There have been ample number of studies available in the literature wherein it has shown that the risk of poor outcomes to the mother and to the fetus are increased significantly even if it is a minor trauma sustained by the mother. However, there has been a systematic review which was published in JAMA in just recently in February 25. This, however, concluded that there is no association between TBI and the poor outcomes. And the prime reason of this review not coming out with a conclusive evidence was because most of the studies were very low quality studies, very few case reports were included in the literature. So there was limited evidence. However, this review did touch upon the adverse maternal outcomes in the mother and the increased mortality in the mothers. And for sure, this review also gave a message that there is a need for more systematic studies. If I ask any of you, have you come across any publication from our country talking about some good studies on traumatic brain injury with pregnancy? Believe me, there are none, except for a couple of case reports. This is our common understanding. We always say that, you save the mother, you save the baby. Like optimal resuscitation of the mother is equivalent to saving the child. But the evidence-based guidelines, even the BTF guidelines or any other guidelines you talk about, the national guidelines, they are somehow non-existent. And believe me, the knowledge gaps are the highest amongst us, amongst the clinicians, amongst the neurosurgeons. I mean, to talk about the very basic thing to do the CT scan, and the moment a patient comes with a pregnancy with a traumatic brain injury, and the resident calls you to do a CT or not, you are yourself in a dilemma, and you also tell, okay, fine, just delay the CT, it may or may not be indicated. Any other patient comes with a trauma, you will always say, okay, fine, do a CT and call me later. But for a pregnant lady, you will think twice. Okay, to give Manidol or Lasix, these are the questions which are actually asked by the resident to the faculty in the mid of the night. And if you yourself do not know what to answer, how will you address the problem of the patient? The ventilatory strategies, not many anesthetists are actually aware about. I mean, with due respect to my colleagues, I mean, it all depends on, because the trauma centers are usually managed by those the senior residents who have actually not read the subject so well. Whether to do the ICP monitoring or not to do, what are the ABG targets? And what if a term pregnant lady becomes brain dead? What is to be done to, these are all very ethical issues involved. And because we are working in a level 1 apex trauma center, we do come across these scenarios. I mean, we see something like 5 to 10 cases in a year with term pregnancies with those reaching a brain state of brain death and sometimes needing surgeries. When to do cesarean section and how often we should do a fetal monitoring. Again, if there is a lot of dilemma, you talk to the gynecology, they will just come once in a day or they may not even come. And so these are the things. And even how aggressive one should be. most of the people who talk about the fetal viability, well, a 500-gram fetus, 24 weeks of pregnancy, we may be able to save in the All India Institute of Medical Sciences or the best center in the country. But if you go to the far-off areas, believe me, they're just equivalent to non-viable. Any fetus which is less than 32 weeks of pregnancy is kind of a challenging one for the neonatologists. The anti-seizure medications, what are the anti-seizure medications to be given to the mother? And when should the mother actually breastfeed the child? Nobody knows about it. The lactation is never talked about. We have seen patients with the engorged breast developing to the stage of breast abscess when nobody is bothered to talk about the expressed breast milk in the mother. So these are the very few practical problems. The hypovolemia in a pregnant mother never ever manifests with the acidosis because pregnant state is a state of respiratory alkalosis. The urine output remains stable even if the patient is hypovolemic. The reason being because there is ADH issues in the mother, and so there is never a the hypovolemia may be there, but the urine output will remain constant. The hypotension in the mother is very, very common. In fact, we have seen patients with the shunt malfunction which was physiological. A lady was there with 32 weeks of pregnancy and she had some increase in the ventricular size, and we went on to explore. The shunt was working very well. All we had to do was to teach mother the positional therapy on the left lateral position so that the shunt starts working. So these are the practical problems which we see in our setup. Like in children, when they come to you in the emergency area, we always tell that put something under the shoulder so that the neck flexion is not there because of the large head side. Similarly, we need to teach because the incidence of hypotension is to the tune of up to 82% in a pregnant lady beyond 28 weeks of pregnancy. So that has to be understood that there is a aortic valve compression which happens because of the gravid uterus, and the mother needs to be positioned to avoid hypotension. And of course, the low BP in the mother is kind of detrimental to the baby also. Yes, you need to monitor the mother as like a normal patient, both invisibly and by we should be thankful that we have got such excellent tools like pupillometry, optic nerve sheet diameters, and our teams, the neurocritical care team, even the neurosurgeons are well versed in managing these patients in the ICU nowadays. I always believe that the pre-viable stage is less than 24 weeks, and that's the time when the fetal ultrasonography is recommended for the fetal viability. And beyond 24 weeks of pregnancy, you need to do a fetal tachography and the electronic monitoring. So regarding CT, again, it's just 0.0 rads per CT scan radiation to the patient, and you can give up to 5 to 10 rads without any teratogenic risk. So you can safely do up to more than 10 CT scans in a pregnant mother without risking the mother, without risking the baby. Let us be very clear about it. If a patient needs CT scan with or without pregnancy, please do the CT scan. There is no extra added risk given to the mother or to the patient. Second issue comes regarding the abdominal shield. There is a beautiful study of a kind of study done very recently, which says that if you use the abdominal shield and you do a CT scan, let's say of the chest and the abdomen, the radiation given to the mother is 40% more. The radiation absorbed by the fetus is 40% more. The reason being because nowadays the modern CT scanners, they have got a AI sensors with them. So the AI senses that there is some obstruction and it gives more radiation. So at our center, we recommend that, if you're doing a head CT and people are ignorant about it, the shield can be used to prevent the scatter radiation. But for the CT of the chest and the abdomen, in a polytrauma patient comes to you, believe me, we don't use any abdominal shield whatsoever, and it is safe. You can do up to 2 contrast-enhanced CT scans in a mother without risking the baby at all. 2 CECTs I'm talking about. And the people have gone to the extent that up to 50 CT scans in a mother can be done if it is really indicated. On an average, you need something like 3 to 4 CT scans in a mother. I'm talking about severe TBI during the hospitalization. So these were a couple of cases which we managed. I'll skip it in the interest of time. And so the bottom line is, if a person needs ICP monitoring in pregnancy with CBI, please do it. And the targets are same. In the third tier therapy, sometimes the patients goes with the kind of race or the refractory intracranial hypertension. You take a tiered approach, tier 1, 2, and 3. In the tier 3 approach, we always recommend just do decompressive cranectomy as the best option, because hypothermia and barbiturate coma does have deleterious effect not only on the mother in terms of increased infections, hypotension, arrhythmias, but also on the baby. So in the tier 2, only one option which is there for these patients is the decompressive cranectomy. And the lactation, we always strongly emphasize that once the mother has delivered, a term mother who after 32 weeks who has delivered a baby, we have got many such patients in our practice. We always say the express breast milk of the mother needs to be given to the child, and the timing, we always say that it should be after the mothers should take the anti-seizure medications after the breastfeeding, or after the milk is expressed out, then the mother can take the milk. They're very basic things which all of us understand. But in the busy ICU, it has to be put up in the practice in terms of SOP instructions have to be given to the residents and to the team very, very clearly in their language. So these are few cases. This was a 22-year-old lady who was put on ventilator, and she had a fall. She had an ICP of 25. We managed with the tier 1 and tier 2 therapy, and the cesarean was done. Then and the express mother milk was given to the child, and at 18 months follow-up, both the mother and the child are doing well. Now, the neurosurgery in pregnancy with TBI, this is where our role comes. I think there is no confusion before 24 weeks of pregnancy. I mean, the fetus is non-viable. You should do everything, whatever you want to do to save the mother in the child. Beyond 24 weeks, if you're working in a good setup, I'm talking about tertiary care hospitals where the maternal fetal metal units, MFM units are actually functional, and your NICU is very good. In those cases, you can actually go for kind of cesarean section even beyond 24 weeks of pregnancy, but try to delay it up to 32 weeks of pregnancy by giving some steroids or whatever for the lung maturity. And to save one life or more, I mean, this was the lady who had kind of a large, I think, basifrontal contusions, bilateral. In that lady, we decided to do a cesarean section just before the decompressive. And it was after discussing with the family, of course. There was a single apneic limp male baby was delivered, intubated in the operation theatre. Child was kept in the NICU for 2 weeks. And the following this, the mother DC was done. Unfortunately, the mother did not make it, and she succumbed. So few guidelines have been published very recently, and this is a study of which our AIMS is a part of, and this is the MAMA study. This is in fact the best study I could come across. The results were published just this year. 122 physicians from 110 centers from the different part of the world, over 35 countries were given some questionnaire. Delphi survey was done. And what you see is that this was actually the drawback of this study was it was done in the high income countries, not in the developing. So actually it's a food for thought that we need to have something, a kind of a study like this for our country, for India, for the developing nations together. Sumit is there, president of NTSI. I think we need to take this lead and talk about this. The very untouched things, they need to be talked about. And as you can see, only 11% of the people who were surveyed in this were the neurosurgeons who deal with these patients left and right. The gynecologists was just 2% in this survey. And in this survey, interestingly, many people were doing MRI. This is again talks about the ignorance. Doing an MRI in a pregnant lady is really not a joke. I mean, to make a lady lie down with 28 weeks pregnancy in the supine position is just not possible. You have to tilt the patient because to prevent hypotension, and it's really super difficult. The gadolinium is not FDA approved, and it is not to be given in the pregnant patient. And even the MRI, again, people use it just for the fear of radiation, which I think is too much in a pregnant patient. And the best part which came out of this study was the variability. There's so much of variability in 2024 and 2025, even in the high income countries, in most of the decision makings regarding what osmotherapy to be given, what PaCO2 level should be kept. But there was some consensus on the barbiturated coma, say for example, like no barbiturated coma in the pregnant mother. All pregnant ladies, at least in our center, any lady coming with 15 to 45 years of age group, we do a UPT by default. In fact, we have picked up many such cases and modified our approach in those cases. Just 2 slides, I am done. So this is the AIMS experience. Like this is the chart I'm showing you just to show you that we do, like out of these 40 plus cases, we had 3 patients who were with the term pregnancy, and we do risk stratifications. And just yesterday, one of our paper has been published in Neurology India. I always believe that we as Indians should publish our work in the Neurology India. This is what I want to give a message to all of you. Publish your work in India, Neurology India, so that people get the maximum benefit because they read this journal very frequently and very often. And we have laid down some SOPs for the pregnant ladies with the severe TBI. In the interest of time, I'll skip it. And many patients we have been able to manage with our protocolized approach. And to save multiple lives, sometimes you have got issues when the lady is when the pregnant mother is brain dead, and then you have to talk to the family bioethicist. And if the family wants a baby, then only you should talk about it. And the most important message which I want to is that we have to talk to our colleagues, the obstetricians, because they are the ones who are quite ignorant, unfortunately, about it. This is a neurosurgeon. He feels that he can actually, it's more easy for him to deliver the baby than to convince an obstetrician, with due respect to the colleagues. It is actually very true. It just reflects some amount of ignorance both amongst us and a lack of interaction with our colleagues. We need to talk to our colleagues. They are very good, very efficient. You just have to convince them and put forward a point very, very clearly. So I always, this is my last slide of my talk. I think we need to have a more awareness activities for the obstetricians and for the healthcare workers, and about the CT scan, the milk, the express milk for the baby. It is beyond doubt that the baby needs to be given the mother's milk, which is the best for the baby's outcome. The optimal imaging needs to be done for the mother, and in terms of many parameters, and some kind of guidelines needs to be there for our patients to have the best of the outcome. Lastly, I would like to say that pregnancy with TBI is a high-risk condition, and injuries are never minor in a pregnant mother. We started a campaign when I was a part of the Brain Injury Initiative, and we are still taking it. We call it a Save Ma campaign, and we will continue it. And anybody who has got time to attend more conferences, welcome to New Delhi next week. We'll be doing the first time in our country a global neurotrauma advanced course, where there will be a lot of activities happening. You're most welcome. Thank you so much.
Thank you, Dr. Gupta, for your talk. It is now time for lunch, which will be served at the Haba Hall. It will be for 30 minutes, so please be back by 2:45 p.m. sharp for the simulation surgery. Welcome back. We will now start off with a 30-minute simulation session on glioma surgery by Dr. Ali Asghar Moidi.
Check.
Yeah, now you can hear me. Okay, so you can hear me now? Now it's coming. All right, so we'll just continue with the pre-lunch glioma session, a small session on simulation of glioma surgery using the silicon models, which we saw yesterday also with the meningioma and the vascular. This model is true scale, but it is only to the, it's only that region of interest of the glioma, so it won't be the whole brain. It's there focused on that. But before that, 2 minutes, let's just go through the MRI on the basis of which this model has been created. So as I'm scrolling here, you can see that it's a right frontotemporal glioma, large one, almost looks like an extraaxial tumor, which is coming to the surface. The screen is focused there, so maybe you have to look at this small screen only for now. Which one? This light? These lights? For the time being, can we switch off those spotlights? Yeah. So, very standard frontotemporal glioma. We don't have all the images, but I'm assuming this was enhancing. It looks heterogeneous, so probably a little high grade. Surfacing, so what we used to earlier call gliosarcoma, now it's no longer called. It's just a name. So anyway, so in this patient, as we discussed, our aim is, of course, surgery is required. Surgery is required to remove the tumor, and we will try to be radical. The concerns here will be, of course, the eloquent areas, but because this is surfacing, it's right temporal and frontal, we won't have that many concerns. Concerns will be deeper, where it goes close to the sylvian fissure and the MCA vessels and even the perforators, which is where we have to be careful. So if I were going to do this case, I would do it under GA. I would plan to do it with intraoperative neuromonitoring with MEPs, more for monitoring than for mapping. And I would use the ultrasound because I use it routinely just to understand where the tumor extent is and the tumor in case it's left behind somewhere. Most probably I may not get a complete resection in this because invariably these usually are entrapping the MCA branches, and it's not wise to peel them off completely from those vessels unless it comes out easily. You could use fluorescence. I don't think we've talked about that in any of the lectures, but you can use fluorescence, and I think this model is also injected with some dye. The craniotomy would be a large craniotomy. We don't have all of them. You have only these images, no? Only T2 images we have. We don't have the contrast and flare. So we assume there is some edema and that there is enhancement in this tumor. So we'll move to the microscope. Is it in the center on the screen?
Yeah, it is. Yes.
So for the sake of saving time, we've already done the craniotomy. The craniotomy for these tumors generally should be large enough. Some people do a much larger one anticipating brain swelling, but you have to do an adequate craniotomy, in this case up to the temporal base and above the superior temporal line adequately into the frontal, expose the whole sylvian fissure. So here we have actually, I'll just remove the bone now that we have done it, and we can see here that there is dura. Unfortunately, we were not very good at doing the craniotomy, so some part of the dura has got torn. So just to orient everyone, yeah, this is anterior, posterior, inferior, and superior. Now I'll open up the dura quickly. Dura we would open based on the sphenoid ridge, as is standard. Since it's already torn here, I'll take this liberty. Okay, so since it's silicone and it's a little elastic, I'm going to remove it, otherwise it will keep coming in the way, falling down. to focus this. How do you focus this? Yeah. Which one is the focus?
I think that is
This one?
height adjustment.
Acha, height only. You have to adjust the height. Okay. All right. Now, so just to orient everybody, because this is only a limited field view. So this is frontal, temporal, and here you can see tumor which is appearing to surface, maybe coming out through the sylvian fissure. In case you don't see it there, you may want to use the ultrasound. I would still use the ultrasound just to find out the extent, how much of the temporal lobe is involved. Here you have the fluorescence light, UV light, and you can see how beautifully this is fluorescing here. Is it seen there? Yeah. Can I center it a little? Better?
Yeah.
Okay. All right. So if we were using MEPs here, once we open this, we would have put transcranial MEPs, but then I prefer putting in a strip also. This is frontal. We'll assume that this is the central sulcus region. Slip a strip underneath that and get a cortical strip MEP. But since here what is at risk is perforators, internal capsule, maybe even the transcranial MEP will be good enough. Now in this case on the MRI, we already know that it's involving temporal lobe, pushing the frontal lobe and splaying the sylvian fissure. So if there is an exophytic component, I will just try and see, look at the infiltrating tumor. A slight artifact of this simulation model may be that because the different components are printed differently. Is that correct? Yes. Yeah. So simulating the infiltrative nature of the tumor, because that is admixed with the brain, may be a little difficult, but we will try and see the principles there. So this is the exophytic component of the tumor. This is temporal part, temporal lobe, which is splayed, and part of the tumor in burying into it. I would go ahead and do an anterior temporal lobectomy also in this case, and start debulking the tumor. Now this, we spoke about end block resection in the previous talk. We talked about subpile resection, end mass removal. This is not a tumor which may be amenable to a classical end block end mass removal. What we will do is we will debulk, we will identify the anatomical extent, functional margins, and then decide if we can go around it. So for now, what I would do is I would complete a temporal lobectomy to have more space and then start decompressing this tumor. I would use a CUSA. We don't have that here, but we would use an ultrasonic aspirator. We can put off the normal light now. Right. So this is we don't have all the ideal instruments. Use a tumor cup forceps. So if you use an ultrasound, one other thing you can do in these cases is to do a Doppler angiogram intraoperatively. In case there are some vessels, MCA branches, or tumor feeders going into this tumor, when you're cutting it, you have to be careful, and it will tell you that. You could also do that angiogram as a check for the sylvian vessels, pre, post, venous as well as arterial. So I'm going to start debulking this. This is going to be piecemeal. As you can see, this is appearing to have an interface, but this interface, as I said, is more of an artifact of the model because of the way it is constructed. I'll have to move it up and down to focus deeper. So can somebody help me with that? Which knob? This one? Okay. What's happening? This is magnification. No, up and down. I want to focus manually. So I'm just trying to see at the depth. Okay. Let's move it back up. This ideally is tumor which is going into the temporal lobe. So I'm going to do a temporal lobectomy. Even when you do a lobectomy, like how you do in epilepsy also, you can do a subpile resection. Difficult to simulate it here in this specimen. This tumor, if the MRI is correct, is going to be burning further into the temporal lobe, and we'll probably see it as we remove. If you remove this temporal lobe part and you send it separately, you will be surprised, or you shouldn't be surprised if you find tumor infiltrating into what looks like normal temporal lobe also. Right, now we have this tumor here. Are you perfusing the MCAs? Not yet, okay. So as we debulk further, what we need to be careful about is the vessels. I'm not sure whether this is because of the artifact, but this was appearing to be a vessel, but I think it's not, because I can see the vessels much deeper. Can I move the microscope a little lower down? I'm not sure whether it's appreciated on the screen, but you can see vessels in the depth. You can see the pulsations. Can you all see that? Yeah. So, I mean, remember, this is a model simulation, but in reality, you might find, especially in perisylvian gliomas high grade, you'll find a leash of vessels coming in from the depth. You may not even see them on the surface or as you're debulking. So, mobilizing like this in that situation is not a good thing. You should still do it piecemeal, layer by layer. Again, as I said, ultrasound with a Doppler is useful. You might consider ICG, but if there's a big tumor sitting on the vessels, it's again difficult to visualize. Doppler ultrasound will show it to you. So since we've seen those vessels now, and we assume there are no other vessels here, we will rapidly debulk the tumor. This is a very firm tumor here. So in that case, I may find it a little difficult to roll it over. Heterogeneous tumor. Some parts are very, very hard. For example, here. And some parts are soft. Maybe you might say there is some calcification, but again, I'm sure this is an artifact, but it simulates calcification in the tumor. Calcified tumors are always more challenging, especially in such regions. As you roll it over, you can get more of the tumor, and always again keep checking. So as I said, because of this model artifact, I would not expect this kind of a plane. It's almost appearing like an extra axial tumor, but you would expect a lot of infiltration, and you have gliosis which you have to separate it from. It is in that gliotic plane at the periphery edge where your adjuncts will help you, because there perceiving the difference and the delineation from normal brain or surrounding brain and tumor is very difficult, even with microscope. If you're using dye, for example, can you shine the dye here now? I mean the UV. We assume this is an infiltrating edge which we are not able to see, but you put up the dye, switch off the microscope light please, and you are able to appreciate this. And trust me, if you're using ALA and fluorescein, I don't use fluorescein, but ALA, you can see this beautifully, the demarcation. And in fact, there is a gradation in the intensity of the fluorescence from strong red, orange to light pink. I need something more sturdy to cut. Do you have another scissor? Okay.
That one is a bigger one. Yeah.
Let's try this one. So keep checking if you are using sharp dissection all around, that you have not pulled a vessel which you would cut if you are not visualizing it directly. All right. So sometimes when you're working with fluorescence, it's difficult to see the normal background illumination. It takes time to acclimatize. Can we switch back to the normal?
Yeah.
Switch off that. I think I've debulked it well enough, and it seems to be well delineated tumor. This is the hard part, and you can see it is turning itself around. But I would think that in real life it won't be so easy. See, it is mobilized, and that's it, it's come out. This is the splayed out sylvian fissure, and you have the vessels over there which are pulsating. Now, in a glioma like this perisylvian, you'll get a leash of vessels coming here, and they would be actually tumor vessels which you should carefully watch, control and coagulate and cut, and not avulse. For example, in a heart tumor like this, especially once it gets mobilized, it is very tempting to just pull it out, but beware, it can rupture, and then in trying to control that accidental injury to that vessel, you might land up damaging the MCAs, M1s, M2s, and also certain perforators in that periphery. So, once you think that you have resected everything, remember these are gliomas and this is a malignant glioma, you need to make sure that you've removed everything that you could have. So, inspect the cavity well. If you have fluorescence, then make sure that all the fluorescing tissue is removed. If this tumor is going further into the insula, then you have to be very careful, because you are liable to damage other substrates, and then you have to plan subcortical mapping. For the temporal lobe, you still have the leeway of doing an extended temporal lobectomy, since this is the right side, and you can complete that. And then finally, what I would do is fill this cavity with some saline, do an ultrasound, and compare it with the pre-op ultrasound, and make sure that all the hyperechoic tumor region is removed, or if there is something residue, it is in a region which I am sure and I know that I cannot remove further because of its location and eloquent substrates. And that would be more or less what we would do in such a situation. If there were tumor fragments, and often that is the case in glioblastomas, it's quite desmoplastic. There's a lot of adhesions there. I wouldn't try and separate it. I would actually leave a small rim over there and remove the rest of the tumor. Okay, so I think that's about it. In case there is anything, anybody has any other suggestions, comments, then we can discuss. All right, okay, so thank you very much.
Thank you, Dr. Moidi, for the engaging simulation session. Now we will move on to the next session on epilepsy, which will be moderated by Dr. Lakindra Singh. Sorry, it will be moderated by Dr. Matthew Abraham. I would like to now invite Dr. Abida Shah for her talk on white fiber correlates of epilepsy surgery.
So everyone can put their 3D glasses on again. Full screen पे है. 3D on कर. So let's move to the next session on epilepsy surgery. 1 3D. So epilepsy surgery, there are 3 types of epilepsy surgery. Resective surgery that consists of hemispherectomy, lobectomy or topectomy. Disconnection surgery where you have a callosotomy, a hemispherotomy and multiple subpile transections. And simulation surgery that consists of vagal nerve stimulation, thalamic stimulation and responsive neurostimulation. So let us look at the white fiber correlates of epilepsy surgery. So the most common and most frequent epilepsy surgery is this surgery for mesial temporal lobe sclerosis, and this is the region where this surgery is performed. So these are the structures that are important for epilepsy surgery. So this structure that you see here is the amygdala, and this is the hippocampus as it is lying in the temporal horn. Here you see there is a connection of the amygdala. It merges with the basal ganglia. So this is the important point to note when you are performing the disconnection, that you cannot cross this line, otherwise you will have a neurodeficit. Now there are 2 ways to perform, there are multiple approaches to perform this amygdalohippocampectomy. We use the middle temporal gyrus approach and use this safe entry zone as I have described in my last lecture. There are, Yasser Gil described the trans-Sylvian approach to the amygdala and the hippocampus. He's coming through the Lyman insulae. Afterwards, he modified his approach and started entering from this region, so to avoid injury to the uncinate fasciculus. Supracerebellar tentorial approach has been described to reach the mesial temporal structures and remove this. And also some people come through the inferior temporal gyrus and through the collateral sulcus. So, but this is the basic anatomy, and this is what you have to remove. This, if you do a selective amygdalohippocamectomy, these are the structures that will come. If you do a temporal lobectomy, then you remove this whole mass of tissue along with going right up to the pia. So in the, we've already seen this anatomy, I'll just go quickly. So this is the important thing you have to remember. So this is the amount of tissue that you will be resecting. Of course, you will be sparing the superior temporal gyrus. So on the base, here you see the uncus. Here you see this is the head of the hippocampus. As it is, if you trace this down, it will be the head of the hippocampus. And here if you trace, it will be the amygdala. The boundary here is this pia that will be there. Beyond this pia, there will be the brainstem, and you cannot violate this pial boundary when you are operating and doing MTS surgery. The other important structure that is relevant here is this optic radiation. So if you see clearly, the Mayer's loop originates here in the lateral geniculate body and turns in the roof of the temporal horn. So anteriorly, the Mayer's loop is in the roof of the temporal horn, and posteriorly, it is in the lateral aspect of the temporal horn. So as we can see, that this is the mesial temporal structures, and this is the seat of epilepsy, the parahippocampal gyrus, the hippocampus, and the fimbria, and going to the fornix. So these are the structures that you're going to disconnect when you're performing a mesial temporal resection. We've already seen this image. Now when you're doing the dissection, you see here, so what happens to the hippocampus? When the parahippocampal gyrus turns, it turns on itself at the subiculum, and the infolding is the hippocampus, and beyond that you will have the dentate gyrus. So if you see this image, here you see the hippocampus. On top of that hippocampus, you see this white structure, that is the fimbria of the fornix. Then you see these denticulate structures that you can see here. So this is the dentate gyrus. You can see it very nicely, the denticulations. I have put this forceps here. This is the radiation of the cingulum as it is ending here in the entorhinal area. And of course, this is the Papez circuit which we have seen previously. So this is the anatomy of the hippocampus. Now this is the safe entry zone that I talked about. So you see, this is the roof of the temporal horn here. Here the fibers are in the roof more posteriorly than the lateral aspect of the temporal horn. So this is what you have to preserve. You have to preserve this Mayer's loop of optic radiations as it is curving. So you saw it is originating in the lateral geniculate body, then turning here, going in the roof and in the inferior aspect. So the hippocampus is hidden. So when I turn this specimen, you will see the hippocampus very nicely in the temporal horn. This place here is devoid of fibers. So if you make the entry here, there will not be any injury to the visual fibers or to the IFOF. More posteriorly, there is a chance of injury. So as I said earlier, there are various approaches to reach this structure. The other important thing you notice in this is the choroid fissure. So the choroid fissure runs between the hippocampus and the thalamus all around in a C-shaped manner in this region. Within this choroid fissure runs the choroid plexus. So these are important landmarks that you have to remember when performing the surgery. Coming next to the callosotomy. So once the second more popular surgery is this callosotomy. So when you're performing the callosotomy for epilepsy surgery, you have to disconnect all the way here from the genu and go all the way back to the splenium. If you leave this part of the splenium or some part of the motor corpus callosum here, the epilepsy will not go. There are some people who have described only an anterior callosotomy or sometimes a posterior callosotomy, but to get a complete remission, you should perform this whole callosotomy from the genu all the way back to the splenium. So the corpus callosum is actually quite a magnificent structure. It has a lot of radiations. For the purpose of epilepsy, this is the disconnection. So you're basically disconnecting the dorsal and the ventral callosal radiations right in the midline. So you enter down, then you go through the fornix and you disconnect that also. So now you see from the top, this is the top view. These are the dorsal callosal radiations that you can see curving superiorly. And this is the cut that you will make right in the midline, all the way from the genu, all back to the splenium. So this is when you're coming interhemispheric. So when you're doing a hemispherotomy, you have to perform an intraventricular callosotomy, and that is when you come from the lateral ventricle and the temporal horn. So this is for the intraventricular callosotomy, you will actually come from within this, and you have to disconnect all these fibers. Along with that, medially you will reach the corpus callosum, and then you disconnect it from within the ventricle. So I will show that in later images. So this is just a view of the corpus callosum. I just want to show these fibers. So this is the posterior ventral callosal radiation. This is actually the tapetum. That is the last layer of the sagittal stratum, and it covers the atrium and the temporal horn here, and this whole thing will get disconnected. So this is for corpus callosum. What are the important landmarks? When you're coming from superiorly, pericallosal arteries have to be displaced, and then you perform the callosotomy. You have to go all the way down till you see this pia and arachnoid of the quadrigeminal cistern, and you see these internal cerebral veins and the galenic system. If you're coming from below, if you're coming from inside the ventricle, you have to go up till you see the pia of the pericallosal arteries, and you don't breach that. So that is for callosotomy. The next part is the hemispherotomy. So the principle of hemispherotomy is that you disconnect the central core of the brain from the rest of the cerebral hemisphere. So the central core of the brain is connected to the cerebral hemisphere by a structure called as the cerebral isthmus. So the cerebral isthmus is actually surrounds the insula, and it is consisting of the extreme external and internal capsule, and they all meet in this region of the limiting sulci. So if you see this structure, this is the central core of the brain. So what you have to do is you have to come all the way from the frontal horn, come here to the, I'm just describing the principles, the technique I will show you. So frontal horn, you come all the way, you have to disconnect the anterior limiting sulcus, you have to disconnect this inferior limiting sulcus and the temporal stem, then you have to go around and disconnect the superior limiting sulcus, and then from within you perform the callosotomy. So you're disconnecting the central core from this ipsilateral hemisphere, and you're disconnecting the central core from the contralateral hemisphere by performing this callosotomy. So this is, in principle, this is what you're going to do. You're going to take the cut all the way around and come here and join the atrium and the frontal horn to each other. So I will show that in the dissection. So this image I will not show. So now this structure is important. What is the temporal stem? So this region here, and the region between the inferior limiting sulcus and the roof of the temporal horn, these fibers that come in this region is the temporal stem. And so this is when you start doing your resection, you can either do a perisylvian hemispherotomy, or you can make suprasylvian windows and then perform a hemispherotomy. For that you have to enter the ventricle, but if you're coming perisylvian, your first cut will be in the inferior limiting sulcus. You cut this and disconnect the temporal stem first. Then you come down and perform this mesial temporal resection. So now you have performed this cut and you have entered the atrium of the lateral ventricle. So when you enter the atrium, so this is the inferior limiting sulcus, when you enter the atrium of the lateral ventricle, will be just beneath this posterior insular point. You go above and disconnect this whole fiber system all the way from the back till you reach in the front here where you see the anterior insular point going to the caudate head. So you have disconnected this whole area from the cerebral hemisphere, and this whole region is actually called the region of the cerebral isthmus. So this is just the image. So ultimately this is what you'll have. You have disconnected this whole area from the rest of the cerebral hemisphere, and then you will go ahead and perform the callosotomy from within the ventricles. And the last bit will be connecting the frontal basal regions, where you will connect the go from the orbitofrontal region, disconnect the gyrus rectus and the orbital gyri, and enter the frontal horn and the caudate nucleus below it. So that will complete your disconnection, and you will disconnect the whole disconnect the central core from the hemisphere. So this is just the last slide. This is an example. Patient was a young child with an MCA infarct and had continuous seizures. You see the pyramidal tract on this side is hardly there, and this side it is robust. So when you perform the disconnection, this is what it looks like. So you see here the frontal horn has been connected. This is the first cut through the anterior, not first cut, this is the cut through the anterior limiting sulcus, going and connecting the basal part of the brain. And here you see on the lateral view, the whole central core has been disconnected. And here you see the last cut that is going through the atrium. So these are some white fiber correlates of epilepsy. Thank you very much.
Thank you, Dr. Shah, for your talk. Next, I would like to invite Dr. James Joss for his talk on complex partial seizures and psychomotor epilepsy clinical features, which will be followed by his next talk on newer anti-epileptic drugs.
Good afternoon, everybody. I will try to make this complex seizures simple for neurosurgeons. See, complex partial seizure, the clinical phenomenology, you can divide into an aura, a behavioral arrest, and an automatism. So in every complex partial seizure epilepsy, you should remember that you should try to differentiate between the aura, then you have to delineate the behavioral arrest, and then automatism. Sometimes you may get only the aura, then you call it as simple partial seizure. When the aura is associated with a behavioral arrest, then it is called complex partial seizure. So the essential part of a complex partial seizure is the behavioral arrest. They can have aura, they may not have aura, they can have automatism, they may not have automatism. I will explain what are these phenomena. You know that these complex partial seizures are characterized by aura, which are usually psychic in nature, and automatism, which are bizarre motor phenomena. So, combining them together, the old terminology was psychomotor seizure. That is why the complex partial seizures are named as psychomotor seizure. Nowadays, we classify them into different groups and all. For the beginning, the residents, this sort of classification is more useful for their clinical analysis. Now you have to see what is aura. Aura is a subjective experience. Subjective, only the person can identify that, manifesting as unusual sensations or feeling. This aura always indicates the focal origin of the epilepsy. It can occur in any type of epilepsy. When it arises from the occipital lobe, it may be a visual flash. When it arises from the parietal cortex, it may be a sensory phenomenon. When it arises from the motor cortex, it may be a partial motor phenomenon. So aura just indicates that this is the site of origin of the epilepsy. In a complex partial seizure, that sort of phenomenon is called Gemaivu. That sort of phenomenon is called Gemaivu. The next aura is what is called cognitive aura. Depersonalization and derealization. Depersonalization means that you feel that you are no more. Your personality is no more. You have changed some way. Derealization means that your environment has changed. The classroom has changed into an auditorium. A big meeting has changed to a place where only few people are there. So this sort of environmental change is called derealization. Then sometimes affective auras are there, like panic, fear, sadness, joy, and ecstasy. Autonomic auras are there, palpitation, gastrointestinal symptoms, sensory auras like olfactory and gustatory. These are some of the common auras which you will encounter in complex partial seizure. Of this aura, one aura which is ecstasy is very peculiar. You know that this Russian writer, Dostoevsky, who wrote The Crime and Punishment, has got ecstatic epilepsy. Many of his characters, if you read these books, you can see that many of his characters are influenced by his epileptic aura feeling. He himself has described that for several brief moments, I feel a contentedness which is unthinkable under normal conditions and unimaginable for those who have not experienced it. At such times, I am in perfect harmony with myself and with the entire universe. Perception is so clear and so agreeable that one would give 10 years of his life and perhaps all of it for a few seconds of such bliss. So he was blessed with this ecstatic epilepsy. Now, the second component is behavioral arrest. The behavioral arrest has two components. One is altered awareness and altered responsiveness. Altered awareness means that patients don't feel where they are. Their environment they cannot perceive. Altered responsiveness is a objective phenomenon, where altered awareness is a subjective phenomenon. Altered responsiveness is a objective phenomenon. If you call the patient is not responding. That is what is meant by altered responsiveness. This altered responsiveness indicate spread of the epileptic activity. In a mesial temporal lobe seizure, this behavioral arrest indicates spread to the thalamus. And in other epilepsies, other complex partial seizures, especially in lateral temporal lobe epilepsy and all, it indicates the spread of the epilepsy to the attentional network, which is constituted by the frontoparietal network. That will result in this behavioral arrest. And the final component is what is called automatism. The automatism is a more or less coordinated motor activity during the phase of behavioral arrest. See, patient will do a lot of motor activity which is more or less coordinated. And the most important thing is it should not have an existence by itself. Aura has got an existence by itself. Whereas automatism you can call only if it occurs during the period of behavioral arrest. One thing medically important is many criminals may be taken to neurosurgeons or neurologists because they may have an epilepsy in the background, and the defense is that he did this criminal act during the epileptic phenomenon, and the automatism is the one which has caused the crime. In such situation, what you have to see is this automatism always occurs during the phase of a altered awareness and responsiveness. So it is never a purposeful or target-oriented one. If he do a stab, the stab may be anywhere in the body, but if you see that the stab is to the chest or to the neck at the carotid, that means that this is likely a purposeful act. It's no more a automatism of this one. A criminal may commit a rape during the automatism, but you should know that it's always a discoordinate movement or act which may finally end up in a rape, but never a coordinated act. That is how you break this defense of the criminals. So different types of automatisms are there. One is oro-elementary, normal eating behaviors like lip smacking, chewing and swallowing. The other is what is called vocal automatism, where there is vocalization. Patient may say nonsense words or even coordinated words during the vocal automatism. And gestural automatism, where patient may attain different types of hand movements and gestures. Ambulatory automatism, patient may run amok, they may run away from the scene. And sexual automatisms like masturbation, sexual activity, pelvic thrusting, all these are described. And there is a automatism which is called mimetic automatism, which is emotional expressions may be coming to the face of the patient. See, if a person is feeling fear, it is an aura. If a person appears frightened, that's not aura, it's automatism. That is the difference. Automatism you should be able to observe, whereas aura only the person, the epileptic person can perceive. Now, if you see, there are certain seizures where there are dramatic automatisms, like what is called gelastic seizures, where there is sudden, uncontrollable laughing or smiling. Surprisingly, this gelastic seizure with automatism is seen usually with the hypothalamic hamartomas. And if you see the literature, 90 to 95% are produced by the gelastic seizures or by the hypothalamic hamartomas. And there is a variety which is called gyrating epilepsy, where patient will rotate during the epilepsy. This rotation is actually an automatism, and this is what is called gyrating epilepsy. Now, if you see the epilepsy, the complex partial seizure. It may be, as I have shown, it may be an aura, a behavioral arrest, and automatism. All the components may be there. Sometimes you will see that the aura is missing, because the aura may not be there because it is so short, or it may go amnesic. Patient may go amnesic for the aura. Then the behavioral arrest and automatism. Only the behavioral arrest and automatism. And finally, you may see that the first and last component is not there, only behavioral arrest. Patient may stand or sit blank for some time, for a few minutes or seconds, and then regain the consciousness. So you should remember that the common denominator for a complex partial seizure is behavioral arrest. Without that, there is no complex partial seizure, and aura can exit by its own. Now, we all think that a complex partial seizure is mesial temporal or temporal lobe origin, but remember that complex partial seizure is a general term which can occur with any lobe where there is three phenomena are there. You can call it as complex partial seizure. The peculiarity for the frontal complex partial seizure, it is characterized by the absence of aura, hyperkinetic automatism. The automatism is so dramatic and violent. They are all called hyperkinetic seizures. And gestural automatism. Patient may assume different positions, like Fencier's position and all. That is the peculiarity of frontal seizure, complex partial seizure. If it's an orbitofrontal, you will see that metallic taste in the mouth. If a patient is saying that he has metallic taste, it means that orbitofrontal. And amygdala, it is the origin. The fear is the aura. And lateral temporal, a buzzing sound. You know that the auditory centers are there. Buzzing sound in the ear indicates that it's a lateral temporal. And insula, never underestimate insula. It is the visceral brain. You all know that is a visceral brain. Previously, we think that the things are ending. The pain is ending with the thalamus, but you know that this is the insula, which is, so the aura can be choking sensation, gustatory, epigastric sensation, and burning pain. Thank you. I will go to the next talk. The most difficult thing which I have faced probably in my talk is to talk about the newer anti-epileptic drug in 10 minutes. It is as if you are trying to contain all the water of the sea in a small pot. So I don't know how to, I will give an introduction, how the anti-epileptics are there, how they can be, what is their evolution and all. So the story of anti-epileptic start in 1857 when bromide is used as anti-epileptic for the first time. All the drugs which were developed from 1857 to 1985 were considered as the first generation or the older anti-epileptic drug. You can see that conventionally with the used one phenobarbital, phenytoin, primidone, ethosuximide, carbamazepine, clonazepam, valproic acid, clobazam, all are considered, benzodiazepine, all are considered as the first generation anti-epileptic drug. Now, what was the problem with the older or first generation anti-epileptic drug? Narrow spectrum, lack of good efficiency, side effect profile, drug interactions, or teratogenicity. These were the main problems with the older anti-epileptic drugs, and we were not at all happy with that drugs. The newer anti-epileptics were developed to have a broader spectrum, increased efficiency, decreased side effect profile, less drug interactions, and less teratogenicity. And we are happy to know that most of these targets are met with the newer anti-epileptic drugs, probably except the increased efficiency. Many of the cases we cannot claim more efficiency than the previous drugs. Now, if you take the history from 1990 to 2009 is the period of second generation anti-epileptics. You are all familiar with these drugs. I am sure that most of us have used at least once. It started with the story of gabapentin, which was introduced as an anti-epileptic drug in 1993, but changed its shape and form to form a pain modulating drugs. Then comes the lamotrigine, which is still widely used anti-epileptic because it's of broad spectrum. I may say that after the sodium valproate, which is an old generation one, lamotrigine is the first broad spectrum anti-epileptic which was introduced. Then comes the topiramate. Topiramate is still surviving in the field because it has got tremendous anti-migraine effect, and you know that many times migraine and epilepsy are sisters or brother or twin brothers. So in such cases, using topiramate is very useful. And then comes the oscarbazepine. Oscarbazepine is developed because you know that carbamazepine and its skin reactions and systemic problems associated with that. So the oscarbazepine was developed, considered to be more effective than carbamazepine, but one problem is their hyponatremia. Hyponatremia is the problem, and you know that all our South India people are very much worried about the hyponatremia. Everybody knows hyponatremia, so if possible, don't use it after the age of 50 or 40 because of the risk of hyponatremia. Levetiracetam I need not explain to this society. And then comes the sonisamide, which we sparingly use because it was developed by the Japanese people naturally, that they have got resistance from American side, FDA approval problems, and also it is still lagging. Then comes the pregabalin, which has now sidetracked to the pain management. And then comes the lacosamide. I will say that of the second generation drug, the one which is very good, effective is lamotrigine, levetiracetam and lacosamide. I will say that lacosamide is much safer and better than levetiracetam, but you know that the trend and marketing trends are more for levetiracetam, so it is universally used more than lacosamide. If you want a safer drug than levetiracetam, use lacosamide. And then comes the third generation one, which developed from 2011 to 2020. Of this group, S-carbamazepine. S-carbamazepine is developed just because it is as equal effective as oscarbazepine, but the risk of hyponatremia is very less. Of the one, carbamazepine, oscarbazepine, and S-carbamazepine, this one has got minimal hyponatremic effect, minimal skin allergic problems, so it is safer, but the prohibitory cost is the one which will prevent us from using this one. And the brivaracetam, which is a blockbuster, I will tell something about brivaracetam later. Then comes the cannabidinol, stirpendol, cenobamate, and fenfluramine. Of this third generation, brivaracetam and the cenobamate are going to be the blockbusters. You should remember this statement. While modern anti-epileptic drugs have novel anti-seizure mechanism, their increasing use did not seem to have improved overall long-term seizure control. The modern anti-epileptic drug still lacks the capacity to rectify the underlying neuropathological process and reverse epileptogenesis. Caution, I have already said, lamotrigine, Steven Johnson. It is even better to go for a genetic analysis for this lamotrigine before you start, because sometimes in many of the patients it's called Steven Johnson syndrome. Topiramate, glaucoma, oscarbazepine, hyponatremia, levetiracetam, neuropsychiatric. That is a problem with levetiracetam. Vigabatrin, visual field defect, sonisamide, renal stones, and sibomamide does something like drug-related eosinophilic systemic symptoms, this severe skin reaction. One thing which you have to remember is the safety in pregnancy of newer drugs. It is established that lamotrigine, levetiracetam, and lacosamide are very safe. Unsafe drugs are topiramate and sonisamide. You should not use. Data is insufficient regarding brivaracetam, perampanel, and S-carbamazepine because they are introduced only recently. So we are not sure whether they are safe or not. You see that the advantage of newer anti-epileptic drugs combination, different neurochemical sites are there, channels are there, neurotransmitters are there where these things are acting. So combination will prevent different types of neurotransmitter so that a good anti-epileptic activity can be achieved. Like that, inhibitory neurons are there. They can also be utilized for the target of newer anti-epileptic drug. The three drugs which I always prefer is levetiracetam, lacosamide, and lamotrigine. Levetiracetam plus lacosamide is supra-addictive and having no addictive toxicity. Like that, lacosamide and lamotrigine, supra-addictivity and no toxicity. So these two combinations are always very good in resistant epilepsy. Know that levetiracetam and brivaracetam, everybody likes levetiracetam. All doctors like levetiracetam, but most of the patients dislike levetiracetam. That is a fact. I stopped using levetiracetam for the last 2-3 years because of his intolerance and patients, the depression. You know that we are seeing a younger generation who are already depressed because of so many reasons, and epilepsy itself is a depressogenic factor. And if you start levetiracetam, they will definitely have neuropsychiatric problem, cognitive darling, all sort of problems are there. Patients comes to us to requesting that somehow you change this new drug. I am not tolerant at all. This is the statement. Whereas brivaracetam, for the last 3 years I use only brivaracetam instead of levetiracetam. I am very happy with the brivaracetam. Only thing it is 10% more costly than levetiracetam. That's all. But the dosing and other things are same. The spectrum is almost same. Only thing we don't know the teratogenic potential. So many advantages are there for brivaracetam. Selective high affinity SV2 ligand, rapid onset of action, rapid. So the same day it has got the full effects. Increased efficiency, decreased side effect profile, less drug interaction, may have anti-epileptogenic potential. This is the only drug which was proposed to have a anti-epileptogenic potential. Cannabidinol, stirpentol, and fenfluramine, they are introduced for specific indication. That is Dravet syndrome and Lennox-Gastaut syndrome. These are two epileptic syndromes in children which are resistant to all our medications. These drugs are tried and found to be very useful. Of the level, it is all cannabis. This drug is extracted from cannabis sativa, you know. And the cannabinol is the psychotropic drug, and cannabidol is the medication. It has no psychotropic action. You know that after the introduction of cannabidol, more than epilepsy, it is used for off-label indications such as psychiatrist, anxiety, pain and all. I don't know how far it is justified and useful. And now comes cenobamate. It is not still marketed in India, going to marketed in within next 3 to 6 months, and it is considered as the game changer. Of the new anti-epileptic drug, it is said that this is the game changer. Refractive focal epilepsy, generalized seizure monotherapy. Its mechanism is voltage-gated sodium channel modulation of GABA receptors. And the problem is it has got DRUS, skin reaction, and short QT syndrome is a contraindication. Thank you.
Thank you, Dr. James Jones, for your talk. Next, I would like to invite Dr. Ashok Pillai for his talk on temporal lobectomy and amygdalohypocampectomy.
Thank you. My gratitude to the organizing committee, Dr. Pandey, Professor Ghosh, for having me again and for having this session on epilepsy. It's always a pleasure to come back, and I look at the Dandy sessions now as, apart from contributing and teaching the younger generation of neurosurgeons, I also gain something. I become a better neurosurgeon in so many other areas. So thank you. And thank you for having this session as we move on to what I call surgical epilepsy. Surgical epileptology. So my job is somewhat made easier by the excellent 3D tour through the brain anatomy of epilepsy surgery done by Dr. Shah. But now imagine that that same models now have blood flow, you have a connectivity, you have real neuronal activity. We have to, before doing the surgery, you have to match the surgery to the epilepsy. So I teach all my fellows in epilepsy surgery, you have to be as good an epileptologist in EEG semiology as your neurologist is in reading an MRI. You have to be talking the same language so that you can match the procedure to their illness. So temporal lobectomy, this was described by Dr. Pete Engel as the most underutilized surgery in the 1900s. Lo and behold, it may become even less utilized in this century. But it's one of the rare surgeries in clinical neurosciences that has an excellent outcome with an acceptable side effect profile. So, but it is one of the reasons, especially when I was recently in the US practicing, I noticed that obviously there's a well-described trend towards minimally invasive thermal ablation in temporal lobe epilepsy with actually inferior seizure outcome. So I was trying to understand what is this. But as somebody who teaches people to do temporal lobectomies, it is one of the most difficult surgeries for people to learn. And I think a lot of this shift to the minimally invasive ablation things are partly due to the difficulty of learning this and being able to give results. And it has even been shown in a matched non-inferiority trial, which is about as good as you get to an RCT, that it is inferior in giving seizure outcome. And throughout epileptology research, seizure outcome has been the single most important thing in determining the quality of life of somebody with drug-resistant epilepsy. And this is being, in this publication from 2025, this is being re-examined by other Western societies, like, are we really moving away from the right thing? So, as a tool in the surgical epileptologist, I looked at our numbers of patterns over the years. Each group here is like one epoch of 3 years. And temporal lobectomy, the green bar, still turns out to be one of the workhorses of epilepsy surgery. As an apex center referral for the difficult epilepsies, we get a large number that have to undergo invasive monitoring with stereo EEG, and many of these numbers bleed out into temporal lobe surgery, which I'm going to describe today, and then extratemporal resections, and then you have the other disconnections. So for the younger generation, these are the standardized surgeries for temporal lobectomy, and I'll be talking about primarily the standard anterior temporal lobectomy with amygdalohypocampectomy. Okay, this is my incision. The points I like to make about that is I use a myocutaneous flap, which gives mechanical support and tethering to of the temporalis to the scalp. Blood supply to the temporalis is preserved. You shouldn't cook it with the monopolar, and you will have no temporalis atrophy in any temporal surgery that you do. So it's a standard pterional positioning with a vertex tilt. Okay, now for the surgical anatomy, we're seeing it from the top, so that's how we number T1, T2, T3. So I divide it into cuts like this. T1, this is my approach. I make a cut through vertically through T2 and T3, and then this cut is joined up to the planum polaire. So let's see, well, let me take you to see. So you can see cut 1 also again coming down to the collateral sulcus here. You have to identify the collateral sulcus, followed up to the collateral eminence, and that will be your entry into the ventricle. That is very key because missing the ventricle then is a disaster in temporal lobe surgery. Okay, and then we enter the ventricle from there. So let me see. Sorry, this is suddenly. Trying to get this full screen. It's slightly different now. It's not. Yeah, we had checked it there. It was playing. Oh, it's down here. I'm sorry. Yeah. Okay, sorry. Here we go. My apologies. Okay, so this is the T2 and T3 cuts. Okay, and then I like to always see the base. So my craniotomy should be enough to see the base so that I can count up from there. The biggest mistake is to start high and then go over the temporal horn and keep going deep, and you may even reach, the basal ganglion internal capsule. So find the ventricle, get in, and the angle for that is very important. You need the hippocampus and the ventricles are C-shaped like this. If you go too posterior, too anterior, you'll be missing it. Okay, and then we connect the ventricle into the T2 cut. Okay, we're in the ventricle now. This is extended into the T2 cut following the superior temporal sulcus all the way up to the planum here. Now I'm going to come across into the planum, and this takes me to my cut It's going slow, I'm sorry. It is not the same as when we did it there. It is not letting me go back to the keynote. If you're seeing it there, okay, that's fine. I'm not seeing it here, that's okay. Okay. I'm sorry, So I'll come around the planum polare, which is the extension of the temporal pole up to the Lyman insula, come across the planum polare, and then bring that medially through the entorhinal cortex, and then from the base you have to come around, join your T3 cut up to that, and then open this up, and then the temporal lobe, the anterior temporal lobe comes out. So I'll try to skip through this. It's hung? Okay. We had checked it there, I don't know why. Okay, let me see if I can present for you from here and then avoid the video. Okay, so this is the cut 3 coming along the planum polare. You can see basally coming to the base there, and then cut 4. And this is, as you saw, then you have the small stem, which I would have shown you in the operative video, but I think we cannot go to that. Okay. I apologize for that. It was checked earlier then, it was running okay. So a little bit in the operative video I show about the retractor placement, and this is something that is very important, the depth of the retractor. The main thing is that you have the brainstem here, and so the retractor is essential. I know some surgeons who don't use a retractor, and they have a technique in which you systematically take out the amygdala or the hippocampus and avoid retraction. So it's a choice. If you decide to use a retractor, make sure that I like to angle the retractor either anteriorly, or just underneath the amygdala, or posteriorly, parallel to the hippocampus, mainly so that we avoid any damage to the brainstem. Okay? So this is for the younger generations whenever you're doing a temporal lobectomy. Now the anatomy of releasing the hippocampus. Now that we've taken the anterior temporal lobe out, I like to identify a point here. It's given a name, but I can't remember. And you can see the anterior choroidal fissure here. Generally, it's unfortunately, I cannot try to go back to the video. Okay, here we go. So you can see it there. Okay, now that is the posterior hippocampus, and maybe I can come back in that. Yes, I can come back with just, okay. Here we can see now, identifying that point, the choroidal fissure opening. And I teach all my fellows that whenever you have to do epilepsy surgery, you like to identify 2 points and then make a cut. So the first point is medially there at the choroidal fissure, and then you're going to disconnect the head here. So I cannot point at it. If you have is this a laser pointer? Okay. And now I like to open up the head of the hippocampus. You'll see the head of the hippocampus being opened up and revealing the hippocampal sulcus. This is essential so that we can strip the hippocampal sulcus of its pia, because all of these vessels, as you can see, are connected to the posterior communicating artery, and to take it out, physically take it out without doing this step will risk avulsion of all those and a vascular catastrophe. So this is the anterior, okay. Now this is the posterior retractor placement, parallel to the hippocampus. Okay, and this is, I found over time when I try to get my fellows to learn that these steps are actually very difficult. You know, sizing your retractor, getting it in, lifting it up without damage to the external superior temporal gyrus, these are all important points. And we do the same posterior hippocampal sulcus stripping, and then from the posterior hippocampal gyrus we can disconnect it. Now this is the lateral cut, unfortunately. Okay, I think, okay, now I can do it here, yeah. So this is the posterior, that was the anterior done. Now the head was disconnected, unfolding the hippocampus, which I showed in the video. Now you have the posterior stripping of the hippocampal sulcal pia. That is what I had showed in the video. Now, disconnection posteriorly, you have the parahippocampal gyrus here. I like to do it right there at this step, underneath the dentate gyrus here. Just do that. And then move laterally, and then find the groove here. And then this is just connect this line, the groove laterally. Okay. And then once we get posteriorly, we snip the tail of the hippocampus there. So let me see. I'm not seeing it on my screen here, but yeah, so this is the lateral disconnection. And from the lateral cut, the aim is to come on the medial side of the collateral sulcus pia. And as a surgeon, this helps you reduce the trauma to the Meyer's loop when you do a standard ATL. And then we come to the posterior thing, and they're just snipping off the posterior, and it comes out. Okay, so we move on. Okay, so now we have the hippocampus out. Now, this is important anatomy to understand. It can be phylogenetically, the hippocampus, the mesiotemporal structures are what we call archicortex, right? And there's a certain important, you have the amygdala and the piriform cortex, which are both a part of the archicortex. This piriform cortex, so the important things that we've been delineated in surgical epileptology in the 90s were the posterior extent of resection of the parahippocampal gyrus should be at least 2 centimeters. Surgically for you can find out where that curves around the brainstem posteriorly and use that as a marker. Because this depends, the seizure freedom after the surgery depends on this. And the resection of the piriform cortex. And I found many surgeons finding it very difficult for piriform cortex excision. And the landmark for that is just to follow the pile plane of the, so this is the posterior extent of the parahippocampal gyrus, clearing out the tail of that. And this is very important for determinant for the seizure freedom in standard hippocampal sclerosis. Okay, this will be finishing in just a moment. Okay, that's the posterior most extent of the dentate gyrus. Now, here we're coming anteriorly, and here you have the planum polare. You get a pile plane, and you work that plane, and then now the whole amygdala with its piriform cortex will come down, and you get a neck. So, as was discussed in the anatomy dissection, when you want to disconnect the amygdala from the basal ganglia, you need some landmark. So, I create a landmark here just by taking a horizontal structure and moving it vertically. It now converts that into a neck at the level of the Lyman insula. And then we can now as a surgeon, you can now see a neck here that can be cut. And this will keep you out of the basal ganglia. We'll be finishing up just a moment. This is the end of the video. So this now you have that neck which can be, and it's an AP structure, so we have to take this posteriorly also. This is the amygdala and its piriform cortex, and these are the final structures, anterocoroidal artery, which are seen through the pile window, perforator branches from the PCOM, third nerve, and the, okay. So that is the operative video. And that's basically the surgery. Now, a little bit about the results. Surgical freedom rates in ATL AH range reported from 50 to 60% up to 90%. This is our recent publication on different subtypes of temporal lobe epilepsy, and we were able to show 90%, 85 to 90% long-term seizure freedom and very good drug freedom. And this is related to the technique, I feel. Now, though I have stopped counting after 300, I don't know how many temporal lobectomies we've done as a large center, but I never stopped counting the complications. The complications obviously happen, and a little bit about complication avoidance. Now, I have found that retractor injury to the crus is very important, especially when you're a large team. Just keeping the retractor in there, anything can push that, so size the retractor. Both of these patients had recovered completely. Vascular injury in difficult cases of complicated temporal lobe anatomy have happened. I've never really had a case of persistent aphasia, apart from the nominal aphasia, which is counseled for in dominant temporal lobe epilepsy. Now, there was some discussion about dominance and non-dominant hemisphere. I'm a strong believer in neuropsychological rehabilitation. I work very closely with some other neuropsychologists like Dr. Urvashi Shah, who has excellent data on the long-term impact of temporal lobectomy versus seizure freedom. Now, the neurocognitive side effects of a dominant side temporal lobectomy versus seizure freedom. And most of us who study these numbers using neuropsychological cognitive profiles long-term, dynamically over time, are fairly confident that the risks definitely are justified by the outcomes of seizure freedom. So we don't really have, the nominal aphasia really improves in dominant hemisphere temporal lobe epilepsy by 6 to 12 months. Rare case of hydrocephalus, and we have had one the risk of complications are definitely reported to be higher after age 45. And hence, you have the newer modalities of thermal ablations. This is stereotactic laser amygdala hippocampectomy using a thermal probe. And now the whole question is this what we need to shift to? And just like the previous discussions about clipping versus coiling, we now have this in epilepsy surgery. It's moving towards that to some extent, but at the cost of outcomes sometimes. And I feel that it was very useful for me to learn this also because we can now identify different phenotypes, different temporal lobe epilepsy, and also combine that with the cognitive profile. This is what I offer, what I call high-risk temporal lobe epilepsy are patients with age over 45, numerous medical comorbidities that preclude a craniotomy, anticoagulation, antiplatelets, or even bitemporal. We offer this stereotactic thermal lesioning, but in general, in counseling the patients, I always counsel them that if their interest is in seizure freedom and absolute or relative drug freedom, really the temporal lobectomy is the way to go, and most of them still opt for that. So with that, I want to thank some of my other fellows who were instrumental in making a lot of these slides and videos. Dr. Gopal is now working in Hyderabad at KIMS, and Dr. Nateshan, both of them are epilepsy surgeons and functional neurosurgeons in Hyderabad and Chennai. Thank you.
Thank you, Dr. Ashok, for your talk. Next, we move on to the next talk, which will be given by Dr. Sarat Chandra. It is a virtual talk on corpus callosotomy for DRE. It is a pre-recorded virtual talk.
Good afternoon. At the outset, I would like to thank the organizing committee, Professor Abdul Salim Rauf, Professor Siddharth Ghosh, and Professor Anil Pandey for giving me this opportunity to make this presentation here. Unfortunately, I could not be there with you in that beautiful place because of some last-minute personal commitments. I would be speaking today about corpus callosotomy for drug-resistant epilepsy. What are the current concepts? What is the history? What are the indications? And where are we going in future? Now, corpus callosotomy is part of a disconnective surgery because it disconnects two epileptogenic networks, and these are the other disconnective surgeries. So in epilepsy surgery, fundamentally, we have resective surgeries and disconnective surgeries. Now, these are the techniques where we have introduced minimally invasive strategies, particularly the endoscope for hemispherotomy, corpus callosotomy, and hypothalamic hamartoma. Again, we did a robotic guided radiofrequency ablation. Now, if you look historically, corpus callosotomy was developed in the year 1939, was refined again in 1970s. Unfortunately, it was given the name of palliative procedure, which I really don't like because palliative is a word which we like to use for some terminal kind of illness. Now, this is not a term. I have found that corpus callosotomy has given some of the most satisfying results, particularly for patient and more for the caregivers. I prefer the name seizure reducing surgery. Now, corpus callosotomy could be used as an alternative to VNS and in the recent study, we could try corpus callosotomy if VNS fails. It could be done as a single or a phased procedure, but I always prefer to do it in a complete single stage procedure. Now, the most important indication is for drop attacks, but it can also be, it is also very useful for Lennox-Gastaut syndrome, which is called as the GBM for epilepsy because it's a syndrome with dismal prognosis with multiple type of seizures, and this is the only treatment which can provide. Some people have shown that corpus callosotomy can provide better localization if the initial investigation have not shown any good localization. We were part of this large multicentric multinational study where we have demonstrated that there is a significant value of corpus callosotomy if this VNS doesn't or is not very effective in children with Lennox-Gastaut syndrome. And it has been shown that there is at least 50% reduction of drop attacks and other seizures in 83 and 60% respectively. Now, when we assess the outcomes for corpus callosotomy, we don't like to use the usual Engel and the ILE grading. Overall, there is about 70 to 80, sometimes even 90% reduction of seizures in more than 50, 60, 70% of the patients. So if you see, it's actually much more than the VNS. So when we do the corpus callosotomy, it should come strictly in the midline, and we should open up the cavum. It's very important that we should not go into the ventricle, but rather we should come down to the cavum. Now, this is a case which I did several years ago. This is the pre and this is the post-op, and the child was having 10 to 15 drop attacks a day, and you can see that the child wears a helmet. So it's very important that when you retract the hemisphere, it should be a dynamic retraction with the help of a suction and a cotton. And it's also very important that all the vessels should be preserved well, and you should not go on cauterizing any vessels because already the patients are compromised. So only those vessels on the corpus callosum may be cauterized and then cut with the scissors and then opened up with the blunt dissector. And this opening should be strictly in the midline so that one exposes the cavum and not the ventricle. And you can see that cavum is very beautifully exposed here. And I never found any restriction of the size of craniotomy in order to do a complete corpus callosotomy. Even with very small sized craniotomies, I was able to do a complete corpus callosotomy. Unlike some surgeons who say that they require 2 craniotomies to do, I never found the need for that. And you can see that we have gone up to posterior part and the corpus callosum now is completely divided. We were among the first to use endoscope for epilepsy surgery, and we developed new techniques using endoscope for hemispherotomy as well as for corpus callosotomy. And these are some of our seminal papers which we published. And we use the standard endoscopic equipments. I will skip the videos. And this is the paper which we published, where for the first time we showed an endoscopic assisted technique not only for corpus callosotomy, but combining it with anterior, hippocampal and posterior commissurotomy for the first time in the literature in Lennox restored, with which we were able to attain very good results, which I will show you in a few minutes from now. So over here, we do a small craniotomy. We split the corpus callosum in the cavum so that cavum is exposed. Then we cut the anterior commissure, and then we cut the posterior commissure, which is like a hood on top of the aqueduct. So anatomically, if you see, the anterior commissure connects both the temporal lobes and olfactory tracts, olfactory gyri, which are highly epileptogenic area. Similarly, posterior commissure connects the subcortical areas, which have been very much implicated in epileptogenic propagation. Now, literature-wise, if you see, Glure and Watson were combining commissurotomy with corpus callosotomy, but they gave it up because of septal infarcts, because they were doing it without the use of microscope. But now in the era of microscope and endoscope, the magnification and visualizations are excellent, and we can save all the arteries, preventing septal infarcts, which can lead to, again, cognitive disabilities. And embryologically, if you see corpus commissures, they form one day before the formation of corpus callosum, and they form a scaffolding or a temporary roof-like structure for the formation of corpus callosum. And they do connect very primitive epileptogenic, potentially epileptogenic areas, and hence there is a reasonable logic in doing its disconnection in order to attain better seizure outcomes. Now, this was a photograph which was sent to me by Ashwini, where this was a patient who had a congenital agenesis of corpus callosum, where clearly by putting an SCG, they show transmission of seizures through the corpus callosum, and hence demonstrating for the first time in the literature the SCG evidence of transmission of seizures through corpus callosum, through the anterior commissure, I'm sorry. So I'm just showing you a short video of endoscopic technique of corpus callosotomy and commissurotomy. So we start with a small craniotomy of 3 into 4 centimeters on one side. We take in the endoscope right from beginning. So initially the brain could be tight, but as you go on patiently releasing the CSF, it becomes relaxed. We always start with splenial disconnection. That is the toughest thing. And once it's done, rest of the corpus callosal sectioning is very easy. So we cauterize with bipolar, section it with scissors, and then with ball dissectors. and then we go on opening it till we expose cavum. Now, endoscope is very useful to magnify it so that we ensure that there is a complete disconnection of splenial fibers. And as you can see, we are ensuring that the splenum has been completely disconnected. Now, then we continue doing disconnection of corpus callosum more anteriorly. We keep on proceeding more anteriorly till we disconnect the genu also, expose the cavum, and then we start disconnecting the anterior commissure. And after doing this, we open up the cavum further so that we get into the third ventricle. And then here we expose the posterior commissure, which forms a hood over, over the aqueduct. And then using a scissors, we just cut. It's a bundle of 50,000 axons. So it's a very nice procedure, and you can cut it. And after doing that, you see the aqueduct. And we ensure that there is no bleeding, complete hemostasis, irrigated nicely. And you can see it's done from a very small opening. Now, this was a patient who had a hemimegalencephaly, was having 5 to 10 seizures a day. Now, he was 16-year-old. Obviously, we couldn't do a corpus in a hemispherotomy. So we did an endoscopic corpus callosotomy with commissurotomy, and he had a significantly good outcome, even though the seizures did not disappear completely, but he was just having 1 or 2 seizures once in 6 months, which was quite acceptable to the patient's caregivers and attendants. Now, when we compared our cases of corpus callosotomy with commissurotomy, we found that it was superior in controlling drop attacks, which is the most aggrieved, which is the most disabling symptoms for the patient. And we found that we could control drop attacks in 100% of the cases whenever we combined corpus callosotomy with anterior, posterior, and hippocampal commissurotomy. Now, this is a patient who was a 10-year-old male where we developed this new technique, which I would like to briefly show. He was having 10 to 12 seizures a day. As you can see that it was non-localizing, there was no localization. So here we did a robotic guided radiofrequency thermocoagulation of the corpus callosum, which we did just through one twist drill using a single suture. And this is first of its kind of technique described in the literature. So by using 4 or 5 twist drills and using an oblique trajectory, we were able to do radiofrequency thermocoagulation of the entire corpus callosum. So here you can see how it looks on CT scan, post-op, and this is the MRI. And so we burn the corpus callosum away from the midline on the affected side, on the non-dominant side. And we do it just by using 4 or 5 twist drills and with a single suture using the robotic device. So we have done this procedure in about 5 patients, and our initial results have been quite encouraging, more than 75 to 80% relief of the symptoms, with reduction more than 90% of the symptoms. So we find when we compared a series of open versus endoscopic with commissurotomy versus radiofrequency coagulation, we find that all of them more or less have an equal outcomes, with the best outcomes being for endoscopic and commissurotomy, endoscopic CC with commissurotomy. And the initial results for radiofrequency ablation has also been encouraging. But it's an ongoing study. It's still, we are just seeing, because it's a new technique. We got the ethics approval and we are seeing how we can do it. So summarizing, corpus callosotomy is an effective procedure to significantly reduce the frequency and intensity of seizures. It's most effective in LGS, also useful in non-LGS without drop attacks. Best performed in young children less than 9 to 10 years of age. It may be performed in adults, but also, but the problem is they may require a prolonged ventilatory support and a longer course. Now, endoscopic corpus callosotomy with commissurotomy in our experience has been best in reducing drop attacks in 100% of the cases and over 63% reduction of seizures, demonstrating that whenever we cut the commissures, the outcomes are much better. However, the above may be performed, should be performed only in children with severe LGS and severe cognitive disability. Now, robotic guided radiofrequency ablation of corpus callosotomy. Corpus callosotomy is a new technique which is currently under evaluation by us. And the initial results do seem very promising. So thank you once again for giving me this opportunity.
So, Dr. Ghosh, am I audible?
A glial scar or encephalitis, a tuberculoma or parasitic cyst, and sometimes there won't be any specific pathology also. But when we saw the slides, there was something which caught our attention. So these are the neurons here, right? So this is the background neurophil. What I marked in the arrows is some bluish, dirty, like some dust-like things were there. So which caught our attention. If it is an elderly gentleman, I would have thought it could be a degenerative phenomenon, what we call it as a corpora amnesia. But patient is a young adolescent. So just to compare with a normal brain parenchyma, so this is the normal brain parenchyma here. You can see the neuropil here, right? So it's kind of clean, but this is our case. If you see, so you can see without any special stains also, some bluish globules were there. So we went ahead with the stain called PAS, that is periodic SIF, just to demonstrate glycogen. So if it is a glycogen, it will be PAS positive but diastase sensitive. But this was PASD, that is diastase resistant. But if you can see the background, full this pink color globules is there, right? So definitely I was convinced that we are seeing something pathological here. And when we had a close look, there were these eosinophilic globules within the neuron also. So this is a neuron. This is called the pericardia or cell body of the neuron. So within the neuron also, there were many inclusions, right? So you can see the eosinophilic inclusions within the neuronal body. So it is called Lafora disease. So Pranav was telling about the Lafora. It's an autosomal recessive and severe form of progressive myoclonic epilepsy syndrome, which is characterized by a triad of seizures, cognitive decline, and myoclonus. So they typically manifest in late childhood or early adolescence. And it is basically an impaired glycogen metabolism. It is caused by mutations in two genes which encode for a protein called laforin and malin. So these proteins, they form a complex and they are participate in the glycogen metabolism. In their absence, the glycogen precipitates because it's an abnormal glycogen. So normal glycogen is soluble, but this abnormal glycogen is not soluble, so which precipitates as Lafora bodies. And not only in brain, they accumulate in liver, skeletal muscle, heart, and even sweat glands of the skin. So they are also called polyglucosan bodies because they represent abnormal insoluble glycogen. And in fact, these inclusions are the reasons for the progressive neurodegeneration and intractable epilepsy. Skin biopsy from maxilla is commonly done for diagnosis. Brain biopsy is not commonly done. And this is very important, especially if you can't do the genetic testing and if you have a suspicion of Lafora disease. So you can go for a skin biopsy in the axilla. In the picture you can see a sweat gland is having these inclusions, Lafora body inclusions is there. So in the brain, they are found in the pericardia, that is the cell body of the neurons of cerebral cortex, like in our case, so within the cell body. The location of the inclusion body is also significant because in adult polyglucosan body disease, again a form of impaired glycogen metabolism, these Lafora body-like inclusions will be there, but they will be in the axonal hillock, not in the cell body like in our case, in the Lafora disease. So in the adult polyglucosan body, it will be in the axonal hillock. And as I was telling, these inclusions should be distinguished from corpora amylacia, which is a common finding, especially in an aging brain. So, but the location also is a clue here because corpora amylacia usually accumulates in subpial or perivascular location, and it won't be there extensively. In fact, in our case, both the temporal lobectomy as well as the hippocampo-amygdalectomy specimen, all of them showed the extensive Lafora bodies. And this corpora amylacia, as I was telling, is not common in children, and it's usually not seen within the neurons. So the other causes of progressive myoclonic epilepsy also needs to be considered, like apart from Lafora disease, neuronal ceroid lipofuscinosis, Lundberg disease, and MERF and sialidosis also. But whatever publications have been done, they all describe like Lafora disease is usually associated with, or it's in all their cases, it is associated with myoclonus. So Lafora presenting only as drug-resistant epilepsy is very rare, like in our case. So the high index of suspicion is necessary to make a right diagnosis. The significant here is it's invariably fatal because of the continuous accumulation of the Lafora bodies into the skeletal muscle, heart, and the nervous system, typically within 10 years of the symptoms onset. So a multidisciplinary approach is essential, including genetic counseling and screening of the family members. Thank you. Over to Praveen.
So what is this case? Is it a wrong timing or unusual presentation? The critical finding in this case was the post-operative persistence of the seizures and emergence of cognitive impairment, suggesting the underlying neurodegenerative nature of Lafora disease was already in progression at the time of the surgery. Lafora disease, as mentioned by Dr. Salapathy, is usually present with myoclonic seizures, but here the absence of myoclonic seizures and unusual presentation has costed us. Take-home message: any young patient presenting with drug-resistant epilepsy, Lafora should be our differential because it can avoid unnecessary surgery where a simple skin biopsy can give you the diagnosis and surgery is not the solution of the disease. So I would like to conclude on a note given by my chief who follows this. It goes like in neurosurgery, true excellence is not measured by the absence of complications, but by the unwavering commitment to learn, adapt, and grow from them. Thank you.
Thank you, Dr. Kumar and Dr. Salapathy, for your talk. I would like to invite the moderator of the session, Dr. Abida Shah, for her insights.
First of all, I think I must congratulate all the speakers for an excellent session. It covered almost all aspects. I must start with Abida Shah. I have a small question for her. What is the approach you will suggest to avoid the visual fibers?
Hello.
So that is what I think I don't know if you saw
Yeah.
the previous presentation. So there is a small area when you enter the middle. See, there are 3 fibers that come in play there: the IFOF, the optic radiations, and below the ILF. ILF one side injury is acceptable, and ILF will be injured every time when you go for a temporal lobectomy, and in all the approaches it will be damaged. So ILF is out of question. So you have to preserve the IFOF and the optic radiations. So the IFOF and optic radiation in the temporal horn are in the roof about 2 to 3 centimeter behind the temporal port, exact anterior part of temporal horn. So you make an entry there and then remain below the roof after disconnecting the amygdala and then come down to the temporal. Actually, we perform an N-block temporal lobectomy with amygdalohypocampectomy. So we enter the temporal horn first and then disconnect the whole thing.
So you don't preserve the visual fibers?
We preserve it. It is on the roof, in the roof and the lateral part of the horn. So I will be below that whole bundle of fibers.
Okay. I just had to make a comment. The visual fibers almost cover the entire lateral aspect of this one. And it's not a big price because you have the hemianopia that you produce, the visual defect that you produce is a superior quadrant, which is practically never used. Except in some countries where there is a problem with driving, a temporal lobectomy does not produce. But once in a while you will find a patient who has a much more dense visual fiber coming into the temporal lobe, resulting in a hemianopia or also in an inferior quadrant anopia. Okay. This occurs something like once in, we have had 2 cases in our series of more than 1,000 cases. And I have had 1, but not to that extent. I think Dr. Girish had a patient who developed a whole hemianopia after a temporal lobectomy without any significant injury to this one. Perhaps my suggestion of an approach towards mesial temporal lobe without affecting visual fibers at all, perhaps maybe through the inferior surface.
It can be, yes. If you go through the inferior surface, but still you have to remain below the roof and roof.
Yeah.
You have to still. So we are doing the same thing through this approach.
Yeah, we have a series of around 25 cases of subtemporal amygdalohypocampectomy through the fusiform gyrus. We did not have a visual field effect. Not collateral is actually more taxing. It is a more technically demanding approach where you have to remove more extensive bone removal. A fusiform gyrus is a very relatively safe approach because the collateral sulcus can be seen throughout and will act as a guide to guide you into the ventricle.
Actually, this technique that we are doing, we are following for last many years. So it was part of a dissertation thesis by Professor Goel to one of his students, that anatomy and how to preserve these visual fibers. So we are just following that, and then retrospectively, by fiber dissection, we have demonstrated that we avoid injury to them.
Okay. Now, is Dr. Sarachindra available for comment? He's not.
Yeah, I'm available.
Okay. So I am again another question to Abhidasha. Do you think in a callosotomy, do you think there is a role for dividing the posterior commissure as suggested by
I think that will be on the indication.
In this specific case. He didn't suggest in general, but he said he will divide the posterior commissure.
So that I think completely depends on the indication. And if you think there is a transmission to the posterior commissure, then you should. But otherwise, in a regular corpus callosotomy, no.
Yeah, I thought that the posterior commissure was part of the brainstem and part of the visual function, rather than related to the seizure. Now,
So can I take a call on that,
an excellent presentation regarding complex partial seizures and psychomotor epilepsy and clinical features by Dr. James Jose. I must say it made it very simple for all of us to understand. I have one question to ask her. That is, do you think video EEG should be used more frequently in the general assessment of patients, even when there is no requirement for epilepsy surgery? When they are not really refractory, should we use a video EEG? Because that will show us all the aspects and the diagnosis becomes simple.
Definitely, sir. Video EEG or even simple recording by a video is very useful in epilepsy workup. You know that nowadays everyone has got a smartphone, and we usually ask the patient to have a record of their epileptic events. And this home recording of the epileptic events are more very useful, even comparable to the hospital recordings. The only thing is you should ask the patient how to record a video event. Usually what happens is patient will go around the patient holding the video, taking the leg part, head part and all. You should train them that this is the way by which you have to record in the home. And if you are sure about the semiology by the video recording from the home, that is good enough. It sometimes helps us to differentiate the types, whether it's a focal onset seizure or not, or it's a generalized seizure, whether there is an onset myoclonus. Sometimes so many epilepsies will be associated with non-epileptic attacks that can be detected. And if this is not conclusive, then I will say that you have to go for a video EEG recording. Now you should remember that the video EEG recording is so common that patients themselves ask, till this time, a video EEG is not done. Yeah. So I think the workup is not complete. That is a patient attitude. So I will say that in any epilepsy, it is better to go for a video EEG.
Very much appreciate it. As somebody who has been working in epilepsy surgery for more than 2 decades, I think video EEG, absence of video EEG is the real reason why epilepsy surgery has not become popular. Video EEG, once done, it will immediately point out which are the seizures which are going to be refractory in nature. And
Dr.
it is said that all over India, the referral for epilepsy surgery is less than 1% from neurologists all over the country. And perhaps a more thorough workup and an understanding of the complex partial seizure and the ultimate refractory nature of majority of them will perhaps increase the number of patients who are worked up for epilepsy surgery. Then regarding the behavior aspect that sir was speaking, I have an interesting aspect. Not always, not 100%, the behavior may be, you really cannot differentiate with the ictal phenomenon. And there can be occasionally a criminal behavior. I've had at least 2 examples. One, we had a patient with a singular dysplasia who had a particular behavior. As soon as he gets a seizure, he will start drawing he will get a transient seizure. He will draw the picture of a heart and an arrow through the heart. And during his ictal episodes, when he sees a woman, he will go and show this hand to her and then behave in a very sexually explicit manner to her. So this, he got beaten up several times, his whole family got beaten up, and ultimately after removal of the cingulate lesion, it became the seizure, he got seizure freedom. And again, there was another patient, as we had a girl with a hypothalamic hamartoma. She was so popular in her class, everybody loved her because she had such a captivating smile, such a lovely smile, and in between, during that smile, she sometimes get a seizure. So this was a smile, a good behavior of this child merging with the seizure. Sometimes there will be only a smile. Sometimes that smile, she doesn't get any abnormal phenomenon or psychic changes. And sometimes she will get a seizure. So this behavioral pattern was there throughout. And after we resected the hypothalamic hamartoma, she stopped. That smile disappeared. Her teacher came and told me that suddenly she has stopped smiling. She became seizure-free. Her overall, she had a neuropsychological improvement. All features became normal. But the smile center seems to have been affected. So perhaps there can be a correlate which is permanent also, rather than ictal in a patient with seizures. Now, regarding the newer anti-epileptic drugs, beautifully said. I had a small doubt whether brivaracetam had a problem of creating the first seizure, prevention of first seizure after a surgery, after in a surgical case, maybe slightly short. That was the feeling. Most of our patients who had the first seizure were on this drug. So do you think as these newer drugs become more popular, the traditional drugs like phenytoin or carbamazepine will disappear?
Sir, that's a trade secret. Previously, when patients are referred for refractory epilepsy, I was upset because there was nothing to offer. Because all the drugs are tried. Now the trend has changed. When a patient is there with drug resistant epilepsy, the job is very simple. You change levetiracetam to carbamazepine. The seizure will be controlled. We know that by efficiency, carbamazepine in focal onset seizure is far better than levetiracetam. That's our experience. So many seizures will be controlled by carbamazepine. Only thing is the public trend is against carbamazepine. They know that it has got reactions, it has got drug reactions, teratogenicity and all these things. If patient is acceptable to, agreeable to accept these problems, that will be the best drug even now. I will say that in this scenario, I feel that 4 or 5 drugs has added to our control. The first newer anti-epileptic drug I will say is lamotrigine. Lamotrigine made a difference. The second one is clobazam. Clobazam made a difference.
Clobazam. So do you think there is a tendency for polypharmacy, where most of the patients who come with any form of persistent seizure, not really refractory, will have around 4 to 5 medications, all in subclinical, small, minuscule doses. Do you think this trend has to be actively campaigned against and prevented, rather than building up one drug to its maximum and then only going for the second drug?
See, sir, there is no problem in using 3 or 4 or 5 drugs together, because after adding each drug, there will be a percentage of patients who will become better. So up to
how much percentage?
It depends on the number of drugs which you are using. With the second drug, at least 1/3 of patients will get a control. And if you go to third drug, another 10% will getting benefit. If you go for a fourth drug, another 10% will be getting a benefit. So you cannot criticize using polypharmacy, but you should, that should be the nature. But you should see that there should be used in optimal dose.
I accept what he said, but this little contradiction to what the Chitra teaching and Dr. Professor Radhakrishnan teaching was, that the chance that, I think he has documented in his book, that the chance that seizure freedom will come with a second drug is approximately 20%, and with the third drug, less than 10%. That's the teaching that was there in Chitra all the time. Now, coming to, again, to corpus callosotomy. Yeah.
Am I audible?
Yeah, I had a question. Do you think the posterior commissurotomy will add? You had shown your case where you did a posterior commissurotomy. Do you think the posterior commissurotomy will add further into the outcome of that patient?
Yeah, Matthew, thanks for asking me this. I was desperately trying to make a comment when you were speaking to Abhida. Now, embryologically, you should understand that commissures are the most primitive structures connecting both the brains, and they connect the limbic system, which are the most epileptogenic areas of the brain. In fact, they form a temporary scaffolding or a temporary roof on which the corpus callosum is formed. So corpus callosum connects the neocortical structures, and the commissures, they connect the paleocortical structures. And they have a lot of implications in seizure transmission. That's the first thing. Second thing, anterior commissure.
You feel that the
anterior commissure has been very well established for seizure
connects
control
both
by
amygdala, so there is no question. Yeah.
But people over a period of time have stopped using that practice. Okay. Now, posterior commissure is not the part of brainstem. It is just a commissural fibers which are connecting subcortical structures, zona incerta, etc. It's not the part of brainstem. Now, we took an ethics committee clearance, and we thought, let us do about 5 or 10 cases of Lennox-Gastaut. As you know, Lennox-Gastaut is a terrible disease. Whatever you do, patients go down, and we need to give the best possible treatment for them. And when we did this, we found that drop attacks disappeared in 100% of these cases.
This posterior commissurotomy was part of a study?
Yes. So on this part of study, and now we have extended this to about 56 cases of Lennox-Gastaut, who have undergone endoscopic corpus callosotomy, anterior, middle, and posterior commissurotomy. So we did a pan-hemispheric disconnection.
Okay.
And they have shown 100% improvement of drops and significant improvement in rest of the symptoms in Lennox
Okay.
gestalt.
Okay, I
The
understood. I got your
reason we did
point.
it in Lennox gestalt is that this is a terrible disease. Patients anyway
Yeah,
go
yeah.
down. They have severe
Your point is
cognitive
appreciated.
deficits.
Your point is appreciated. Now, I understand it's part of a study and with an ethical clearance. Abhidasha, do you have any comment? Yeah.
Before placental mammals, all the transmission of both the hemispheres was through the anterior commissure. The corpus callosum is the first commissure that developed, you identify that the mammal is placental by the appearance of corpus callosum. And why did the corpus callosum appear? Because the transmission had to be faster to carry out the higher functions that mammals started developing. So anterior commissure was doing the role before the corpus callosum.
Yeah.
Posterior commissure, I'm not sure what.
Yeah. Regarding the craniotomy for a callosotomy, I just had to make a comment that the posterior, the splenium comes in line with the central sulcus actually, with the central sulcus. So it is not a difficult entity to do a callosotomy through an anterior craniotomy. You don't require 2 craniotomies before. The corpus callosum is a very much anteriorly located structure, and the posteriormost part of the corpus callosum is still just almost at the middle of the brain. Now, regarding the case of Lafora disease, I must say this is one of the dreaded diseases which sometimes we may have a pitfall of operating on them. But most often the neuropsychological assessment of these patients will show severe cognitive decline. And they usually die in around 10-year time, if I am not mistaken. Most of them are dead in a decade. And it is basically neuropsychology which will point. You may get focal disease, you may get focal atrophy in these patients, but they will have severe neuropsychological decline, which will take you away from a surgery. Otherwise, the burden of the surgery, since you got this diagnosis, you have escaped. Otherwise, the burden of the operating on this patient will fall on the surgeon. And epilepsy surgery is a program where you don't accept any mortality. Your mortality should remain well below 0.5%. Now, I had a question to Dr. Ashok Pillai. What do you think is the most common pitfall a beginner will have? And how many cases do you think a surgeon should assist before he can do an anterior temporal lobectomy independently?
So it's an excellent question. Thank you for asking. I don't have the answer because I keep trying to teach people, and each student, each fellow who comes, they come from a different background. Some people have good. It's a microsurgical skill, so it depends on all the cumulative microsurgical skills, the sense, and their understanding of anatomy. So if you're asking for a number, it's very hard. And I think it's a good thing that you bring this point out. I think this is training to do a good temporal lobectomy without complications is one of the hardest things. And this is what is actually driving a lot of the thermal ablations, because the complication rate is definitely lower with minimally invasive things, but the outcomes are not as good. So it is, I don't have a number, but I think the point is well taken that for the younger generations, as I want to echo Professor Abdul Rauf this morning, we don't want to be dying dinosaurs. So it's a cumulative thing of your microsurgical skills combined with an understanding of the anatomy, combined with a desire to make your patient better. So
it's not uncommon to find
a
surgeon who is away from operating neurosurgery for a long time, coming to get trained in epilepsy surgery, thinking that it is an easy surgery.
No, it's one of the hardest.
It is actually among the most difficult and deep surgical procedures that we perform. And I have felt that the crux of a mesial temporal lobectomy surgery is a twin direction. The neocortex is removed in one direction, while the mesial structures, the microscope has a almost 90-degree, almost a trajectory pointing right to the opposite side. And you work against the thalamus rather than against
in a small corridor also.
Through a narrow corridor. Thank you, I think.
Which is the best drug, James?
What is the question, sir?
Epileptic girl desirous of pregnancy, which drug we should put her on?
I will say that at this time, the best drug is levetiracetam, lamotrigine, or lacosamide. Brivaracetam, the safety during pregnancy is not sure because it's in the market for the last 4 or 5 years. I think that in no time, levetiracetam will be replaced by brivaracetam after a long time. So I will say that if it is a lady in the childbearing age, start with levetiracetam. If it is not controlled, you can add lacosamide, which they have got addictive effect with no increased toxicity. And even if it is not controlled, then you can try lamotrigine. All these 3 drugs are very safe for the periods. There is no risk for polycystic kidney, hormonal changes, and very safe during pregnancy.
Thank you. Are there any more questions to the speakers? Okay, we will conclude the session. Thanks, everybody.
Thank you, Dr. Abraham, for your insights. We will now move on to the next session on AVM. I would like to invite Dr. Andre Giovanni for his talk on microsurgery of large AVM.
Hello, thank you so much for having me here, and thank the organizers for such a great congress. So I will talk today about my experience with large AVMs. I will describe a method of remodeling and dividing the needles as a solution for safe removal. I will skip, because are quite late, I will skip the general information, but of course the surgeon must know precisely when he enters to an AVM what it is, how it developed, when it will rupture, what you will do if it ruptures. Conceptually, it is seen as a cone, or more recently as a box with 6 sides. But this is only conceptual. Every AVM has a very particular geometry, and you need to learn it by heart before you enter the surgery. So for a neurosurgeon, this is more specific. What means a grade, a Spätzler-Martin grade, a Lawton-Young grade, if there is a hematoma, if there is some diffuse nidus there. And after he makes a plan, he needs to decide. He treats conservatively, he will do radiosurgery or embolization plus surgery. And of course, it's very important to know when to treat an AVM, because not every small AVM is a surgical case, for example. But as a natural history, in time, all the AVMs, or most of the AVMs, will have this tendency to rupture. And when they bleed, they can give a minor deficit, or they can give a catastrophic hematoma. These are a few of our cases, what I've operated ruptured cases. So a race against time begins. You sometimes don't have an MRI, don't have a DSA. It comes ruptured at night. You only do a CT angio, and as soon as possible, you must do something for the patient, at least to take out the hematoma, but you must be prepared to take out the AVM as well. With non-ruptured AVM, there is another story. You have plenty of time to study everything, to know where the feeders come from, what feeders have to be taken first, which vein should be preserved for the last, what other dangers are inside the surgery. So you should use all there is now. You have 3D reconstructions, you have 3D printing, you have now VR, and you can use all this before surgery to make a map of the AVM in your head and to know precisely what you should do and how you should do. If you decide for surgery, you should know before you entered surgery how you do it. Circumferential from surface to bottom, bottom up, you mobilize, you rotate the nidus, or you divide the nidus. You have to understand the anatomy, to integrate all the CT, DSA, everything. Find way to the feeders through the main veins, understand if there is an intranidal fistula, and of course, if you need to divide, if the nidus is big and part of the nidus will prevent you from getting to deeper portion of the nidus, you will have to divide the nidus. So this is what I will show you. For example, I did in this very extreme AVF case. This was a giant case with the feeders from everywhere, from external, bilateral external ICA, from ACA, MCA, PCA, everywhere. So once you start a surgery like this, there is no way back. You must stay there as many hours as needed until you come out victorious. So technique is your best friend. Once you enter a very great AVM like this, you must have a very, very good technique. You start with sharp and extensive dissection of the sulci. You try to clip the main feeder. You dive deep into the nidus, but stay in the nidus parenchyma plane. When you go deep, you will sometimes encounter these red devils that will have this tendency. You put the bipolar and they will rupture on you. So there is a technique of keeping the bipolar a little bit open, like you see here, and they will not rupture. You could coagulate. Then you have to go for the deep feeders. If there are deep feeders, you go for the deep feeders first, and then you come up and do the circumferential dissection. You have a bleeding, like in this situation, you will have to stop that bleeding. Don't open many fronts of battle, and then you will understand there's nothing more to do. So leave the vein for the end. The main vein you should always leave for the end. Okay, always before the surgery you should look up for potential dangers. So some AVMs will have a large vein dilatations inside. So some serpiginous veins that go around the nidus and hide the nidus. You should be aware of this before, and you should have your thinking of how to go around it, how to move this big vein or maybe coagulate it a little bit to make space there. Other potential dangers. So maybe you have some diffuse nidus that you will have difficulty to recognize intraoperatively, but you have to know from the MRI where it is before. You will have an intranidal aneurysm, you have a flow-related aneurysm. What we do with them? You clip before surgery, you clip before you attack the AVM, or you leave them to occlude by themselves. If you have this situation of a partially thrombosed vein, it is dangerous during the surgery because it can also rupture. How to treat? Grade 1 and 2, if ruptured and superficial, go for surgery. Grade 3 and 4, if ruptured, they are an emergency. So life-saving surgery is required. If not ruptured, you weigh the risks and the benefits, and you have these options. For grade 5 or grade 7 supplementary Lawton-Young scale, you most of the time don't have to do anything because this is not a surgical or embolization treatment available. But if vital risk is anticipated, you can try surgery by downgrading the AVM. And what I mean by downgrading is decomposing the nidus in 2 or more nidus compartments that can be disconnected and removed separately. For example, here, this was the first case that I've done. It was a conical shape AVM, so I split it into 3 compartments. I first put a clip here, removed the upper compartment, that another clip removed the second compartment, and the third compartment remained in the end. You see, as a ship has compartments to prevent it to shrink, so compartmentalizing the nidus sinks it into complete resection. So this here will be a video of that. I will go faster because lack of time. So clipping there, coagulating, dividing this part of nidus, and then going deep and taking the last part in the end, okay? Another case, this is the last case where I had to divide the nidus into more than 6 compartments. Basically, I went around the main draining veins because it had draining veins in superficial, in sinus, in sigmoid sinus, in, and also deep feeders. This was a formidable AVM. This is the part where I take the dura out, where I remove the dura, and it had many dural feeders, where I encountered intense bleeding. After this, I started dividing and creating corridors between the veins into the nidus. And slowly progressing in this case. One AVM like this you cannot take in one piece because maybe it will require you to stay more than 20 hours there, and it's impossible. So I cut corridors through the AVM, every corridor based on its corresponding vein. And then I divide step by step, I divide all these nidus parts. Because, for example, in the end, after I divide one part, in the end you can have some bleeding from deep, from the dura, from the tentorial dura. You see my colleague here holding his finger to stop that bleeding. If the nidus was here, he could not do this and help me for this part. And step by step, everything is out. Okay, this is the result. I think this movie is working as well. You see here the post-op result. Here are a few of my cases, pre-op and post-op. A few large AVMs here. Some temporal one, some occipital one, interhemispheric one. Of course, in AVM, you expect complications to appear. So I had 2 cases with post-op hematoma. I don't know, maybe it was residual nidus, maybe it was this phenomena of reperfusion. In this case, you see here, she eventually recovered with only a mild deficit. She can ambulate alone. Also, I had in one patient this scalp deficit that plastic surgery had to interfere. So I will tell the story and the drama of a girl with AVM, 26-year-old, global aphasia, right hemiparesis, visual and auditory hallucinations, headache, drowsiness. She had a large Spätzler-Martin 4, compact and diffuse nidus, left temporal, high flow, superficial and deep drainage, amygdala and hippocampus were involved. Embolization was not an option. Surgery was deemed too risky in most hospitals in Europe. She was scheduled for the surgery in another country, this country. So she scheduled that surgery, and 2 weeks before that the flight, this happened. And when this happened, it was a Sunday. I was called at the hospital, and I said, I have to do something, no matter what. She was Glasgow 6. Glasgow Coma Scale 6. During the surgery, severe bleeding was there. We only had 4 units of her blood in the whole hospital, so the anesthesiologist called the surgery off. This is the CT scan in the morning, but the patient regained consciousness. This is the angio-CT. The next day, we went in again. This is the control after the second surgery. This is her now, dancing, rehearsing for her wedding that will be now. This is Zeno from Ilia, a pre-Socratic philosopher searching for truth. So large AVM, what appears to be and what is, how it is viewed. It's extremely dangerous, very complex anatomy of surgery, bleeding from multiple sides, inoperable without pre-op embolization. The AVM pulls you inside the nidus. Bleeding can become uncontrollable. One has to go through the parenchyma to take feeders along with normal arteries. Expect important blood loss. And how it is for me in reality. It's like a mantra. You have to repeat the same move for hundreds and thousands of times. You have to Only bipolar and cut, bipolar and cut. Start by extensive dissection of arachnoid, spend time in understanding the AVM. Don't dive deep. Always see the nidus on one side and parenchyma on the other. Differentiate feeders from en passant artery. If there is a bleeding from nidus, you can't stop it with a bipolar. Place some cotonoid pressure and then continue your dissection in some other plane. Take the big feeders first, even if they are deep. Avoid taking any veins unless absolutely necessary. Minimal or no blood loss. No need of blood transfusion in many of these cases, what you saw. In conclusion, all ruptured AVMs should be treated as soon as possible, considering the severity and the neurological deficit. In large AVM, dividing the nidus in 2 or more parts allows for a safe, faster resection and reduced time for surgery and blood loss. In non-ruptured large AVMs, the nidus division technique can avoid a commando surgery. So thank you.
Thank you, Dr. Giovanni, for your talk. Next, I invite Dr. Matthew Abraham for his talk on microsurgery of SM grade 3 or 4 AVMs.
Respected Chair, my seniors, teachers, and dear friends. Am I audible? Surgery for high-grade cerebral AVMs. I appreciate the what my previous speaker had said of dividing an AVM. There is a AVM has a subtle segmentation which often the neurosurgeons do not get an opportunity to understand, and the interventionist often understands it. There is a subtle segmentation within every large AVM which you can utilize to get some relief in your effort. Not moving. So this is the risk and success of the different modalities. This is actually one of the this is the largest study that has been published. If you see, this is the death and permanent disability from surgery. It's quite comparable. All the different modalities have almost the same outcomes when it comes to disability and death. But when it comes to hemorrhage rates, surgery eliminates hemorrhage in great majority of patients. There is 10 times more successful in eliminating a bleed. So total obliteration is essential for eliminating a bleed. It is successful in 96% of the time in most large series that has been published. Radiosurgery is successful in 38%, maybe up to 75% sometimes. And embolization is part of a matrix of treating this thing. In taken independently, it's unlikely to cure an AVM. So does a partial resection or embolization offer any benefit? Partial resection or embolization? The hemorrhagic risk of an AVM, more so for the larger ones, is increased after partial embolization by a factor 1.5 is to 10.4. So partially treating an AVM is likely, whether it by surgery or whether it by embolization, is likely to give a much poorer outcome. You are not doing a great service by partially embolizing an AVM. The risk persists for at least 2 years, and this levels off over the next 3 years. So any role for standalone partial embolization is progressive deficit, and in all other situations, it should be combined as a strategy to eliminate the AVM. A few words about the technique. Needless to say, a careful selection of approach, strategy, and exposure needed. You get all the accessories that are available with you. I don't choose any. I don't discriminate against any. Image guidance, Doppler, flow seal, a diamond knife, clips, all this is going to be useful. Pre-op embolization should be judiciously selected. I shall show the reasons why. And the techniques, territories, and interventions with surgery should be well planned. It should be kept short, and it is contraindicated for most 1 and 2 and grade 3 AVMs because they are surgically eliminatable. Combining the techniques adds the morbidity of both techniques for one patient. And when it comes to grade 4 and 5 AVMs and some of the grade 3, it becomes a very critical accessory because it will greatly reduce the effort of the surgeon and will reduce the morbidity. And reducing the total blood flow would probably reduce the chance of a breakthrough bleed also. So the technique is to initially start off with meticulous arachnoid dissection. The larger feeders may perhaps be occluded from the subarachnoid plane. Then you gradually move to the subpile plane where you will get rest of the feeders. And ultimately, you will have to go for a perinatal dissection through the surrounding gliotic plane. The principle is you should have steady geometric progression. There is no role for procrastination when it comes to AVM surgery. If you procrastinate too much, you wait for a single bleeder for a long time, you may not control it. Ultimately, the patient may succumb because of from blood loss. So continuous geometric progression, low current coagulation, keep the current at low levels, don't keep it high, it will just burst, particularly the small red devils that you see. And the venous compromise should be kept to the very end. Occasionally, a strategic vein can be compromised to get access to the to one facet of an AVM. Understanding, as I said, as my previous speaker had said, understanding the segmentation within AVM will give you great relief, because otherwise an AVM is a grade 5 or a grade 4 AVM is a very taxing lesion. It will have an arterial segment. The veins may be common, but sometimes there will be an arterial segment which you can exploit to get some relief. And prevention of breakthrough bleeds is absolutely important. You have to keep the patient dehydrated. As my professor Suresh Nair used to say, if you are managing AVM properly, the urea should rise. That means you should keep the patient really dehydrated. And a prompt post-operative DSA should be done. So if you have a residual AVM, go for it again. It will be much simpler. Don't wait too long. A re-exploration of an AVM after a longer while not only is more difficult, but it also subject the patient to a much higher risk of bleed during the waiting period. I will say by a proportion of almost 5-6 times, a partially treated AVM is much more difficult to, it's a much more dangerous condition. So DSA guidance can occasionally be used when you go back for an AVM. We have done almost all our AVM re-explorations with DSA and has found to be useful, intraoperative DSA. So I'll just demonstrate 2 AVMs, one grade 3 and one grade 4, as it was my mandate today here. So this is a grade 3 AVM. You can find the deep venous drainage through the ambient cistern here. The nidus is around 4.5 centimeters, deep venous drainage into the basal vein and into the vein of Galen. It is actually located on the frontal base. The craniotomy has been done, a frontal craniotomy has been done. There is also a feeding artery aneurysm and ACOM, this being just inspected initially. The larger feeding artery aneurysms may be treated. If they are very small, you can allow it to go through its natural course. But since this is in the same exposure, we'll perhaps treat it. I'm just exploring that initially. You can see this is the nidus of the AVM, and it has both feeders from the MCA as well as from the ACA. These are the initial MCA feeders being tackled. A principle of dealing with a larger AVM is to steadily work on one geometry and finally trap it against an avascular firm structure like the forks or the base. The larger AVM, you can't be standing in the center of the brain tackling a larger AVM for a long time. So basically you try to trap it against a firm structure. The initial subarachnoid plane is being gradually abandoned for a subpile plane. The ideal fluid for coagulation would be 5D rather than normal saline. The current should be kept low. Your coagulation technique should be good. The bipolars should not be immediately approximated or jammed. They may be gradually brought together. You should see the vessel gradually coming down, and you gradually close the clips. So we have reached the medial surface. These are the ACA feeders and the large vein. And now that's being coagulated. So this is the olfactory nerve. So the vein is finally what is on which it is hanging. The transformation into a blue color of the vein is such a pleasant sight for the surgeon. The pleasure of cutting off, detaching an AVM is unmistakable. Okay, this is the aneurysm being tackled. That's fine, aneurysm. So this is the post-op DSA showing full elimination. So this is another patient who is a 43-year-old shopkeeper with headache, apathy, basically he's getting dementia. And with neuropsychology showing executive functions and attention span into the 5th percentile. He has not bled. So this is a grade 4, it's a large AVM with a deep venous drainage and reaching the eloquence. So this grade 4, I'm specifically showing this grade 4 AVM for a specific reason. An AVM requires a continuous high concentration throughout the procedure. During a certain step, there is just a small transient lapse of concentration on my part, which it shall evolve. So again, I am trapping it against the base, against a hard surface. Any vascular lesion, when you trap against a vascular structure, you will get a certain comfort. So this is a frontal base. Some strategic division of some of the veins may be useful in accessing remote parts of the AVM. This is the olfactory nerve. It's being preserved. Now I have a feeling that I have detached most of the AVM, but there is still turgor. There is some degree of turgor. I start coagulating that structure, thinking that there is only a small attachment left and I can manage anything happening within this small area. This is in the perisylvian area. You can see suddenly the AVM starts bleeding. I actually cut it and I think it is a wrong move. You can see the AVM suddenly engorging as I attempt to coagulate it. I am unlikely to be successful by just purely coagulating it. So I go for multiple clips. But I have a good luck, I have mobilized most of the AVM. Most of the geometry is already mobilized and I can turn it around. At this stage, an abnormal bleeding is still manageable. Some strategic coagulation or maybe a little bit desperate moves. Still the pressure in the nidus is high. So most of the nidus is mobilized. I am able to take it out. Now this was the reason. I am just dissecting this region. There is one artery which is actually nicely hiding behind a vein. This is the fellow which is giving me this anxiety. The patient ultimately did not have any deficits. He had a major improvement in his neuropsychological parameters by 20 percentile and he started working. That's fine. This is my personal experience, 146 AVMs. Of 125 cases, I have a post-operative imaging, that is 328 years of follow-up. For grade 1, 2, and 3, I have no significant problems. I have a slightly larger proportion of grade 2 and 3. 85% of all AVMs are grade 1, 2, and 3A. Only 15% are the high-grade AVMs, but there is some disproportion here, probably because we are a referral center. And I have a mortality of 2, that is none for grade 1, 2, and 3, 1 for grade 4, and 1 for a grade 5 AVM. And so there's a 20% mortality for a grade 5. In the long-term deficit, 6 patients had a visual field deficit, and AVMs are very forgiving lesions. They hardly give you much long-term deficits. The complication rate has been 1.8%, and overall obliteration has been 97%. 9 patients required resurgery, and it could be eliminated in a resurgery. So SM grade 1, 2, and 3 AVMs are excellent surgical correlates with more than 90% chance of cure with very low morbidity. Pre-op embolization is to be used judiciously as part of a strategy to fully obliterate the nidus. Most grade 4 and grade 5 AVMs are curable, and a well-coordinated multimodality approach gives the best benefits to the patient. Thank you.
Thank you, Dr. Abraham, for your talk. I would like to invite the moderator of the session, Dr. Atul Goel, to share his insights.
Uday, you are going to talk now? Okay. So AVM surgery is difficult, it is dangerous, but it is the treatment. It is a difficult treatment. You know what? AVM surgery is one where the surgeon has to be confident, where the surgeon has to be sure, where the surgeon has to be having both his legs firmly grounded. He cannot be egoistic. He cannot have overconfidence. On the other hand, he has to be full of confidence. If he is overconfident without caliber, he can kill a person with marginal symptoms. See, many of these patients come with just headache, or just convulsions, or just some kind of giddiness, and this form a very big proportion of these patients. For a headache, you create hemiplegia. For giddiness, you kill the person, or you create devastation. Is not acceptable to the patient and to your own self. On the other hand, you know, you have to have absolute experience of hemostasis. Hemostasis is the game. The whole operation depends on how good you are in hemostasis and how you have the hemostasis and how you go further. And that has to be learned by experience, and that has to be learned with all the gadgets that you have in your mind and in your heart and in your experience. You have to be real good. You cannot be artificial in AVM surgery. That is what I have to say. And those who enter should know how to exit. You know what, Matthew, one thing I didn't like, that you had to re-explore 9 of your patients, which is, in my view, quite a big number. It means you have left some residue behind. When you go for AVM, you have to remove 100% of AVM and then come out. Now, you will say how to remove that 100%. I will say that is the trick. That is the basis of AVM surgery. You have to know how to control big vessels. You have to know how to control small vessels. And you have to know how to control medium vessels. You ask me one trick in AVM surgery. That trick is how to control small vessels. You have a small vessel bleeding, and you coagulate, you cannot coagulate, and then, you know, Harsnemi used to say dirty coagulation and all those things. That is not the business of AVM surgery. When you have a small bleeding, it means there is a mother vessel sitting behind that. You follow that small vessel and get to the mother vessel and get that. That is the way you have to remove the AVM completely. In my view, this normal pressure perfusion, pressure breakthrough concept is a kind of a, you know, we blame it onto that concept. You don't blame normal pressure perfusion breakthrough as an excuse. It means you have not done the job properly. To do AVM surgery, you have to remove it completely. Go to the small vessel that leads to the big vessel, get to that big vessel and coagulate. Remove it completely. Second thing is about Uday Limesh sitting here, about pre-operative. Uday, just listen, ignore it if you don't like. I must say that Uday is one of our stars of our country, and not our country, he's an international star on interventional, and we have worked together. He has grown in front of my eyes, and when I see him grow, I become happy. I don't become upset. I don't become competitive. I become happy when he shows good work and all that. Believe me. As regards AVM, my concept is clear, my concept is definite. You see, AVM, if you think you can operate, operate. If you don't think you can operate, just leave it. Now, when I talk to people like Uday, they say that you can embolize intranidal aneurysms and you can make the thing safer. You can feeding vessel nidus aneurysm, you can make it safer. You can reduce the size of the AVM. You can make the the overall outcome safer. You can reduce the symptoms by going through the AVM and dangerous points. Deeper vessels you can get through this. And some of these AVMs, the number may have been more now, that you can completely operate it. My concept is clear. AVM is a surgical beast, but not many people in the world can do it. That is, I am guaranteeing that. And it is not the game for everybody. If you want to reach that everybody level, you have to be absolute and you have to be complete. You cannot, this is not one AVM per month or one AVM per year operation. It is a multiple AVMs throughout the year. And to get that experience, you have to have a very big institutionalized practice where you can do this. And that is, I believe in that concept. And other thing is, I liked Andre's presentation. He is, he has the guts to go into that AVM. It means he has big self-confidence, which is very much mandatory in AVM surgery. I like the technique of Matthew for a long time, and in my belief, in my understanding, he's one of our very brightest technical neurosurgeons in the country, and I always like to watch his surgery. AVM is the last chapter of neurosurgery. If you want to do it, you have to have super confidence, and that should not be artificial, egoistic pride and hyper nonsense. You have to be sure as to what you are doing. Uday, I would like to have your comments on what is your, are you going to speak now? Because no? I would have loved to hear you. Actually, I thought you are going to speak, because can you come and give your few concepts about what do you think about your current indications of AVM treatment as far as you are concerned? Come here.
Okay, I really appreciate the opportunity. I will take 1 minute max, because you saw some fantastic work in the 2 lectures, and of course you have seen him years together showing his fantastic work that he has done over the last 25 years or so. So here, AVM, we must understand AVM is a dynamic disease, and as I showed yesterday in aneurysms, the technology and techniques of AVM embolization also has evolved a great bit over the last 2.5 decades. Starting with going just inside some arteries and embolizing and hoping for a better angiogram, that's how, frankly, we used to do in the 90s, to now, we try to cure the AVM. I agree that some of the AVMs, if we cannot cure by ourselves, then we cannot hesitate to have help, surgical help or radiosurgical help. And this is a new thing, because when everyone is younger, everyone wants to do like he's the best philosophy. It never helps the patient, never helps you. So this has happened over a period of time that, one, if you want to treat an AVM, cure the AVM. If you cannot cure it by endovascular means, no hesitation in going to a good surgeon or a good radiosurgery operator. If you do not cure the AVM, if the AVM is so-called reduced by 60% or 75%, that means sooner or later that person is going to bleed. And we realized that in our initial practice, we used to say that if you get the AVM 3/4, that means his chance of bleeding is going to be 0. That didn't happen. We had several patients who came back years later with a bleed. So aim for cure, whichever way you look at it this way surgically, look at it our way, endovascular, or something in the middle, the aim should be cure. Two, the techniques which have improved a lot, not just transarterially, but transvenous. And there's one concept that we follow, and that concept, as you often say, mother vessel. So we say fistula first or fistula last. Fistula doesn't mean it has to be a high flow AV fistula. It means the most dramatic central part of the AVM. And we used to do previously, go into the biggest artery and get to that portion first. And then we have something left around it. With a smaller artery, sometimes we cannot get into it. So when we embolize large AVM, we always do it in sessions, in stages. It may be 4, it may be 5. But we go around it first, get the nuisance vessels, the nuisance nidus first, perinidal angiopathy first, and then we are ready. We go into the main vessel, and we have techniques to have complete cure of the AVM in the main vessel. Also, you can add a transvenous approach. So all these things are new, or newer, I should say. They've not been new. Last 1 decade, they have been developing. It's a good time. It's not competitive, as you rightly said, but it's a good time to treat AVMs, either by embolization or surgery or gamma knife, I'm sure. Thank you.
So what is the complete obliteration rate in endovascular management, even after multiple sessions of embolization, in your experience?
So, you have to be sure, as I said in the beginning, you have to be sure that what are you trying to achieve here. If you're trying to achieve a deep AVM, you're trying to achieve a little reduction in size and send to radiosurgery, then you have to plan accordingly. If some of the presentations I saw, a large frontal AVM, in our opinion and practice, there are some areas of the brain, the size doesn't matter, because it's the eloquence matters, it's the access which matters. Like a massive 6, 7, 8 centimeter AVM in the frontal lobe is not the same as the same AVM sitting on a motor strip, or same AVM in the cerebellum. So you have to see that where the AVM is, what's your access, and what you want to achieve. If you want to achieve cure, it's possible, as I said, with the technique that we use. The nuisance arteries, the small arteries, go around it, and in his term, mother vessel, in our term, fistula last. So we go into the main aspect of the AVM and absolutely cure it. And so we have to be sure. And maybe this time there was no time to show some of the work that we have been doing. But in percentages, you cannot say that, okay, I will cure 40% or 50% of the AVMs. It is 40% or 50% is not good enough. You choose the AVM, you cure the AVM, either by endovascular means or by other matters. I have absolutely no ego in saying that we refer AVMs for surgery. We refer AVMs for radiosurgery. But the ultimate aim should be cure. Either you do it by yourself, of course everyone likes to do it by yourself, or with help. And when we do that, the cure rate of the chosen AVMs, not the huge arteriopathy kind of AVMs, the chosen AVMs are around 90%.
That's all right. But I one more thing to you. We say inoperable AVM, better Martin 6 or whatever it is non-treatable. It's a presenting something who's telling palliative embolization for progressive. I have taught students, what about intractable mistake? I think it is an indication. It is just an indication, palliative embolization.
Yeah. See, if intractable AVMs is because of so-called steel, there is no steel in the brain, as all of you know. There is no steel in the brain. But if it is stealing from the area which is around the AVM, most of the blood obviously will go to the AVM, and if the headaches are because of it, it will help by us to do safe embolization, not trying to cure it. The second thing is, especially if there is a meningeal feeder, a middle meningeal embolization, even in patients of intractable headaches with or without AVM, is coming up big time. And like magic, people have been diagnosed as migraine for years together, but we do this embolization because we are doing a lot of it now for the chronic subdural. In addition to that, if we do this for headaches, then it will help a lot. Thank you.
Thank you, Dr. Goel and Dr. Uday, for sharing your insights. We will now have a short tea break. Please be back by 6 p.m. sharp for the simulation surgery.
We'll start the program now. We'll start the simulation surgery by Dr. Uday Limay.
We will now start off with simulation surgery by Dr. Uday Limay on endovascular embolization of AVM.
Okay, thank you and welcome back. Yesterday we took a little while longer because we had to do the entire setup. So today I used the tea time to get the guiding catheter inside already. So if you remember from yesterday, it's the same 6 French guiding catheter which goes through the femoral, and like yesterday we have gone through the aorta, descending, and the out of aorta. Is the camera on?
Yeah, it's on.
Yeah. And then this guiding catheter is actually placed inside the so-called carotid artery. And see, this is nowhere close to how the AVM actually is, because this is like I've placed the guiding catheter inside something like a skull base. But through that, you have to really navigate a microcatheter much, much distal. You saw how the tortuous and elongated the vessels of the feeder of the AVM are. Here, it looks like a straightforward one. This is a model which shows that this is the artery. My guiding catheter is here. So the microcatheter which I'm going to show you in a minute, it's a different microcatheter from yesterday because it has to go with the flow. So it's a very floppy microcatheter. This time we have the marathon microcatheter, which is used for AVM embolization for liquid embolics. The coils won't go through this. So we have to use liquid embolics for the AVM. For the simple reason is that there isn't any simple target like an aneurysm here, which you can fill with coils. So you have to use the liquid embolic because the liquid embolic needs to go through the crevices, through the nidus of the AVM. You may call them arterioles, venules, or something in between the arterial feeder and the venous drainage. So you have to fill that nidus to cure the AVM, as I was talking in the session before. In the 90s, we used to just go into the arteries and block those arteries. If you block 1, 2, 3, 4, 5 arteries, then another 50 arteries, smaller arteries will open because you have not blocked the actual nidus, actual epicenter of the AVM. So the principle to do the AVM embolization is to block permanently the nidus of the AVM, and then you take the vein which drains out. So once you have used one of the arteries or maybe multiple arteries, get the entire nidus and the main vein. So once you get it, it's like a surgical resection. The whole nidus along with the vein. And we will try to do that. It's a model. It's not flowing blood. Okay, and so you can see this is the model which is there. We are on the flow, which is water, which is flowing through, and then it goes on to towards the right of your screen. Those are the veins. Now, unfortunately, the veins don't have a portal here. Otherwise, we would have gone to the venous side as well, time permitting, maybe next time, for the venous access or venous approach for the AVMs. Today our job is simple, try and get the microcatheter inside the arteries, close to the nidus, and then see how onyx, which is a liquid embolic, works. I also don't know how this is going to work in a model, in an AVM model. It's difficult to get a model of the AVM, unlike aneurysms. So let us see, we are almost there. I'm going to show you the microcatheter. Come on this side. So you can see the microcatheter. It is an extremely flexible, long microcatheter. So this from the femoral axis needs to go all the way into distal cortical branches of whichever artery which is supplying, ACA, MCA, sometimes the choroidals or the PCA. So this microcatheter, the wire also will be different. This is a small wire. Yesterday we used a 14 wire to access the aneurysm microcatheter and aneurysm. This is a small wire. This is an 8 wire which will go through this, because the 14 wire won't go through this. It's a smaller microcatheter, as you know. So let us, can you hold this now here? Just hold it like this. So now we will go into the guiding catheter, which is in place. Like yesterday, everything is hydrated. And now the micro goes in, and hopefully we can get to see where it goes. You see the small water bubbles coming there because I'm pushing it. The catheter is full with water. Here, it comes and it goes on to the left. Where is the model? Is it okay? The artery is okay? It goes to the left, which is not our target. We need to go to the one which is here on the right. So I'm going to use the wire to navigate it to the right one. Pull it back a little. Again, yesterday the visibility is poor. I cannot see the branch which goes to the right. Can you just show it with the light on here so that at least I can see it here? Yeah, I think even this light can be on. Okay. So here it goes here. You have to go on this side, right?
I think we'll hold it from here.
Okay, so now let us see if the wire is seen. Is the wire seen? There is a wire?
Yeah.
It's so distal?
No, it is here. Tip.
The tip of the micro, do you see the wire?
Yes, sir. Wire. No, now it's coming.
Now it comes and it still goes where we don't want it. Okay, so this happens sometimes that it is not going where we want it. I'm going to pull it out and reshape it again. Can I get some light on this? This is how you shape the wire. You see that the distal tip of the wire is now shaped. So when you torque it, it has an ability to go one way or the other. So let's try it again. Yeah, I need the light here. Can I get the light here? Okay. Fine. So now let's see the wire there again.
It didn't come with.
Yeah. Okay, that's better. What we are doing is better. I can see it now.
Yet to come.
Yet to come? Okay, it's going.
It's going out now.
Okay, it's gone where we want it. Could you see anything? Sorry, well, I didn't. Could you see anything? Okay, so So at least I know that it has gone where we want it. And now just see if the microcatheter is going over it. Okay? So fine. So is there any way of showing them better? Yeah, this is better, this is better, this is better. You see the black line is the microcatheter. There it is, which is close to the AVM. I'm going to hold it right here and now take out the wire. Okay. So now, you can start. Not this, the onyx. Yeah, good. And I need the syringe. No, not this. The water syringe.
Yeah, it's filled.
Okay. So the first thing you do is that this is too huge a syringe. We have 1 cc or 3 cc. Is you take the chute inside the AVM nidus to confirm that you are there. This is water, so we are not going to see anything. I'm just hydrating the lumen of the microcatheter. And once this is done, your partner now take the needle and take out into the white syringe. Yeah, the onyx. Okay, so this is DMSO. I'm going to use DMSO inside the microcatheter because the solvent is a DMSO. If you use contrast or blood or saline, the catheter will get blocked immediately. So you require to prime the microcatheter with DMSO, which is the solvent for the onyx, which we are going to use as an embolic agent. Generally, the inner lumen of the microcatheter and a little bit more, so you should be able to inject 0.3, this is a 1 cc syringe, 0.3 cc of DMSO inside. I'm injecting DMSO. Can you get it out? It's coming? Yeah, good, grind. Okay. So here it's 0.3, I'm injecting a little bit more and take it out and remove the needle and give, yeah. It will stain your hand, okay? It's black. Okay. So this is onyx. What is onyx? Onyx is a stone, it's a black stone. So this product is called onyx. It's a DMSO solvent, embolic agent. And so we are now ready to put it inside the hub of the microcatheter. And generally again, 0.15 to 0.2 cc is the lumen of it. So now let us see, we hope to see it coming into the nidus. I've injected 1.5. I don't know, what do you see anything? Yeah, can you hold it like this so that they'll be able to see, and maybe I can see the same. Yeah, did you see that? And how it escapes into the venous side. So this is what is going to happen with the flow. So you have to go slow. Here, it goes towards the venous side, pretty much close. So probably I am too much deep inside in this model. And see now it goes to the heart. So it is not good. I'm going to come back a little with the microcatheter. And here I'm going to inject now. Hopefully it is going to be better. Wonderful, it still goes. So you are neurosurgeons. So in case this happens when we are embolizing, that we first go onto the venous side and occlude the vein, we have a problem, a drastic problem on our hands. Luckily, this is only a simulator. So we will now get it from venous side up to the nidus, hopefully. Did you see that? Now, this is the nidus which fills. Onyx is about flow, onyx is about physics. Yeah, very good. I think this is good. This is onyx now filling the AVM nidus. The initial parts which have escaped into the vein to the heart, small little 0.1 cc, don't do any damage to the pulmonary vasculature. And onyx generally layers on the vein, so even it is not going to block the vein of the brain. And you see that bit by bit you inject, and it wants to go again towards the venous side. You wait. You wait for a few seconds, and see, now you have got the occlusion of the vein. So now we have to wait, and then inject again. So hope to get rest of the nidus. It still wants to escape towards the vein. So we wait. We have many concentrations of onyx. This is onyx 18. We have onyx 34. And we have the other agent, the squid, which also comes in 12, which is viscosity-wise, 34 is the maximum, 18 is standard, and 12 is very watery. So to control the 12, even here the 18 is not controllable. To control the 12, you need to have some kind of adjuvants. So let us see, we have waited enough if it wants to behave. And now it comes back onto the microcatheter. This is exactly how it will happen in the case. So we have techniques like pressure cooker, means we have something holding this onyx reflux onto the microcatheter so that it doesn't come and block the microcatheter, it may get stuck. It will hit that roadblock and again will go towards the nidus. I'm just going to wait a little to see if it comes back or it is filling the nidus. It goes to the other branch, and now it comes onto the microcatheter. Okay, I'm still going to wait because I don't care too much even if this microcatheter gets stuck out here. So we will wait for maybe 30 seconds and see if the flow is going to be different. It comes onto the other side. This is on the micro, right?
Yes, sir. So onto the micro, it's coming back.
It's on the micro?
Yes, sir.
Yeah, it's going to the other side as well.
Okay, so this is what will happen, that it's liquid, so it will find its way. You just have to understand the physics behind it and most definitely the anatomy. Every time that you do, even if it's a simulated model, you need to know what you're trying to achieve here. If it happens, great. If it doesn't, there are other ways. So you get the whole circle around the nidus, and now we don't care, all this vasculature doesn't happen. Initially, it was going very fast towards the veins and out. As long as that is not happening, we would like to fill the entire vasculature wherever it goes. And this is, so much I've injected, this is now 1 cc. So can we get the other vial as well? If it's going, may as well inject it. It's going onto the venous side. So probably what I had to demonstrate is over. There's no point getting another vial of onyx out and try to do stuff. But this is the basic of how we do embolization of the AVM. Every single thing cannot be shown on a simulator in 20 minutes. So this is what it is, and I'm going to stop here. And this AVM, I don't know what your grade is, but this AVM is, for us, is 100% curable AVM, okay? So how we do it is different, maybe not on simulator, but AVM of this size, like 3-4 centimeter, with one good axis, can be easily got with maybe a little bit more onyx, a little bit more on the technical side. I think today, I was hoping that yesterday you were not there. So yes, I could not see the aneurysm and the coils going inside. At least today we saw it. So it's good. Well done, boys. Thank you.
Thank you, Dr. Uday, for the simulation session. Now we will move on to the next session on cavernous sinus.
Worked well.
I would like to invite Dr. Abita Shah and Dr. Sukhdeep Jawar for their talk on anatomy of cavernous sinus. I request the next two speakers to be ready.
So I hope everybody So now coming to the last session of the day, it's on one of the most interesting area of the brain and one of the most difficult area, and you can say no man's land. So while we are waiting for the 3D setup, it's coming now. So cavernous sinus is a area of interest more to, I think, neurosurgeons than any other branch. Anatomy people, of course, they are also interested, but from neurosurgeon point of view, it's always been very interesting. So this is the lateral view which we have already seen, and if you see now this area below the skull base here, from the middle cranial fossa, extending, maybe not in this image. This is the mid-sagittal view we have already seen. So this is the superior orbital fissure here, and we have the foramen rotundum here and the Vedian canal. So if you see, this is a sphenoid sinus, and the cavernous sinus is related to the superior orbital fissure to the dorsum sella. So this is the side-on view. We have already seen this, and this is the top view of this sphenoid bone. So most of the cavernous sinus is related to the sphenoid body here. If you see here the dorsum sella here, this is the clinoids. This is the anterior clinoid process here, and from here we have the carotid sulcus making an impression on the body and side body of the sphenoid. So we have, so there is some. If you see, this is a very important structure here. Is this? So this is the projection of the from the sphenoid greater wing and the body. This is a lingual process. So lingual process give attachment to the petrolingual ligament, and from where the carotid artery enters from foramen lacerum to the cavernous sinus. So this is the posterior boundary of the cavernous sinus in relation to the dorsum sella here, and then it travels along here to the superior orbital fissure. And the ICA goes medial to this segment of the anterior clinoid, which is a clinoidal segment. So we will be seeing this anatomy in detail. So here we, this is the posterior view of the superior orbital fissure. Another important structure, if you see, there is a process, this is a petrosal process, and it is, this also, if you see that this is the dorsum posterior clinoid, and if you go, this is dorsum sella, and this is the petrosal process. This also gives your attachment to the Dorello's canal, and it is a landmark for sixth nerve. So this is the lateral wall of the cavernous sinus. As we know, there are two layers of dura, meningeal layer, periosteal layer, which outer layer can be stripped off. This is the top-on view. So here you see, this is the Meckel's cave. There is the internal acoustic metis. So this is the Dorello's canal here. And this is the basilar venous plexus. And this is the, so the cavernous sinus extends right from basilar plexus and goes all the way to superior orbital fissure, where it receives the venous drainage of the orbit. And also there is communication with the nasal cavity. So if you see from the top view, this is the second nerve. This is the oculomotor triangle, which we saw yesterday also. So oculomotor triangle is a very useful landmark. If you see the oculomotor nerve, it enters in the center of this triangle. So we have anterior clinoid, we have posterior clinoid, and the petrous apex. Interclinoid ligament, anterior petroclinoid, and posterior petroclinoid. And in the lateral wall, you have the fourth nerve entering just below it. So if you see from the lateral side, the fifth nerve, this whole Meckel cave has been opened. So only the V1 segment, which is related to the cavernous sinus, and V2 and V3 are in relation to the Meckel's cave. So we have to remember V1 is the partially which is in the cavernous sinus, and the only cranial nerve which is traveling inside the cavernous sinus is the sixth nerve, which is in relation to the internal carotid artery. Rest of the cranial nerves are in the wall of the cavernous sinus. So once you reflect this fifth nerve here, you see this the petrolingual ligament which I showed earlier. So from where the cavernous ICA is starting, then it is giving the branches. Of course, this is the inferior lateral trunk here supplying the lateral cavernous wall. Then we have some meningohypophyseal trunk which has 3 branches, which I will show in another dissection. So this is the third nerve have been reflected. This is the fourth nerve. So this is a top on beautiful view you have seen. This is a very nice view. You can see the Dorello's canal. You can see petrosphenoid ligament here, bow-shaped ligament below which sixth nerve is entering. So sixth nerve have a very long and oblique course. Before entering the cavernous sinus, it has a long course in this. This is a venous lake here, where all these cavernous sinus, basilar plexus, and from where superior petrosal sinus, inferior petrosal sinus. So this common venous area through this sixth nerve goes and enters all the way, and it's entering here into the cavernous sinus, then going into the superior orbital fissure. So raised ICP and all this problem, they can have pseudo sixth nerve palsy because of raised ICP also. So here you can see on the this is a cave here, and on this side we have opened and showing some branches to the dorsal clival here. And if you see, there is the inferior hypophyseal supplying the posterior pituitary here. So here we have removed the clinoid, anterior clinoid process just to show the anterior. This is a clinoidal segment, this is the cavernous segment, and after that there is a sellar segment. And from endoscopic point of view, you can see it much better. This is again, here you can see that it's petrosphenoid ligament, and it is entering here. This is the petrolingual ligament. So this is top view. So here we have just retracted just to show that medial cavernous segment here. And this again is the inferior hypophyseal here. And this is the tentorial artery, and this artery is the dorsal clival artery. Here it supplies a branch to sixth nerve also. So this is again same view. And here all the venous injection and rest of this has been removed just to show the relation of fifth nerve, third nerve, and all the cranial nerves. And from endoscopic perspective, we all know that from sphenoid we can access now from sella and the paracellar and the cavernous areas. So there can be variable configuration of the septa, and similarly there can be variable configuration of the sellar ICA here. There can be a narrow segment here, there can narrow like his. Here we have a wider segment. Then also depending on pathology, we can have variable configurations here. So just stepwise, you have sphenoid ostia, rostrum of the sphenoid, and this is the middle turbinate here. So cut the middle turbinate, uncinate process, ethmoid bulla, both these are open. You enter the sinus. Very rarely you see a midline septum like this. And now the important landmarks is this tuberculum here, planum, and the OCR. OCR again is the ventral representation of optic strut. So another process where from here it is sometimes difficult from where the cavernous ICA started. So here you see a little recess, which is a lingual process, and on this side you see the lingual recess. So from clival to the sellar ICA. So this is again the dura has been removed. Now you can see beautifully the venous injection. This is all the clival basilar venous plexus here. And from here, this is your lingual recess. From here, the cavernous ICA will start, and it will go all the way to till the clinoid segment. And here you can see the clinoid segment beautifully. This is the proximal ring here. This is the distal ring, and this is the clinoid segment. So those clival segment, cavernous segment, clinoid, and supraclinoid. So this is again the median nerve here coming to the sphenopalatine ganglia. It is a useful landmark for the this lateral or the petrous part of the ICA. So for cavernous sinus, this is a inferior hypophyseal which we saw from the top. Now you can see from here also inferior hypophyseal. This is that same dorsal clival artery, and you can see sixth nerve. And in the next slide, this is inferior hypophyseal. Then the diaphragm sella. This is superior hypophyseal branches supplying the stalk and part of the hypothalamus. So this is the sixth nerve inside there. So here I have medialized this ICA just to show the lateral wall of cavernous sinus. So this is from the endoscopic perspective. This is inferior lateral trunk here. This is the third nerve coming. This is the sixth nerve, and this is the V1 beyond that, and the V2 is below. So, and this is the clinoid segment here. So this is the, again from third nerve entering in the oculomotor triangle. And you can see here this artery supplying the sixth nerve. And this is the petrosphenoid ligament, Gruber's ligament. Here you can see much better. So this is the sixth nerve on the petrosal process, and this ligament bow shape which you can see from endoscopic perspective, and this is the petrous apex area here. So here you can see all the dissection now with all the both the side the cavernous sinus and some middle fossa dura has been opened just to give the orientation, and you can see the even the supra ACOM complex. So this is a close-up view of the circle of Willis, and this is again the whole dissection. You can see beautifully even the basilar and the posterior cerebral this PCA coming out like this. And this is the vertebral arteries. And this is again another specimen. This is the orbit here. So here is the orbit. Just behind you have the area of the cavernous sinus here. So thank you with this. I think we have covered almost from both the sides the cavernous sinus. Thank you.
Thank you, Dr. Jawar, for your talk. Now I would like to invite Dr. James Joss for his talk on syndromes related to cavernous sinus.
Good evening, everybody. This is my last talk in this scientific section. I take this opportunity to thank all the organizers and delegates for giving me a chance to address you, as well as your patients to listen the medical side of a neurosurgical problem. Actually, I was shocked to see that there are 8 topics allowed to me, and this in a short notice of 3 weeks. I was working with the slides and the literature day and night to accomplish this one, and I was so much relieved when the last topic, that is cavernous sinus syndrome, is done. You know that cavernous sinus, the anatomy is so easy and so beautiful. The diagnosing cavernous sinus syndrome is also very easy. But we always pray that a cavernous syndrome should not come to us, because etiological diagnosis is very difficult in cavernous sinus syndrome. Neurosurgeons shy away from the cavernous sinus syndrome, saying that it's a small lesion likely to be medical. We don't know what to do, we don't know how to investigate. We blindly give steroid and wait to see that after some time it is enlarging. Again, we have no choices. We send to neurosurgeon. They say that you send to ophthalmology because they have got better approach to the retroorbital areas, and also it's a misery for the patients in the usual institutions unless there are specific setup and specific surgeons skilled in cavernous sinus management and syndromes. In this talk, I will emphasize some clinical points, especially for the etiological diagnosis. See, the clinical presentation, I told you that there is no confusion. You know that, as already the anatomy has said, 3-4 nerves, V1 and V2 in the wall, carotid artery inside, the supraclinoid part of carotid above, and the 6th cranial nerve inside the cavernous sinus. So the structure involved is very easy when you see that this combination 3-4 V1, V2 and 6th nerve involved either unilaterally or bilaterally, we diagnose is a likely cavernous sinus syndrome. So diagnosis is very easy. You have to remember that not only the cranial nerve palsy, the ophthalmic veins drains into the cavernous sinus. So always there is a increased pressure effect to the ophthalmic veins and to the orbit, which we usually underestimate. So you will see that this pressure effect in the cavernous sinus will produce proptosis, congestion and chemosis, which is usually underdiagnosed. Proptosis, unless you see it properly in a clinical examination, you won't see a subtip proptosis. A radiologist can easily pick up the proptosis. Similar way, the conjunctival congestion, the eye congestion will go to the ophthalmologist. They will think that it is a conjunctivitis, iritis, something like that, and the patient will waste their time. Chemosis, they will say that there is some allergy. So whenever you have these problems, without the problem of cranial nerves in the cavernous sinus, again suspect this problem, because the clinical presentation may be either the pressure effect or the compression effects on the cranial nerves. Now, we divide the cavernous syndrome into anterior syndrome where the trigeminal V1 is involved, middle syndrome when the trigeminal V1 and V2 is involved, and posterior syndrome when all the 3 trigeminal nerve is involved. Even though clinically it is possible, I will say that there is no charm in making anterior, middle and posterior syndrome because it doesn't help us to differentiate the etiology. I told you that the most difficult thing is not to diagnose cavernous sinus syndrome but to decide the etiology. So etiologically, this division won't help. Any etiology can happen at any area. But for clinically, we usually ask whether it's an anterior syndrome, middle syndrome, or posterior syndrome. And sometimes what you have to remember is the anterior syndrome may extend to the orbital apex, and it may produce an orbital apex syndrome. The posterior syndrome may extend posteriorly and involve the other cranial nerves also. Now I told you that the etiology is very variable. The neoplastic etiology is the commonest one. Infections are there, inflammatory diseases are there, vascular diseases are there, and traumatic diseases are there. We have no clues by which we will diagnose it easily. If you take the neoplasm, this trigeminal nerve is closely associated with the cavernous sinus, and it usually produces a tumorous growth, schwannomas. Then cavernous hemangioma, because it's a cavernous space where hemangioma are common. Meningioma, because it is a dural one with dura, so meningiomas are common. And you see that metastasis is a common site for metastasis. This lady, he came to us with a cavernous sinus syndrome. I told, it's a mother of a doctor, I told that we are locked because it's not possible to reach a diagnosis initially. So I told them that we will send to neurosurgeon as usual. Neurosurgeon was shying away from taking a biopsy. So I give a course of steroid temporarily but relapse again. Well, I told them that we will go for a PET scan, and this PET scan showed that there is metastasis in the liver, and it was a metastasis. And of course, you should remember that the spread from the nearby structure like nasopharyngeal carcinoma can have paracavernous syndromes, which unless you carefully look down, you may miss that. Now, aneurysms are the most common non-neoplastic lesions of the cavernous sinus. 2 to 9% of all intracranial aneurysms are in the cavernous sinus, and they are usually asymptomatic, symptomatic only when they are large enough, more than 2.5 centimeter. They may be traumatic, infectious in infective endocarditis or idiopathic. You see that this person who has a swelling here, paracavernous, which is diagnosed as possible aneurysm, he presented with ptosis and sixth nerve palsy. Actually, when you see closely, it's not ptosis due to third nerve palsy. Can you say why it is not a ptosis due to third nerve palsy? Sympathetic plexus. This is because you see the lower eyelid. That is the clue. In a ptosis, the position of the lower eyelid will be normal, usually seen equally. But in a sympathetic paralysis, it is not only a ptosis, but the lower eyelid will elevate. Actually, it is a blepharophimosis. The upper eyelid comes down, the lower eyelid goes up, because the role of sympathetic to keep the palpebral fissure wider. And when it is affected, the upper eyelid will come down and the lower eyelid will go up. And this gives the clue that is a sympathetic one. And when you see that there is a sixth nerve involvement plus a sympathetic plexus involvement, consider strongly that something inside the cavernous sinus is in trouble, like the commonest structure being the carotid. Carotid is in trouble. Of course, this sixth nerve plus sympathetic plexus can affected in other sites also, but this is a clue. So this is a person. He visited so many ophthalmologists for conjunctivitis. They gave some ointment, but the person is intelligent enough that he found that there are some blood vessels in the conjunctiva. You see that this one. So in Kerala, veins and nerves are equated. For everything we call Nyaramba. So he felt that these are likely to be Nyaramba. So I have to consult a neurologist. So that is how he came to me. When I saw him, I understood that it is a congested vessel, and I went for a MRI contrast. You see that the ophthalmic vein is very much enlarged. That was the clue. And we did a angiogram. It showed a carotid-cavernous fistula. Carotid-cavernous fistula is not very uncommon. Direct fistulas are type 1, type A, they are direct fistulas. Indirect fistulas, you will see that there are meningeal branches from the carotid, and they will produce the problem. And there are type C and type D when the meningeal vessels are involved. And you see that in a suspected carotid-cavernous fistula, it is usually missed because the cardiologist who carries the steths does not auscultate over the skull, and the neurologist who auscultates over the skull does not carry a steth. That is the problem. What you have to remember is auscultating over the eyeball is a skill. You have to use the diaphragm, keep it gently, ask the patient to close the eyes, gently place the stethoscope over the eyeball and ask the patient to open the other eye. And you can see the bruit. And remember that there are different types. When it is a meningeal type, type C or type D, you may have to auscultate not here but over the temple. So don't finish the auscultation with the eyeball alone, but go for the temple also. And we, as physicians, we always pray that the lesion should be either inflammatory, and which closely mimic infiltrative pathology. The Tolosa-Hunt syndrome, which is our favorite medical condition, we always try steroid because thinking that it's a Tolosa-Hunt syndrome, which is a non-specific inflammation. And sometimes other inflammations like IgG4 can also mimic Tolosa-Hunt syndrome. And one clue in MRI which we look is for the narrowing, focal narrowing of the ICA. I will say that it is almost very specific or common if you see that the internal carotid artery is focally narrowed by the lesion. It is inflammatory disease, especially Stolz-Sagan syndrome. This Stolz-Sagan syndrome is a wide disease. It can involve the orbit, producing a pseudo-tumor orbitae. It can involve the orbital apex, producing orbital apex syndrome. It can involve the superior orbital fissure syndrome, paracavernous area, and it can sometimes invade or spread to the brain areas, middle cranial fossa, mimicking pseudo-tumors, which are excellent responsive to this one. I will say that before you proceeding to surgery or biopsy, it's always better to have a course of steroid empirically to see whether it's Stolz-Sagan syndrome. Now, one clue, this is a proven case of biopsy, proven case of Stolz-Sagan syndrome. You see it is growing to the temporal lobe and it is producing, it presented as a aphasic syndrome to us. And one clue whether it is a Stolz-Sagan syndrome, inflammation, is you look at this pupil. If a paracavernous lesion is there and the third nerve is involved, and if you see that the pupil is spared, you can be fairly confident that this is not a neurosurgical case, this is an inflammatory case, likely Stolz-Sagan syndrome, and you can be confident that steroid, it will be responsive to steroid. So you always look at the pupil, whether it is a pupil sparing lesion. The two conditions where pupil will be spared in third nerve palsy is, one is diabetes, the second one is Stolz-Sagan syndrome. Now, this is another patient, same clinical presentation with third nerve and all. You see the dilated pupil, and subsequent investigation showed that it was an infiltrative lesion in the paracavernous area. So the pupil will help you. Now the another pathology which will affect the cavernous sinus is fungal infections. You all think that fungal infections are common in immunosuppressed patients. It's not true. The mucormycosis, rhinocerebral mucormycosis, which is very common, is usually seen with diabetes and immunocompressed stage. But you see the most common paracavernous fungal infection is aspergillus. This aspergillus, when you see that there is a paracavernous lesion, always look at the sinus nearby. If the sinus are full and the lesion is invading to the paracavernous area through the sinus, eroding the bone, then you can be very confident that it is likely to be a fungal invasion from the sinus, and usually the pathogen is aspergillus. Invasive aspergillosis is a very common. In our area between these blackwaters and river areas, blackwaters and sea area, the humidity is very high and we usually see this sort of fungal infection. Invasive aspergillosis is very common. And the clue is the sinus. And you can have a histopathological diagnosis. If you send to ENT surgeon, they will scoop it, send for culture, send for histopathology, and usually you will see it's a diagnosis. And finally, I will say that the dramatic infection, the dangerous area of this face, bacterial infection, especially by the staphylococcal organism which produce the acute inflammatory problem, bacterial infection, very dangerous one. Thank you.
Thank you, Dr. Jose, for your talk. Small announcement. Please place your 3D goggles on the table for collection. Now I invite Dr. Arun Srivatsava for his talk on cavernous sinus made easy, applied aspect of angles and approaches.
My dear young colleagues, as mentioned in today's oration, if we really don't want to be labeled as an extinct species, as a microneurosurgeon, we are supposed to do two things. The first thing is we have to continuously improving our microneurosurgical techniques, and the second thing is following the magisters and the gurus in given field. So I've been to Professor Ali Crest and I met this guy, Sanford, who published a very beautiful paper, explaining about how to expertise in the field of cavernous sinus through pretemporal transcavernous approach, and he described 4 levels. So I'll start with the level 3 with this index case of basilar top aneurysm done through the transcavernous approach. She was a 60-year-old female presented in a very poor sensorium, and we opted for the surgery, and level 3 because it was a low-lying basilar top aneurysm. We opted the right side, and we proceeded with the right frontotemporal craniotomy with zygoma lowering. We have already published this technique of zygoma lowering, how it gives space. After temporal craniotomy and this flushing the temporal base with the skull base, it's the coagulation and cutting of the middle meningeal artery close to the foramen spinosum. The next step is to perform the posterior orbitotomy. This is the coagulation and cutting of the orbitomeningeal artery, followed by opening of the horizontal segment of the supraorbital fissure. Orbitomeningeal band 7 mm can be coagulated, then cut in the direction of the dural groove. And this is how a dural duplication should be separated between the true cavernous membrane and temporal dura in first half, and the latter half between the temporal dura and the industrial dura. And this is a contribution by Dr. Ali Christ, making this cavernous sinus avascular. So you can see the V3 nerve going through the foramen ovale. You can see the opening of the Meckel's cave. We release CSF through this, and brain become further lax. Now you can see beautifully all the 3 division, V3 going to ovale, GSPN you can see V2 going through rotundum, and V1 going through the lateral wall of the cavernous sinus. Now we are going to perform the extradural anterior clinodectomy. We are deroofing the optic canal, and now we are drilling the optic strut. In that attempt, sphenoid sinus was opened. So after taking out this clinoid, this beautiful Dolenk's triangle has been exposed. Second nerve, third nerve, between that is the clinoidal ICA, beautifully shown by the squeeze, and then this fourth nerve, and then you can see whole anatomy of the lateral wall of the cavernous sinus right from the second nerve to V3 and GSPN. So if you have done this, and you are opening the dura like a terminal craniotomy, you are actually not doing justice with your this exercise. So what it offers opening of the dura at the base, so you are minimizing the retraction and manipulation of the normal brain. You are making all the deep structure very superficial by cutting and tailoring the basal dura cutting. So now we don't cut the dura, we just tailor the dura after discussing with Dr. Ohata, and then this is how the distal dura ring is cut, and then posterior clinodectomy was performed to mobilize the third nerve in the oculomotor triangle. And after that, the surgery was very simple. This whole basilar complex became very, very superficial for us, and the clipping was very simple. The clipping ergonomics was very favorable for us. So with this, ladies and gentlemen, I'll take you to the tour to the cavernous sinus with pathologies. So I'll take you through first, that is the level 1, opening the Dolenk's triangle, and that gives you almost answer to the 60% pathologies of cavernous sinus. So I'll take you through the case of left-sided ophthalmic segment paraclinoid aneurysm. Again, the left-sided craniotomy, frontotemporal with zygoma lowering. This is Oikawa technique to raise the temporalis muscle flap. And then again the craniotomy. After craniotomy, the posterior orbitotomy, just shown in last case. And then after posterior orbitotomy, we are actually going to coagulate and then cut the orbitomeningeal band in the direction of the dural groove. And then tailor dural opening up to the V2 only. In this case, we don't want to peel the dura right up to the GSPN and petrous apex. So here now we are going to perform the extradural clinodectomy. We are deroofing the optic canal, and then optic nerve is nicely seen. After that, we are going to drill the optic strut as shown in last case. And then we have completed the process of extradural craniotomy. So in this case also, the sphenoid sinus was opened, and Dr. Suresh Nair has given a very good wisdom to us, and we are about to publish the utilization of drilling right up to the sphenoid sinus. And in that way, the clinoidal ICA is very nicely exposed for the proximal control in the cases like paraclinoid. So from last 5-6 years, we don't take neck control in paraclinoid aneurysm. We take control here and in the cavernous sinus or in the Glasscock triangle. So this is opening up the proximal dural ring. And then we nicely completed this. This is, we are going to attempt the trial temporary clipping. This is nicely done. Now we are confident that we can take control here. Then other process is similar, like opening the dura at the base, cutting the dural leaf, and cutting the distal dural ring completely, medial as well as lateral, so that you can mobilize this ICA well and you can make it in the one compartment, the clinoidal ICA and supraclinoid ICA. Otherwise, your exercise will be incomplete. So this is the cutting of the optic nerve sheath, because you want to see the ophthalmic artery from where it's arising and what is the relation of this ophthalmic artery with your aneurysm. So this can be very well can be very well done, and you see there is no retractor throughout this procedure. And then distal ICA has been exposed. And we also seen and dissected the A1 for proximal control, and this kind of beautiful, dissection can lead to the good ergonomics, and this aneurysm was successfully clipped. So another advantage of Dolenk's triangle opening gives you the arterial lengthening. Like in this case of left-sided superior hypophyseal artery aneurysm, see this much of arterial lengthening. We got cavernous ICA, we got clinoidal ICA, we got supraclinoid ICA. So you have direct proximal control, and you have all the ease of using, clip. If there is anything goes wrong, you have all the control. So now coming to the oculomotor triangle, part of that is Hakuba's triangle. I already shown with the basilar top aneurysm. Now I'll take you through this case of left-sided, clinoidal meningioma, dropping down in the through the oculomotor triangle in the cavernous sinus. And here we are doing this procedure for all anterior clinoidal meningioma which are fibrous to form. So again the same steps. But what is the advantage of doing this in cases of clinoidal meningioma? You will be having proximal control and proximal dissection of ICA, of optic nerve, as well as third nerve. So you will not be doing anything blindly. You will be having the control of ICA, control of, see, this is the ICA. You are having ICA control from beginning. This is the optic nerve. You are having the control of optic nerve and delineation of optic nerve from beginning. So the very interesting part of this case, this delivering the tumor from this oculomotor triangle, which was going into the cavernous sinus. You can see the sixth nerve nicely draping over the ICA. So this tumor was completely removed, and here we have actually exercised the oculomotor triangle. Now going to the level 2, where you are actually exposing whole lateral wall of the cavernous sinus. I'll take to show you the exposure through the supratrochlear triangle. This case of left-sided IG4 disease turned out as a sarcoidosis, and here we have gone with the left-sided pretemporal transcavernous approach, again coagulation and cutting of the orbitomeningeal band. Then you'll see that the same steps, it's like in our muscle memory, we do it like, and now you can see the Dolenk's triangle, and then in this case, we have actually approached this lesion through the supratrochlear triangle. So it was a granulomatous lesion, and after removal of this lesion, cavernous sinus was bleeding normally, and you can see the cavernous ICA through this. Now, the utilization of infratrochlear triangle through this left-sided cavernous sinus hemangioma, and here actually the same left-sided approach, And then the exposure of the level 3 pretemporal transcavernous exposure was done. And here is the tailor cutting up to V2 only. And then you can see that we were able to see this beautiful lateral wall anatomy. And then we actually approached this cavernous sinus hemangioma through the infratracheal triangle. We were able to approach the meningohypophyseal trunk in the early part of the surgery to make this cavernous sinus hemangioma avascular, and then complete excision was done. This is the fourth nerve and V1 division and ICA. So this was done completely. Now I'll take you through the Mullen's triangle through this petrous chondrosarcoma. And here actually what we have utilized this Mullen's triangle that is between the V1 and V2, and then through that you will see all the anatomy as shown by our colleague. You can see the GSPN through the cavernous sinus, you can see the petrolingual ligament through the cavernous sinus, you can see the sixth nerve draping over the ICA through the cavernous sinus, and then the Gasserian ganglion, and then you can see this beautiful anatomy of Dorello's canal and the sixth nerve traversing through this. And then you can see the posterior clinoid process. You can see the mid-brain. You can go to the mid-pons through this transcavernous approach. And as said, the lesion which are medial to the fifth nerve can be approached through this elegant surgical procedure. So the last case is of level 4. So for that, we selected this case of true cavernous sinus meningioma. And here the patient was having complete ophthalmoplegia. But after the surgery, the third nerve, you can see this is the cisternal third nerve. You can see the third nerve in the cavernous sinus, and this is the whole ICA in the lateral wall of the cavern, inside the cavernous sinus. So this patient shown partial improvement in the third nerve, and complete excision was done. So with this, my dear young colleague, I would like to say that art of microneurosurgery need to be refined a step further. For that, you need cadaveric courses, you need training under able mentor gurus, and you have to gradually translate your surgical practice, proper selection of the cases, and you should be utilizing intraoperative neuromonitoring in each and every cases. Thank you so much for your patient listening.
Thank you, Dr. Srivatsa, for your talk. Next, I would like to invite Dr. Manmohan Singh for his talk on surgery of cavernous sinus hemangioma.
Good evening, everybody. I would like to thank Professor Ghosh and Dr. Anil Pandey for calling me here to present my talk on cavernous sinus hemangiomas. I would like to thank Dr. Arun also to make my life easy and excellent presentation on the cavernous sinus dissection. So I will not waste much time about that anatomy and everything. I will go straight forward for my presentation on the hemangioma. So can I have the pointer, please? Okay. So a little bit of pathology. These tumors rise within the cavernous sinus, and you take its blood supply from the intracavernous carotid arteries. Cranial nerves, as usual, because it's the cavernous sinus tumors, the third, fourth, and fifth cranial nerves are found stretched on the lateral wall of the cavernous sinus and in the overlying dura. And hemangiomas, they can extend. Once the hemangiomas start growing, they take their area of the least resistance. They can extend medially into the sella. And that is the only tumor which rises from the cavernous sinus and goes into the sella. Otherwise, it is the other way around, from the pituitaries coming into the cavernous sinus. And superiorly into the suprasellar lesion, extensively large tumor can grow there, anteriorly into the orbital apex also, and causes a visual decline. As the tumor grows laterally, it dissects between these two layers of the dura and in the lining of the middle fossa floor also. And sometimes it comes underneath that V2 and the V3 division. And once the tumor also starts growing laterally, it picks up the blood supply from the middle meningeal artery and sometimes the accessory middle meningeal artery also. I think in today's time, treatment of the cavernous sinus hemangioma is incomplete if we do not discuss radiosurgery. And I would like to make this statement that surgery for the cavernous hemangioma is practically unusual now, especially for the small tumors, because the gamma knife is the primary treatment option for the small hemangiomas and even up to the moderate size. And the treatment shows a very strong response, and it is outpatient, and the treatment and the long-term results are excellent. And just look at these tumors. This is a cavernous sinus hemangioma extending into the sella also. So this is a radiosurgery, one single shot, and this tumor is practically disappeared. Another tumor, you see that this is a cavernous sinus hemangioma, and this whole tumor has completely disappeared, and excellent extraocular, there is no deficits which the patient has actually suffered, and which is usually unusual in case of surgery, because the patient do develop ophthalmoparesis for some time in the post-operative period. Surgery, it is definitely challenging, and it is not simple, because a thorough knowledge of anatomy of the cavernous sinus is definitely required, and there is a learning curve for that. And it is, today's time, it is only reserved for the large tumors. And small tumors, they are taken care by the radiosurgery. And surgery, as I have discussed, that it is associated with a little bit of morbidity of the cranial nerve dysfunction. And usually it is for some time, and most of the time, if the patients, these cranial nerve palsies, they recover. Technique of cavernous sinus hemangiomas is usually, which I prefer, that patient is supine with the head turned to the contralateral sides, fixed on the Mayfield clamp. Temporal craniotomy is done with the only zygomatic osteotomy. I do not prefer any orbitozygomatic osteotomy, and that is enough for this cavernous sinus dissection. And the temporal bone is drilled till the base, and the superior orbital fissure is also drilled up, and the anterior craniotomy is done. And temporal dura is stripped and retracted, followed by the coagulation and the division of middle meningeal artery. There is always a plane between the tumor and the overlying dura and the cranial nerves. There is always a very good plane. And the tumor is coagulated all around. As you start coagulating a tumor surface, the tumor starts becoming very soft. It is manipulable, and it becomes devascularized, and you can roll it up. And it is not that difficult to shell out the tumor from the cavernous sinus. And this is a video, and this is the drilling over that middle meningeal artery. And it is coagulated and cut. It is cut. And then this stripping of the dura from the cavernous sinus is now begun. This is the V2 area. This is V3. And this is the tumor now is showing up. This is the V2, V3 division, and this is the clinoidal area. So you just go around from anteriorly, then inferiorly, and then posteriorly, just go around this tumor. So it is not one point that you have to go from one side, just attack from all sides. Do not start coagulating immediately. First, define your territories, define the normal structure, so that you do not coagulate any nerve. Because if you coagulate nerve, that ophthalmoparesis is the norm. So this is whole vascular tumor. It is pulsatile. And once you have dissected all around, now you start coagulating this tumor. And this coagulation has to be gentle, not overzealous, lot of saline irrigation. And you have to keep on coagulating, dissect, mobilize the tumor. This is now V2, V3 division. And it is practically coming out from the Parkinson's triangle, practically. This is that superior part, this is the inferior part, anterior and posterior. Lot of irrigation. And this is that ophthalmic division is there, which is going into the superior orbital fissure. It is dissected. This is the anterior part, and this is the area of the anterior cleanout process. So you have to make sure that you are, this is third nerve now. You see that this is a third nerve, very gentle dissection. This third nerve and maybe associated fourth. Fourth isolated could not be identified. Probably it is a part of this whole complex. So once put a little bit of gel foam or a cotton, very small cotton, so that thermal coagulation does not is transferred onto the third nerve. And then coagulation. This is the posterior part. You can say that this may be, this is the dura. Now you are going posteriorly. So again, coming to the inferior part, this is that V2, V3, V1 division. This is the temporal base. Now we have gone to the back. So probably I have not shown here. ICA I could identify somewhat here, coming out from the foramen of Lastrum. Now this is the medial part again. This is the third nerve stretched over the tumor. Now coming down over the third nerve, this is anterior. This is ICA. This is ICA. And there was a lot of bleeding here. And this tumor was actually going into that sella also. Now this pulsatility of tumor is gone. Now, and this is a too big tumor to be rolled out because it is extending into the sella. So now I am dividing the tumor inside and coring out with the help of a CUSA. Now see that it is practically is not bleeding at all. There is hardly any bleeding now. So it is nearly avascular. So now it is easy to roll up. So once if you start doing from the beginning that this bleeding is torrential, it is extremely difficult to control then. So now we is going into, this is the third nerve. Very gentle dissection, no hurry. So this is now we entering into that sellar part. This is the sella. So this is rolling out from the intracellular part. So this tumor is now completely dissected off. This tumor is out. Now the hemostasis is secured now. So this is the preoperative patient. This is a preoperative scan. You see that this is axial section entering, almost touching the opposite ICA. And this is the coronal section. You see that the size of this tumor is too big. And this is the postoperative image. This that cellar part is also gone. This is the coronal section. This is the axial section. And this is the postoperative 2 months later. So this is the done 2 months back only. So you see that there is a little bit of ptosis there, but the patient has now full range of movement. So I hope that in a couple of months this will disappear. So now this is again a case which is very unusual, that this ICA was encased by this whole tumor, this cavernous sinus hemangioma, completely encased, it is inside the tumor. Usually it is not the norm, it is always pushed to one side. So this was the surgery, same situation, the same technique, and peeling off, coagulation of the dura, then coagulation of the tumor. So in this case, it was very important to identify that proximal and distal part of that internal carotid artery, so that I can know that where I am exactly, so that I am not going to injure. So this was one of the most challenging case probably for the cavernous sinus I have ever operated. So this whole tumor is mobilized, lot of vascularity, and this tumor is practically now not now very turgid. It is now yielding very well because it is devascularized very nicely. Sorry. Just a minute more. So, sorry again, it is moving. Okay. So this is, I am cutting the tumor because it was not coming off the ICA. ICA is here, this is ICA. Once I just cut this tumor, there was a bleeder. I thought I have cut the ICA, but probably this was that inferior lateral of the meningohypophyseal trunk. It was there. I just caught hold of with that aneurysm clip, and I continued my dissection. It was very difficult dissection from the ICA. It completely encased, and adventitia was stuck to it. And this tumor was dissected off, and then I saw that there was only small branch holes. And I did a cross clamping, and these branch holes were then repaired with the help of 6-O-proline. So it's done completely. So in my All India Institute of Medical Sciences experience, in the microsurgical group in the last 15 years, we did a large hemangiomas, 13, gross total 12. One patient intracellular portion could not be removed because a lot of bleeding was there, and subsequently that required gamma knife, and the visual improvement occurred in all patients. So this is the gamma knife group, 9 patients, and median dose was around 16.8 gray, and tumor volume was 6.3. It means that this is not a very big tumor, and 7 patients had significant tumor shrinkage and more than 75%. So this is a very good way of treating cavernous sinus hemangioma. If they are small, no need to go ahead with the surgical resection. So to conclude that gamma knife radiosurgery is the treatment of choice for the small to medium-sized tumor, though the surgery is challenging, but it is not difficult to master, and the total excision should be the norm and possible without any significant morbidity. Thank you.
Thank you, Dr. Singh, for your talk. I would like to invite Dr. Ayadurai for his talk on endoscopic excision of pituitary adenoma involving cavernous sinus.
Very good evening to all. If I have to be considered as a tree to become a senior consultant neurosurgeon at one of the top hospitals, it has to start as a seed. I was a seed, and then the water was put by Dr. Siddharth Ghosh. Like, without that, I would not have become like this. Thanks for that, sir, and thanks for the opportunity too. I would like to congratulate Sukhdeep also. Is Sukhdeep there? Okay. So his anatomy videos were fantastic, and it was on par with the 3D anatomies which are shown in Stanford and Pittsburgh. So the anatomy has been extensively described. We have seen beautiful dissections shown by Dr. Arun and Manmohan Singh sir. So the concept is like laterally when we come through, even in the anatomy also he has shown all the triangles are embedded with the nerves and the artery. Except the ICA and the 6 nerve, rest of the nerves are lying in the lateral wall of the cavernous sinus. So when we come from the lateral aspect, we have to go through, identify these triangles and then go through them or go in between them. When we see the picture on the right side, we see this is a sphenoid bone. When we drill this sphenoid bone, we have nothing on the medial aspect and the anterior wall of the cavernous sinus also. So this gives a lot of space, and then early identification of the neurovascular structure, and medially located, medial to the lateral wall of the cavernous sinus lesions are very well addressed in this. So a little bit of the anatomy, though he had told, I'll just tell it briefly. The meningeal dura and then periosteal dura, the meningeal dura continues, or the superficial dura continues as the anterior wall of the cavernous sinus, like it is shown here, and the periosteal dura, it hugs to the pituitary gland and forms a medial wall of the cavernous sinus. So it has several ligaments which originates from the medial wall of the cavernous sinus and goes and attaches to the ICA and to the clinoid. One of the prominent ligaments are the carotidoclinoid ligament. They arise from the various segments of the medial wall of the cavernous sinus. They are attached to the genu of the ICA, anterior genu of the ICA, and then they go and join the interclinoid ligament. That forms a very big band, and then this is the most prominent ligament which you always notice during the surgery. And these are the ligaments which are shown here. This is a demonstration of the various ligaments, carotidoclinoid ligament, and interclinoid ligament. We see the middle clinoid portion here, and then just below that is the proximal dural ring. So understanding the compartments are also very important. Actually, it was all started by Juan Carlos Miranda, who is in Stanford now. He is the one who described about the anatomy, endoscopic anatomy of the cavernous sinus, and then he is the one who described these compartments too. The superior compartment, it lies just above the level of the cavernous segment of the ICA, and then lies posterior to the superior to the anterior genu. So the most important structure which has to be taken care is the oculomotor triangle. Dr. Suktdeep also showed that where it enters into the oculomotor trigon, where exactly it becomes an interdural component. That's what we have to expect in the superior compartment. The posterior compartment, it has got several structures. It lies behind the short vertical segment of the ICA, the meningohypophyseal trunk, the inferior hypophyseal travels from lateral to the medial to the sella, and the dorsal meningeal artery that travels to the dorsum sellae, and also the interdural compartment of the portion of the 6 now, which is seen here. This is where it enters into the Dorales canal. We would find out the Gruber's ligament here, and it lies here. Sometimes all the 3 branches may arrange from the meningohypophyseal trunk, or it may arrange as different branches, or it may arise as different branches too. One more thing is both the superior petrosal sinus and the inferior petrosal sinus come and converge at this level where the 6 now enters in. So during the surgery we would expect more bleeding there, and then that's area 1 where we would probably put the flowable coagulants there to take control of the bleeding. Inferior compartment, that has got the distal cavernous segment of the 6 nerve there, and the sympathetic plexus of the carotid artery also travels along with them. So laterally, majority of the vessels lie in the laterally, but then lateral to the cavernous ICA, the anterior genu lies the lateral compartment. So that has got the inferior lateral trunk that lies inferiorly. Superiorly, only the distal component of the cranial nerve 6 we have where it enters into the cavernous sinus. Goes into the superior ophthalmic fissure. And laterally we have the lateral wall of the cavernous sinus and the rest of the 3 structures there. So these are the steps where we how we excise the medial wall of the cavernous to have an access into the medial wall of into the cavernous sinus. Always the inferolateral compartment has got a bag of blood, or that's where the superficial petrosal sinus, where the inferior petrosal sinus comes and attaches. The interdural gap is more, and then we would be able to gain access easily, and that's where we would expect the inferior hypophyseal artery too. So once if we take care of the inferior hypophyseal artery, we are sure that next ligaments we have to progressively cut one after the other. Very rarely when we go into the posterior compartment, then we see the rest of the vessels. When we are remaining, or when we are excising only the medial wall of the cavernous sinus, if we take care of the inferior hypophyseal artery, that is sufficient, and the rest of the things are ligaments. And the second cut comes the inferior medial. The third cut comes this is the lateral medial aspect of the proximal dural ring. So this is a little bit about the approach. Actually, when we have such a nice lateral recess, we may not have to go do one transpterygoid approach. But in such cases, where we don't have too much access, this much of bone is there into our access, we will have to do the transpterygoid approach. We will have to drill the base of the pterygoid to gain access into the full anterior aspect of the cavernous sinus. This is how this is the video now which directs us to the foramen lacerum. This is the paraclavial ICA. Just above that, the whole area we might have to expose, if you have to have an access into the lateral wall of the lateral compartment of the cavernous sinus and the posterior compartment of the cavernous sinus. One of the case examples, acromegaly, middle-aged person. This tumor, it is going into the lateral compartment, posterior compartment, and the inferior compartment. We went ahead and then did an endonasal approach, like a bony exposure is all, like this did not require an transregard approach. It had a good lateral recess. Expose the whole of the anterior wall of the cavernous sinus until the V2 is identified. The importance of navigation and the intraoperative Doppler is mandatory here. So we identify these kind of the ligaments there, like if we full of the anterior wall is opened until the ICA. If you have to just confine only to the excision of the medial wall, those are the ligaments. But sometimes like we may have confusion like whether it is a ligament or cautery, so we don't have to worry about cauterizing them. So cauterize, cut, and then make sure that like we are not avulsing onto the inferior hypophyseal artery. Here we are going into the posterior compartment. As we reach the posterior and the inferior compartment, we face copious amount of bleeding. That's where like the help of the flow seal or the Surgiflow, the flowable coagulants are very useful. So as we keep progressing, like one after the other ligaments, like when we keep continuing to cut, the medial wall gets relieved from its attachment to the clinoid and to the ICA, and then towards the end, like the last cut is made towards the proximal dural ring, where when we make the cut, that shows the conversion of the cavernous ICA into the clinoidal ICA, and also like we see the cisternal segment of the ICA. So we are finishing the last cut there, like that's a incision of the proximal dural ring that we can see the optic nerve there. This is the adenoma excised along with the medial wall and the gland. So the patient had a good remission. So this is a preoperative and then postoperative scans. This is the medial wall of the histopathology also showed the invasion of the tumor cells. Same when Miranda, like he looked into the medial wall of excision, like he had done about 50 patients, and among the 50 patients, he was found the medial wall invasion in 43 patients, irrespective of whether it is functional or non-functional. This is a meningioma, like which was the retro-sigmoid approach was done for the posterior compartment, and then like she came back with a recurrence when she was progression. So we are seeing like the meningioma is occupying all the compartments here. So here we are able to get into this is the pituitary gland here, and then like the tumor was very soft suckable, that was fortunate to us. We continue progressing, and then like the whole of the medial wall does not or all the ligaments does not get destroyed. Like we still have to remove the tumor, identify the ligaments like which is tethered to the ICA or to the medial wall, the lateral wall. That's the inferior hypophyseal trunk which is arising from the ICA, and then like that's cauterized and then cut. So towards the end, like this is what the picture will see. Like the whole of the cavernous sinus segment is visible there. Like short cervical, short vertical, posterior genu, anterior genu, and the clinoidal segment. It's a post-op scan, small residue. So average about 500 ml, 500 to 750 ml of blood loss was seen. Like it's a bloody surgery, but then we'll have to learn to operate within the surgery. We had very good remission with most of the functional adenoma, and there were transient abduction paralysis in 5 patients. Oculomotor patients paralysis were in 3 patients, which were all improved. So to conclude, it's a paradigm shift. Understanding the endoscopic anatomy of the cavernous sinus is a paradigm shift in managing cavernous sinus lesions. It gives excellent outcome in functional adenomas. Very good anatomical understanding or training is mandatory. Like Dr. Arun said, like we'll have to keep undergo training, cadaveric workshops, try to understand the intricacies of the approaches, and it's teamwork. We have to have a good ENT surgeon, endovascular surgeon. I would always want to have as a backup, like in case of any ICA injury there, because we are handling with the ICA, good endocrinologist, and then good anesthesia to back you up also. So this approach has to be an armamentarium for any skull-based surgeon. Thank you.
Thank you, Dr. Ayadurai, for your talk. For the last talk of the session, I would like to invite Dr. Sumit Sinha for his talk on keyhole surgery for medial sphenoid wing meningioma.
Can you please dim that light? This one? No? Okay. Well, it's 7:30 and still the hall is full. So I will not keep you long from between your gala dinner and these deliberations. I mean, whole day it's been a wonderful academic feast, and thank you, Dr. Ghosh, for this wonderful opportunity that I'm able to present my little work, whatever, in front of this august audience. So the keyhole surgery, the topic I've been assigned in this 10 minutes or so. This is what I'll be talking about mostly to the younger generation sitting out there for the keyhole surgery. To start with my gurus, these are all people, some of them whom because of whom I am what I am actually. So thank you so much, and we look up to you, we learn from you, and try to imbibe your qualities whatsoever little way we can, and lots of gratitude for you for this. Thank you so much. I have no financial disclosures, and the photos and videos, of course, with the permission of the patients. So talking about the keyhole, well, the keyhole is not about the size. First of all, let me confess about it. It is about a philosophy. It is not a 1 centimeter or 1.5 centimeter or 2 centimeter craniotomy that I am talking about right now. It is the most comfortable minimum skull opening that you can make and take out the tumor tissue without disturbing or without producing any neurological deficit, number one. And number two, by taking out the tumor or the lesion completely. So this is what the keyhole concept is. This is an epitome of ultramicro neurosurgery, which a youngster should always learn. And these are some of the things which, some of the principles of the keyhole concept, which I would like to enumerate in this presentation. Now, this is in reverse funnel-shaped view that you get in a keyhole. As you get closer to the keyhole, the structures which are located deeper to the keyhole, they are in the wider field of vision, and you can see through them easily. The thing which you have to learn is to manipulate the instruments through this small opening, and do not have to cross-sort these instruments. And this is what you can learn through various cadaveric exercises and the meetings, to attend meetings like this and view the videos of other people doing this. So these are the principles. I already told this is an inverted funnel vision. Now this keyhole is an immobile keyhole. So once made, you can't, you cannot move it in the skull. So it has to be very, very precisely, accurately placed. And needless to say that this needs navigation, image guidance is a mandatory thing that you should have. And generally this keyhole is placed along the long axis of the tumor where it intersects with the skull. So this is the best location of any of the keyholes when you want to take a deeper tumor from the depths, actually. So howsoever the viewing trajectory is mobile, you can look from this angle, you can look from this angle, and not only this, you can take your endoscope inside during and after the surgeries to see for the completeness of the tumor excision. However, there are certain disadvantages also, because you cannot look at the back of the door, and therefore the superficially placed lesions, they are not ideal things to for this keyhole surgery. If a tumor is a convexity meningioma, the keyhole surgery is futile. I mean, you have to make opening as big as the tumor tissue. Like the trajectory I was talking about is the long axis of the tumor. Now this thalamic glioma, which I did some time back, the long axis of the tumor tissue, the keyhole was placed along this red arrow, and this is the complete tumor excision that was achieved. So this is the minimum craniotomy, as I already stressed upon, required to access the deep intracranial pathology. This is the concept. The conventional craniotomy is very, very large, and this is the exposure of the brain tissue for several hours makes it vulnerable to injury. However, a small opening, only somewhere around 3 to 4 centimeters square of exposure of the brain tissue does not produce any damage or a thermal damage because of the light of the microscope. You need a neuronav. It is an essential requirement for making a keyhole surgery. Endoscope is a beautiful tool which you can use during and after your
surgical procedures. Not only this, you can look through the angled endoscopes into the nooks and corners to remove the residual tumor tissue. So coming towards the keyhole approaches, I would be specifically sticking to the keyhole approaches in this for the need of the time, and specifically to medial sphenoid wing meningioma. So I will be showing you one video if time permits, and this is a mini terminal craniotomy, and why it is coming again. So this is one such tumor which was dealt with keyhole terminal craniotomy, and this was a 40-year-old female with complaints of mild to moderate headaches, visual deterioration for the last 6 months, on the right side more, and left side weakness was there. And this was a lesion which was sitting on the sphenoid wing on the medial side, and this was slightly on the sagittal scans and the coronal scans. This was there, and for these lesions, I mandatorily do MR angiography for looking the configuration of the ACA, and of course they are displaced, and very rarely they are encased by the angiomas, unless until it is some other pathology. So position in the keyhole surgery is it matters, and it's fine with the head turned 30 to 40 degree to the left side and the neck extended, so that you take the advantage of the gravity. Incision was a 4 centimeter skin curvilinear incision with tear at the midpoint. So this was it after fashioning a craniotomy of about 3 by 4 centimeter size. So this was it. Let me orient you along this. Can I have a pointer, please? So this up was the base, and this is the anterior and this is the posterior. Sorry, this is the cranial side, this is the caudal side. Thank you. This is the caudal side, this is the cranial side, this is the base, towards the base. So once you've made a craniotomy, then I make a little cheating, because I do bevel this, sorry. I do make a beveling of this base, because it increases. The more you bevel it, the more it increases your visual angle by 20 to 30 degree, which helps you in visualizing the attachment of the tumor tissue to the sphenoid wing. So once you do this, the bony work is complete, and this is the only bony work which you require to do in these cases, as I will show you during my surgery. And then the most important step is the opening of the dura. So dura in keyhole is not opened in a conventional manner. As you see that, I always open it along the sylvian fissure, and only that amount of dura which might overlie the tumor tissue. Because if you open it in a conventional manner, the brain will come out, and then the life will become messy. Always remember, the meningioma surgery is an intra-arachnoidal surgery, so it is the arachnoid planes that you have to open once you enter into the dura, and drain the CSF whatsoever you can do. Wait for some time and be patient, and then the brain relaxes, and then you are directly on the tumor tissue, as you are seeing there. Peeling the arachnoid over the tumor tissue is the sine qua non of this surgery, and you have to really respect and take care of this arachnoid while dealing with the meningiomas per se. So once you have peeled the arachnoid back, you coagulate the tumor tissue, and then all the veins, even you have to take care of these veins. Sylvian veins are very important veins. If you have coagulated that by somehow, then may end up with disastrous complications. Venous infarct later on, patient may not wake up with in good circumstances. And all the important neurovascular structures have to be preserved, needless to say. Decompression, devascularization, and dissection. These are the 3 Ds of, like any other meningioma surgery. And once it becomes manageable because of decompression, then you can roll the tumor tissue. Until then, you have to decompress the tumor tissue and make it small. Take the biopsy, and then use the image guidance to localize the ICA, because you may not end up with surprises by injuring this ICA anytime. And I'm doing the decompression side by side, the devascularization of the tumor tissue from the temporal skull base also, as you see there. This helps us in reducing the vascularity of the tumor, and again devascularizing, localizing, using ultrasound also. It helps in quite a bit handy in localizing the ICA, and so that you have a 3D picture of that ICA in your mind while you remove the tumor tissue. Making it further small, and then dissecting the tumor tissue from the olfactory nerve there, from the base of the frontal lobe, again using ICA. So now the tumor has been quite, manipulating, and it becomes handy so that you can roll out the tumor tissue. Now comes visualization of the ACAs, A1, the separation of the tumor tissue from these vessels. It's quite, you have to be very, very patient. And most of them, they have a sleeve of arachnoid around these vessels, and you can utilize this sleeve very, very well, taking care with sharp dissection, removing the tumor in bits, and so this is the right ICA bifurcation, and developing a plane with a flat dissector. This is a very good instrument, lifting the tumor tissue from the vessels, and then you're working on the lateral side of the ICA, cutting the tentorial attachment of the tumor from here. All this is through the keyhole. I mean, there is no dearth of space, as you can see, anytime during the tumor resection. Take care of the perforators, and only in the sharp dissection the tumor tissue from the basilar artery and the perforators. There you see that. Very precious perforators, to take care of them at any cost. There's a third nerve there, and the basilar artery, PCOM, right ICA, everything is coming out, opening itself in the form of a book, clearly, patiently, rolling out the tumor tissue, no pulling, always a sharp dissection whenever required, gently coagulating the things, not pulling around anywhere. And one more minute. And whenever you feel that have to decompress the tumor, decompress it more. Rolling out the tumor tissue again from the lentix, and dissecting the tumor from the middle cerebral artery. So that's So that's the ICA, ACA, MCA, skeletonized, some bit of the tumor tissue attached to the ICA bifurcation. Now the time for the tumor under the optic nerve to be decompressed, because this is the most crucial part. Patient will not improve in vision unless until this has been decompressed. So you may choose to cut the falciform ligament as well, and which is quite required, because once you cut the falciform ligament, the optic nerve gains mobility, and it is easier for you to dissect the tumor and remove the tumor tissue after that. Dissection of the tumor from the right A1. So as I said, there is a cuff of arachnoid around the artery most of the times, and you can utilize this slowly and gently lifting the tumor tissue from the vessels. Sharp dissection, decompression again. And this is the tumor which is being rolled over from the optic nerve completely decompressed now, and this bit of tumor tissue is being removed from this. Now optic nerve decompressed. I would like to leave this small bit of tumor tissue over the ICA rather than pulling it out and landing up in an injury to the ICA. And this is what my complete surgery is for this meningioma. So this is how we accomplish this, and then routine dural closure and all. And this is another patient. You see the left side meningioma. This is the post-op CT scan, and this is what patient's incision looks like after 2 months of surgery. So this is keyhole neurosurgery is absolutely safe, and this is maximally curative and minimally invasive. This is a learning curve is required for the youngsters to attend these cadaveric workshops and meetings like this, watch videos before the surgeries again and again, and so that you can do it. Thank you so much.
Thank you, Dr. Sinha, for your talk. Now I would like to invite the moderator of the session, Dr. L.N. Tripathi, to share his insights.
Good evening, friends. Thank you, Dr. Ghosh, Dr. Pandey, for inviting us. What a session. Cavernous sinus, and if we do not mention the master, one of the masters, can I request everyone to please stand up for 30 seconds for Professor Vinkodolens, who passed away on 15th of January, 2025. Just 30 seconds. Thank you. We had a wonderful start to the session with Dr. Sukhdeep, and of course the duo, our Rotan duo, Dr. Sukhdeep and Avida. I would request them to please also record it and put it on the I don't know, YouTube or somewhere. And can you actually modify it a little bit like Professor Rotan when he used to show it, every part would light up, rather than showing you the laser pointer. It would just light up. Whatever he said, it would light up. Many of us had the opportunity, I'm sure the masters sitting in the hall had direct contact with Professor Rotan, but we had some association as well. So that was wonderful anatomy, as I think, there is no comment about it, no other comment about it. Dr. Jose, thank you very much, Dr. Jose, for being with us. And this meeting, Dr. Ghosh, I appreciate that, neurologists, neuroradiologists, of course, Dr. Lima is here, and pathologist and anesthetist, intraoperative monitoring, all the aspects of neurosurgery have been taken care of. And he really mentioned about the Tolosa-Hunt, the orbital apex syndrome, pseudotumor, which really, sometimes confuses neurosurgeon. Of course, the third nerve, the sixth nerve, complete cavernous sinus thrombosis, infective thrombosis, CCF. He showed beautifully the syndrome related to the cavernous sinus. And Arun made it look so easy. The trans-cavernous approaches, the 4 levels of approach, was very wonderful, as elegant as ever. Whenever I watch you doing that particular approach, I really get absolutely overwhelmed. Thank you, Arun, for showing that approach. And of course, Manmohan showed beautifully the hemangiomas of the cavernous sinus. Now, our approach to the cavernous sinus, especially doing a pituitary or doing a meningioma or one of those rare tumors like hemangioma, is to stay away from it. But especially, I think, with Alicrist and others showing, infuse the Flosil or Tisil into it, the bleeding stops. And like in the morning, Dr. Mishra was showing about the sinus bleeding, putting gel foam and just putting pressure and maybe Tisil. So these are the small but very important techniques that we learn, improving our strategy for this kind of difficult tumors and difficult pathologies. And of course, Dr. Ayadurai really mentioned about especially functional pituitary tumors, especially for our residents and trainees. Functional pituitary tumors, people have gone lateral to the cavernous sinus, lateral to the carotid, and removed the last bit of tumor, especially in Cushing's and acromegalics especially. That was very interesting approach. Of course, endoscopic approach to pituitaries has been well accepted as a mainstay approach for the tumors. And of course, Sumit, as elegant as ever, a minimal invasive approach, and of course the minimal craniotomy required for this kind of pathologies to deal with in the cavernous sinus. So anybody has any comments? I would approach Dr. Misra, please. Have a microphone to Dr. Misra, please. Give a working microphone. Thank you.
Yeah, thank you. I mean, it's such a pleasure, such a great pleasure to hear these talks. 30 years back, 1991, I just checked with Suresh because he remembers also the dates of NSI in 91. I presented petroclival meningioma and 11 cases, I still remember. And after my talk, Professor Sambasivan got up and asked me, are you taking the patient out of the tumor or the tumor out of the patient? I was very, very upset, of course. So I realized the point he was making, and that was very relevant. I really understood that because when you are working in a public sector hospital, there is little bit of, there is little bit of protection. You get away with morbidity, which is unfortunately when you get out on the public to private sector, it's very unforgiving. But the surgeries which I saw today, I mean, remarkable. You are really taking out the tumor from the brain, and not the patient from the tumor. So I'm so proud that we are still not dinosaurs, and the next generation has really taken this forward to the next level. Thank you very much. It's a pleasure to be here.
Thank you. Thank you. And that you were mentioning, Dr. Misra, was in Manipal, wasn't it? Yeah. Thank you. Anybody comments? Suresh, Professor Suresh Nair? Yeah, we have a microphone. And Dr. Goel.
It's a super session. Especially I'm so thrilled, what I am today, and everybody. And Sumit, he showed keyhole, unbelievable surgery and all. They unnecessarily showed my photograph. It should not have been there. But I was happy for that. But what a great session. Great session.
Thank you.
Arun, great.
Thank you very much. Atul, Professor Atul, go ahead.
No, I missed a couple of initial lectures. I missed because of some special engagements, but I'm sure I've seen Arun's presentation earlier. I've seen all these presentations earlier, and there's no question that things are moving, and things are moving fast and rapid and smooth. And I'm sure we have a beautiful, wonderful future ahead of us. What is more important is to understand the tumor, understand the membranes, understand how to remove the tumor, and how to be safe. Safety is first, resection comes later. This is the principle that I thought that I have earned and learned over the period.
Thank you. I just have one question to the surgeons. When you are operating on this kind of tumors, you have ICA and all, maybe involving all the other arteries branches. Do you use an intraoperative ultrasound or intraoperative angiogram? Once you expose the artery, of course, you may not need it, but I'm just wondering whether you do. Like intraoperative monitoring. Arun? Yeah. Give a microphone, please. Yeah, I thought so. That's why I'm asking you.
So these two things really helps us, and obviously the sacrosanct is the understanding the distorted anatomy. So that is very important.
Anytime you thought about doing a bypass just in anticipation?
No,
very difficult tumors like meningiomas.
We have few cases where we have done bypass and then we have done the complete job. So we have not mentioned that even Glasgow triangle control and doing some cases by taking control in Glasgow triangle, we have done few cases.
Thank you.
So that is how we are going into that.
Thank you.
I don't want to spoil the fun, but just for the young neurosurgeons out there, I mean, these are very difficult surgeries, which we saw today. These are highly, morbid surgeries. So please go to the lab, train under the mentors before you do it, because the damaging the patient is not uncommon. Please understand. And what Dr. Sambai Simon told me, that I still remember, I mean, getting a good scan doesn't help anybody, neither the patient nor and you can say lie to others, but you can't lie to yourself. So be true to yourself. Another cautionary note, in spite of the fact that we see beautiful surgeries, these tumors are to be followed of life, and they come back, unfortunately, meningiomas. And we have enough data, people, 80s or early 80s, late 80s and early 90s was the golden era of skull-based surgery. People used to, what do you ask? That's why I'm asking the bypass, taking off the bypass, taking off the carotid for meningioma. Nobody does that anymore. Unless until, of course, somebody has failed microsurgery, failed radiosurgery, come back, or a malignant tumor. Then only the taking out the bypass, taking out the carotid is probably acceptable. But otherwise, taking out the carotid to achieve a complete excision is not on. You cannot achieve that, because pathologically they've shown it, the tumor goes to all under the places, the dura, the bone, the adventitia. So I think be careful about what you're showing, and before you start doing what these gentlemen, ladies showed, please go back to the lab and learn from your masters before doing that.
Thank you.
Just a cautionary note, I don't want to spoil the fun.
Thank you. I think last comment from Dr. Turel, he was there before.
Sir, for endoscopic
could you
approach...
just take Dr. Turel,
okay.
and then you can.
Right, sir.
That was the last one. Thank you.
This Dr. Ghosh, this conference has been extremely well designed. And I must say that this was a great thought, because you started with the basics of anatomy, which was so brilliantly shown all along, at all levels. All parts of the brain were shown beautifully. And I think no words can explain the hard work that these two young people have put in, Abida and Sukhdeep.
Yeah.
So that has formed the basis of
give them a standing ovation too.
Of all the papers. And yeah, I think what we have learned today is microsurgery forms the basis of everything. So even if you're doing endoscopic surgery, your basic training in microsurgery stands in good stead all your life. So get good microsurgical techniques, whether you have a little larger craniotomy or smaller, does not really matter. What matters is how well you have handled the main tissues. And as far as possible, do not handle the normal structures, just handle the disease. This is what we have seen. And just for the sake of repetition, I think whatever we have seen today is world class. And that is because people have trained. So training, cadaver dissection, anatomy understanding is so important. I don't think anybody is allowed to enter the theater unless one has done this. So no amount of workshops that you see that are being done are going to satisfactorily cover this deficit of your lack of training. So you have to go to the cadaver lab wherever they are available. And I believe you have a wonderful lab. So there are once. Yeah, there are plenty. Well, if they are not there, then you must make them. So cadavers, there is no shortage of cadavers. People are saying today that we are doing simulation. You'll get your turn to talk.
Sorry, Dr. Ture, I think we have to stop the session. Time is up.
No, but I have to make. I made my point.
You made your point. Yeah.
Let me just conclude.
Thank you, sir. Thank you very much, Dr. Haidura. I think we can discuss later on since the time is up. Thank you very much. Thank you.
Thank you, Dr. Tripathi. We have successfully completed the second day of the Dundee educational course. Thank you all for your patience and undivided attention. I request all to stay back for the photo session and the gala dinner.
some cultural program? Yeah, there is. So announce the timing. Cultural program कहाँ पे है? यहीं पे है. Dinner भी यहाँ